Good morning, Mrinal. Good morning, Rajiv.
Hi, good morning. How are you?
All well, all well. The organizers has called me that Rajiv sir phone नहीं उठा रहे. बोला Rajiv sir join हो जाएंगे.
I had a talk with him at 8:45.
Okay, no problem.
Good morning everyone.
Hi, how are you?
Good morning, Dr. Manti, Dr. Rajiv. I'm fine.
In fact, today I have ensured that I am at home for this meeting because at Mulchan, the signal is very poor.
Okay. So I am in the hospital. So I couldn't join because I thought I will be giving lecture yesterday, but then due to some changes, I had commitments here at work. So
okay.
That's why I'm still in Delhi.
Achha. Good that we'll be hearing you today.
Yeah.
Yes, sure. How are the cases in Bombay? Are they rising, Dr. Manti?
Yeah, there are rising.
COVID and all.
Now every day there are more than 1,000 cases for the last couple of days. It has reduced like anything, 300, 400. Now it is rising. Actually, it is more in interior.
I think Delhi
rather than in Mumbai. Maharashtra, Vidarbha region, those yes, Amravati, those are the horrible. Maharashtra now almost more than 10,000 today. 10,000, 11,000 like that.
So that's a real lot.
Delhi, I think it's quite quiescent right now. There are not many cases.
Yeah.
Well, you never know what will happen very soon.
Yeah, I think it's waxing and waning. They keep coming back. I don't know when it will end.
Dr. Ashish, you are ready?
I am ready. Just asking them to upload my PPT.
Yeah. I'll just.
Can you please upload my PPT, please?
I'll give the.
It's already uploaded in the mainframe.
Dr. Ashish, I'll give
Good
the.
Morning, everybody. I see my friend Dr. Mrinal Sharma, Dr. Rajiv Sharma.
Hi, Ashish.
Monty said, regards from wishes from Jaipur, and actually missing you all.
Dr. Ashish.
So should I start?
No. Dr. Ashish, just let me give some introduction, then we will start. Okay.
Just a minute. Actually, I've already uploaded in the mainframe. They'll just put it on the main screen. Yeah. Oh, okay.
Who is from the organizer side is there? Dr. Arun is there?
Will it talk? Okay. I'm ready, sir, from this end.
Dr. Arun is there? Somebody has to start there, no?
Maybe, Monty, you can start introduction.
Okay. Dr. Ashish, you are able to hear us? You are able to hear me?
Okay.
Yeah. So, very good morning, dear friends. We are going to start the arthroplasty session today. Yesterday, we had a beautiful session of Indian Arthroplasty Association, subspecialty of Indian Orthopaedic Association. As I told yesterday also that we are completed 25 years, and last year we celebrated the Silver Jubilee year for Indian Arthroplasty Association. And we are conducting webinars every month now to upkeep the academics going. And we are really grateful to the President of Indian Orthopaedic Association, Dr. R.C. Meena, and the scientific coordinator, Dr. Arun Sharma, from Indian Orthopaedic Association Conference IOACON at Jaipur, and for giving us an opportunity to have an arthroplasty session. Yesterday we had a beautiful session. Now today we'll continue with the session. Today we have an excellent panel of speakers, and we are focusing on some important topics pertaining to Indian situation, like some new concept like robotics in the arthroplasty, which has just the new baby in the armamentarium, followed by periprosthetic fractures, which is increasing in incidence in our country. Use of metaphyseal sleeves, this is in revision situations that how to address the bone defects. Then in certain severe deformities, which we commonly see in our country, people abroad, they don't see this kind of deformity, that how to handle that. Then primary THR, which stem to choose, that how there are plethora of stems available, how to choose the perfect stem for a perfect femur. And next we come to megatumor prosthesis when there are extensive bone loss or osteolysis, then how to address that. These are the new things which one must learn when doing arthroplasty. And last but not the least, our guest speaker from United Kingdom, the President-elect of British Indian Orthopaedic Association, Dr. Amit Tolat, he will be joining and talking about reverse shoulder arthroplasty, which is a hot cake now. Now, how to get it right. So we'll have a very good session today. With me, we have our President-elect of Indian Orthoplasty Association, Dr. Rajiv Sharma. We thank him for joining us today. And without much ado, let us go ahead with the session. And may I request Dr. Rajiv Sharma give the introductory remarks and invite the first speakers for this session.
Thank you, Mohanty. It's wonderful to meet again though virtually, and we have been missing our physical meetings, but I think that we'll try to continue the academic events and ensure that the dialogue, the interaction continues. Today's program, as Dr. Mohanty has explained, is a very, very well thought program with very special topics which will be of interest for all. I think that the robotic is a new interest, with Dr. Ashish will be speaking from Patna. Ashish, I'll invite you to speak on the first talk of the session today on robotics in joint replacement.
Thank you, sir. Thank you. And I'm very thankful to be here and team IOACON, mini IOACON Jaipur. So I would be speaking on robotics in arthroplasty. So basically, what we aim in arthroplasty is accuracy, confidence, and reproducibility, and of course, flexibility. Now, total knee replacement, or for that matter, hip replacement, is the surgical treatment of arthritis, and the robot is the next level without any questions. So we have to understand how and why the plan, how did the evolution and execution has changed over the past couple of years. But we need to understand technology first. Now, basically, CAOS is the use of computer in orthopedics is COS. Computers aid in geometric precision, reproducibility. It has a perfect memory, and of course, it lacks fatigue. Computer-assisted surgery is a misnomer. Like, it's not exactly a robot. I mean, you have computers and robot in your aid. It does not replace the eye of the surgeon and does not require technicians dedicated to it in most of the cases. Another thing which we need to understand is active robots that are in these, the surgical tasks are performed without the intervention of the surgeons. The semi-active robot, whereas robotic controlled, but surgeon is there to control it, and passive. So the Mako Navio falls in this category. Now, importantly, you have to feed the robot or the computer what you are going to do. So you can feed it in the form of X-ray, you can feed in the form of CT scan, or for that matter, MRI, or freehand, that is image-free navigation or robotics. Now, computer navigation are rigid bodies, and basically you can see the markers which gets the signal from the body to the computer. And navigation was a giant step in joint replacement. Basically, this is a very important slide, which is very much discussed in meetings. The human eye cannot judge 1 degree, 2 degree, or 3 degrees. I mean, we're not good at it actually. So if you see the C column is the 3 degrees, but E and F, it seems to be 0 degrees, but E is 1 degree. So here the computer comes in action. And I'm very fortunate that we have worked, in fact, Dr. Mrinal and myself both have worked with Frederick Pickard, pioneer of navigation. So let's, surgeon, is it time for a long coffee break? Yes. Now we are in the robotic era. And so let's talk about the robot. So as I told you, it is an enforced controlled robot. Mako, Navio, Rosa falls in this category. These are some pictures. And also you are having the newer robotics are coming day by day, and things will definitely progress with time. Now, for that matter, for any robotic or navigation system to work, you need registration, and registration is then worked out according to your plan. So you need the registration, you register the patient, then you have a planning, and then the bone preparation. Now, there are two types of robotic guided systems, like one is the image free and one is the CT based. So the Mako falls in the CT based, and there are image free, and the Rosa takes X-rays. Image free works as the same, but you don't need to enter the CT scans in the system. Now, when you talk of the CT based, basically you have enhanced planning, you have more precision, and the most important thing is that it is robot guided preparation of the bone. You know each and every system, what is going to be happening next few steps, you know it very well in advance, and you take it from there. Robotic gives us a visual feedback, it will give us a tactile feedback, and also bleeps when you're going wrong. So basically, what do? We take a CT scan, we do a planning, the execution is done with the help of the robotic arm, and it has so many technologies, importantly the AccuStop technology, the haptic boundary technology that enables us to be right. So X-rays, CT scan, then we segment, plan, pre-plan, and then we are in the theater. So you have more precision, you have more personalized implant planning, you have software for intraoperative planning, and it is surgeon controlled but robotic preparation. So you are always right. Now, most importantly, you see so many data before the surgery, and this happens when the patient has a CT scan, and we know each and everything, how much varus, valgus, external rotation we have to give. We plan it accordingly. When we are in the theater, we have arrays which captures the data from the body and assimilates in the system. Then, as usual, we do the femoral registration, tibial registration, and this is a small video which will show how we do the registration. So registration is marking of the bone points so that a the machine captures it. Now, once we are done the registration, we get the planning in hand, and then we do a dynamic planning on the table. So once we have a dynamic planning on the table, so here you can see that this was the status of the knee pre-op. So this is what we are able to see. 14 degrees, 14 millimeter, it is medial tightness, 17 on the lateral side, but we all have numeric data and a dynamic plan in front of us, both in flexion, 30 degrees of flexion at whatever angle you want to see. And then you have the bone cut measurements, what you have to do to get the best knee without maximum bone cut. The most important thing which we need to understand, that once we plan everything, it is robot guided. I mean, you can see the video. It is not the robot is doing. I am doing it, but you are seeing on the screen and you are seeing that you don't need any detractors. You don't need an assistant. You plan, it gets executed. You have a haptic boundary. You cannot go wrong. If you want to cut 1 millimeter, there you can cut 1 millimeter. You don't need to increase the pin size. So less is everything, what I always say. So everything is guided by the computer. But of course, we need a lot of software, hardware. You can see the OT gets a wee bit, I mean, you need the whole system in the theater. You need big theaters. We do intraoperative balancing and dynamic planning. And this is the result which we get in the same case, 1919, we get it. But the question is, the most important question is, considering the economic impact, why robotics? Over the past 6 months, done a couple of hundreds of joints, and I see the pain factor, the pain is definitely less, which is enhancing the healthcare outcomes. Decreased pain, better HB levels, quicker restoration of straight leg raise test, a shorter hospital stay, and a better knee flexion on discharge. This is what I have been getting. Let's focus on some clinical outcomes. So functional recovery is definitely less in robotic assisted. It might be psychological, I don't know, but the data indicates that. Accuracy is definitely more. So I believe in the revision rate should go down. Of course, we don't have the long-term studies. I have to reiterate this fact that there is definitely soft tissue protection. And if you can see that in the PCL sparing TKR, we are leaving the bony island as well. So definitely there is less bone cut, and due to the haptic boundary, you cannot go outside the haptic boundary. You cannot cut the MCL, LCL or go posteriorly. And the most important thing is that you cannot have an overhang or underhang. That is what gets wrong. So revision indicators, these are the revision indicators, but what we perceive that in the future, revision rates definitely is going to come down because of better implantation techniques. Coming to the partial knee replacement, the patients are definitely more satisfied after a partial knee replacement using robotic guided, and it is definitely better. Without any doubt, I've started doing loads of partial knee replacement and I feel more comfortable and accurate during my implant positioning, especially of the femur. The pain scores have come down. But the most important question which we should talk in this seminar, in this conference, is timing in technology adaptation. What is the time? Yes, definitely to get back to time neutral, it takes time, but it is a parabolic curve. If you're working using navigation and then the robot, the time neutral comes in about 10 to 15 cases. The robotic technology has been adopted worldwide. And of course, what I believe, these are some latest papers which say knee arthroplasty is widely considered a successful procedure, and the future is going to be the robotic surgeries or robotic guided surgeries. You should have an understanding what is the difference between navigation and the robotic. Navigation gives you the data, but you are cutting it. Here you are getting the data, and with the help of the haptic boundary, AccuStop technology, and so many things in front of you, the CT in front of you, basically you are guided. So before I end, whatever be the technology, choose lesser pain, lesser recovery time, shorter hospital stay. This is what I believe. So why then we are still using the traditional conventional techniques? Because despite lots of evidences, if you are a patient, what would you like to choose? A procedure 60, 70% or 85% accuracy, or more than 100% accuracy? A big thank you. So important thing is that another thing, change is the law of nature. Progress is inevitable. Technology is here to stay. Only the form will change and become smaller with time. And those who embrace the change will survive. Those who don't, perish and retire. So we need to get accustomed to the technology. That's what I believe. Thank you. Any questions?
Thank you. Thank you, Dr. Assis, for sticking to time. It was an excellent presentation. Actually, we got aware of this new technology, and way you show the video that really we can cut until about 1 millimeter, so
Yes.
which is not visible to the naked eye. That is where the advantage of robots lie. Now, my question is that do you do hip replacements also with the robotics?
Yes.
And what is the advantage of hip replacement with the robotics? Can you tell 1 or 2 points?
Sir, when we are doing hip replacements, right from the very beginning, regarding the position of the patient, anteversion, more inclination, abduction angle, there is so much confusion. When you are doing a robotic guided total hip replacement, you have the CT scan in front of you and you plan and you get there. So it is basically one word in Hindi, I would say, it is a jugalbandi. When you have your X-ray CT scan in front of you and you're executing the plan, you are better. I am getting to the teardrop, planning is executed, the combined offset is matched and everything. So it basically helps. I do more of hips than knees and more of hips and partial knees nowadays. Yes, sir.
And another important question is that, this technology, we saw the navigation and all these things. They keep on changing their software every 5 years, 10 years or something like that, and some new thing comes.
Yes, sir.
Suppose I am an orthopedic surgeon, I bought the robot today, and there is change in the technology, something else comes. I have utilized such a huge amount of money there.
Yes.
How to go about it? Does it really worth to utilize that money for just 5 years, 10 years, and then again something new comes? Then I'll have to buy that. Then this becomes outdated. As you can see, that last 10 years, we have seen navigation, but now very few people talk about navigation. Specific people talk about navigation. What is your opinion about it?
Sir, a very good question, because am a navigation user, but when the robot came, I do still have the navigation. Yes, the navigation cart has increased in efficiency and new softwares have come. So out of the blue, I would like to say, when you are purchasing anything, make sure that you have the software's upgradation at least till 5 years, because investment, the hardware becomes the same and only the software gets, for that matter, if you're talking of the Striker Mako, we are on version 3 at the moment and version 4 has been launched, especially in hips, and that is useful. So I have a contract that next 5-7 years, and I think in 5-7 years, this technology, definitely there will be a new technology, but I think for the next 5 years and over the past 10 years, this system of robotics has been there in the market. So I would recommend that make sure that you have contract stating that you have software upgrades till next couple of years at least, sir.
Thank you.
What is Minal's comment for this? Because we have been working together and seeing all the navigation cards and everything.
See, I think I do a lot of navigated knees.
Meenal, Dr. Rajiv has a question.
Okay.
Yes.
Is there anybody in the auditorium wants to ask any questions?
Any question in audience, sir? We have one here, sir.
Yeah, Dr. Rajiv, we can just ask a question and just
Sure.
make a discussion out of the audience. Let the audience ask first.
Sir, we have one doctor from the audience, sir.
Yeah.
Please answer.
Good morning, Dr. Sanjay Chaturvedi from Agra.
Yes, sir. Answer.
The only question is, every technology fails. Have you seen any failure inside orthopedic theater failing one of the software in your cases?
Sir, a very good question again. One of my professors in Glasgow had always taught me it is very important to bail out from the surgery. Yes, I have had problems sometimes in navigation when you have taken the cuts and something has gone down, but there you need to have an understanding and have a plan B. In robotics, at this point of time, we have a product specialist along with us during in theater, but it seldom happens. It has never happened over the past 200 cases.
The question was, how will you check? This is human.
Yes.
In technology, you fail. You see all the corona data, everything. There is a failure. Computer fails, everywhere fails.
Yes.
Get wrong data.
Yes.
That is there.
See.
So when you have made all the cuts, put the prosthesis, how do you say that it was wrong or right? Have you seen in any of your cases
No,
post-op? So how do you check those things?
See, most important thing in computer-assisted surgery is registration. If you register your patient wrong, everything will be wrong.
Yeah, Dr. Ashish, that is a GIGO principle, garbage in, garbage out. So
Yes.
if you put the garbage in, naturally garbage is going to, that's why you need to be experienced enough to handle the computer. There
Yes.
the human role lies, there the experience lies. So first one must do at least 50 or 100 knees, get experience before, adapting to computer or navigation. I
Yes.
think Dr. Chaturvedi is going to highlight that.
Yes.
Okay, over to Dr. Rajiv, please.
Sanjay, you asked a very pertinent question. Ashish, my question to you is almost in line with what Dr. Sanjay Chaturvedi had asked, that you see, knee replacement as we understand today, and always we understood, that is mainly a soft tissue balancing is very, very important.
Yes, sir.
And I think that's what Sanjay was trying to hint at. What is your opinion, like in navigated surgeries, which we started in 2005 and done several hundred navigated surgeries, and we realized that in spite of the best care and precautions, you sometimes have to guide the computer, which I'm sure Manal and you both will agree with me, that you'll have to change on the table. So what is your experience with the robot? Do you have to change the size on the table than what you planned earlier?
Sir, the most important advantage of the robot is that you have both the workflows, bone resection and soft tissue balancing, number one. Number two, on the table, we have dynamic planning and the numerical data in front of us. Like, for example, if we see the medial tightness is there, but on the screen, we are seeing the medial tightness in numerical, and physically we are seeing tightness. So we know that we have to do this. And then if we release, let us say I want to cut 1 millimeter more. So I plan 1 millimeter more. And what is the next effect that is going to happen? I can see on the screen itself. So that becomes, you are 2, 3, 4 steps ahead. And soft tissue balancing is one of the workflow. I also do soft tissue balancing. Here in the robot, there is less soft tissue cut, no lateral, collateral, posterior, even it's on the bone always. So less soft tissue injury, but yes, soft tissue balancing I do on table, and you have a workflow in the robot in this system for the soft tissue as well.
Thank you so much. Now we'll go on with the session. Dr. Mukesh Aswal will be our next speaker, who will be speaking on periprosthetic fractures around the knee.
Thank you, sir. See you, sir, at some.
Thank you. Thanks a lot. We welcome Professor R.C. Meena, the President of Indian Orthopaedic Association. Good morning, sir. Thanks for
very good morning. Thank you very much, sir. Monty, sir, you have given your so valuable and prestigious time to this our August body conference, IOACON 65th IOACON 2020 here. We really appreciate your gesture and your contribution in this academic feast.
Thank you,
definitely,
sir.
I hope the delegates and the orthopedic surgeons will benefited by this, particularly the young generation and youngsters. Yeah.
Sir, we welcome Dr. Rajiv Sharma, also our President-elect of Indian Arthroplasty Association.
Yes, sir. Hi, Rajiv.
Yeah.
Sir, thank you.
Thank you so much.
Arun, you want to say? Yeah.
And I would like to thank Professor Mohanty for weaving together such an extravagant scientific feast where he has invited everybody in, and on such a short notice, he took everybody on board, including Dr. Rajiv Sharma, Dr. Amit Tola, Dr. Samarjit Patnaik, Dr. Jhurani, everybody. We are extremely thankful, sir, and we would like to get your guidance and contribution in the growth of orthopedic surgeons among our association for a longer time. Thank you, sir.
Thank you. Thank you, Arun.
Well, definitely. Really appreciable, sir. Really appreciable.
Thank you, sir.
Excellent. Thank you, sir. Thank you. So nice, sir.
Yeah, thank you so much. Now, do we have Dr. Mukesh Aswal ready for the next talk?
Yes, sir.
Dr. Mukesh Aswal, please. Yeah.
So good morning, everyone. Today we are going to discuss about the periprosthetic fracture around the knee. We are going to discuss about the incidence, various risk factors, patient evaluation, strategy, various classification and treatment modalities. So incidence is overall 1 to 2% and higher following revision arthroplasty because of the increase in life expectancy and functional demands of the elderly patient, the incidents are increasing day by day. So the risk factor patient related is age more than 70 years, female sex, rheumatoid arthritis, osteoporosis, steroid therapy, and neurological disorders. And surgeon related are in femur fractures due to the femoral notching, large box cut implants, component malpositioning. In tibial fractures is because of the various positioning or malrotation of the tibial component. In patella fracture, due to the maltracking or extensive resection of the patella less than 10 or 12 mm, extensive lateral release or central pec patella. So patient evaluation, the history and physical examination should focus on pre-fracture knee symptoms such as pain, instability and stiffness, and infection workup should always be done, especially in loose implant or osteo pre-fracture knee pain, medical optimization of patient, high quality radiograph or sometimes CT to know about the stability of implant and periarticular bone stock. Status of neurovascular bundle and neurovascular and soft tissue is very important. So distal femur periprosthetic fractures is classified by Lewis and Rorabeck based on the stability of implant and displacement at fracture site. Type 1 is undisplaced with prosthesis intact. Type 2 is displaced with prosthetic intact. Type 3 is if when there is prosthesis is loose or failing. So goal of our treatment to provide a stable joint, complete fracture healing, range of motion and restore knee function to the level prior to the trauma. And a functionally favorable result is described when there is a minimum range of motion 90 degree, shortening less than 1 centimeter, whereas for valgus malalignment less than 5 degree, or minimum change in torsion and anti and retroflexion. So type 1 fracture or undisplaced fracture measures generally conservatively in long knee GT cast. Type 2 fractures are displaced fracture and depend on the location of the fractures, they treated by nail or plate. So locking plates, there are various advantages of locking plates like multiple distal fixation screw, or nowadays the variable angle plates are also there, rigid internal fixation, option of unicortical screws, we can use cables with it, and we can use as a MIPO. So these are the variable angle plates, and some MIS jig is also there for biological plating. The retrograde nail is load sharing implant indicated only in the open box implants when there is a sufficient distal bone stock and more stable in medial comminution than LCP. But we can't use in closed box and typically comminuted osteoporotic distal bony fragments. So these are the common implants appropriate for DFN like Biomed, Max, Gmer, open box implant, and some Esculap, Smith Nephew, and Depew. They are not appropriate for DFN. So revision arthroplasty is indicated when components are loose or malaligned and the fracture is simple and easily reducible and without any ligamentous deficiency, and there is no significant bone loss after component removal. So distal femur replacement or megaprosthesis is indicated when there is a loose prosthesis, inadequate bone stock, non-union periprosthetic fractures. Intraoperative femoral fractures generally occur in severe varus or valgus deformity at the time of exposure or the trial phase. So it's a good practice to keep a periprosthetic set as a backup in 3.5, 4.5 screw set, CC screw, recon plates. This is an example of medial condyle intraop fractures fixed with leg screw and a buttress plate. So this diagram shows the where to nail or where to plate. When a fracture is sufficiently proximal to the prosthesis, it's better to do a DFN, or when a fracture is around the anterior flange of the prosthesis, it's better to do a plate. So this is a treatment algorithm. Distal femur prosthetic fracture, well fixed implant, undisplaced fracture managed conservatively, displaced fracture with open box, retrograde nail, and with closed box, plating is a better option. And in unstable component, good bone stock, revision arthroplasty with stem extension, or when there is a poor bone stock, megaprosthesis is a good bailout option. It's an example of type 2 periprosthetic fractures. managed with minimal invasive technique, accurate reduction. This is the post-op X-rays showing good reduction and good consultation at 9 months. Another example of 57-year female, elsewhere reported case of navigated TKR, complaint of thigh pain since 5 days, no history of trauma. So these are the immediate post-op X-rays showing large pin track stress risers that may be the cause of fractures. So it's a pin track induced fractures. The causative factors are large diameter pins, bicortical or transcortical pins, diphygeal placement of the pins, multiple attempts, and oblique tract. Now how to reduce it? So we should use a small diameter 3.5 mm pin, unicortical pins or metaphygeal placement of pin, and we should perpendicular to the lateral cortex. So again fixed with MIS technique. These are the post-op X-rays and 3-month post-op showing good consolidation and callus formation. This is the range of motion. Again, type 2 fixed with plating. Role of dual plating when there is a medial comminution or less than 3 distal screw through the lateral plate. It's better to do a medial plate, augment with a medial plate. Otherwise, the lateral plate is going to fail. Type 3 fracture, loose implant. So do a distal femur replacement. Another type 3. So tibial periprosthetic fracture, generally they associated with the loose implant. They classified by Felix classification. Type 1 is tibial plateau fractures. Type 2 is adjacent to the stem. Type 3 distal to the stem. And type 4 are tibial tuberosity fractures. They further subdivided into type A, prosthesis well fixed. Type B, prosthesis loose, or C is intraoperative fractures. So again, treatment algorithm for intraoperative tibial fractures, undisplaced, managed conservatively, or displaced or complete fractures need a cancellous screw or a stem extension. And postoperative fracture with a stable implant, again undisplaced, conservative, displaced with plate or screw, depend on the fracture type. And in unstable fracture with good bone stock, we need to revision with a good stem component. And in poor bone stock, need a mega prosthesis. So intraoperative fractures, we need to fix with screw and stem extensions. So type 3 fractures, again fixed with the breeze plating, good alignment and good consolidation at 6 months. So again type 2 fractures with tibial tuberosity avulsion, fixed with plating and CC screw for the tibial tuberosity avulsion and showing good consolidation. So periprosthetic patella fractures is classified by Ortigura and Berry classification. The type 1 is stable implant with intact extension mechanism. Generally they treated by conservative management. Type 2 is disrupted extension mechanism. Type 3 is loose patellar component with type A reasonable bone stock, or type 3B is poor bone stock. So again, treatment algorithm is when patella periprosthetic fracture, stable component, extension mechanism in intact, needs a conservative management with extension mechanism disrupted, need, or if in form of tension bend or screw fixation or partial patellectomy. Whenever there is a loose component with good bone stock, we need a patelloplasty with component revision. And when there is a poor bone stock, we need a patellar component removal or complete patellectomy. So when there is a displacement less than 2 mm, always conserve. This is the example of displaced fractures treated by tension bend wiring. Again, a bilateral inferior pole patella fractures treated by tension bend wiring. So take home message is prevention is better than cure. Treat osteoporosis not just like just the knee. Be cautious in RA elderly patient while going surgery or post-op period. In intra fracture, fix and stem. In periprosthetic femur fracture, plate or nail as per the case. And distal femur arthroplasty is a good bailout option. In tibia, fix and take care of extensor mechanism. Any questions?
Thank you. Thank you, Dr. Aswal. That was a very good, excellent presentation and excellent number of cases. You have handled so many, difficult cases. It's really amazing. And you have covered everything. I mean, supracondylar, Agilas, tibia, and patella. That is commendable. Thank you very much for presenting and giving an outline of this, management. As you know, because of increasing, longevity of the patients and increase the incidence of osteoporosis, the incidence of periprosthetic fractures are increasing, and increasing number of, total knee replacements also in our country. So that is why one must know about this. But one must not forget to treat osteoporosis also after treating this kind of fractures, because many of the surgeons, they forget to treat osteoporosis after fixing these fractures. Second point is that you have rightly stressed upon when to do a medial plating. Many people, they do only lateral plating, then it fails, and then it fails. We have seen many failures in the supracondylar fractures. The point is that when there is a medial comminution, or when you are not able to pass at least 3 screws in the distal fragment, there you need to supplement with a medial plate. That is an extremely important point. That's why I wanted to stress it again and again. And most difficult is to treat these patellar lower pole fractures or patellar tendon disruption. Those are the worst cases to handle because of extensor mechanism disruption. Thank you very much for an excellent presentation. Any questions from the audience?
Mohanty, what I like to comment here is that it's very rightly mentioned by you and Dr. Aswal that the osteoporosis has to be managed simultaneously, not just the joint replacement. Now, the only thing about the technical part that I like to comment upon is that one thing is very important, that varus alignment is very easy to get while you are fixing the fracture, because you are not able to see the whole extremity. So it is preferable that you prepare the whole extremity so that you are able to see the alignment, and varus alignment should be avoided at all cost. What's your opinion on this?
Dr. Aswal, please.
Yeah. So the main cause of failure is always a various alignment of the distal femur. So it should be always avoided. And when there is a medial comminution, we should use some graft or medial plate.
Yes, very, very rightly said that either the graft, bone grafting should be done wherever you see the comminution, or as Dr. Mohanty rightly said, that use 2 plates, both on the medial and lateral side.
Yeah.
Thank you so much.
Thank you. Thank you, Dr. Aswal. Is there any question from the audience in the hall?
Yes, sir.
Yes.
Yeah.
Is fractures more common after patella resurfacing or in native patella? In that case, tension band wiring, whether it works in resurfaced patella or native patella?
Actually, the results of tension band wiring after resurfaced patella is not so promising. And the chances of patellar fracture are more when the patellar dissection is less than 10 mm. So it's always should be avoided when there is a thin patella. When there is a thin patella.
You know that tension band wearing after a patellar resurfacing, whenever there's a patellar fracture, there's a possibility of loosening of the patellar component. So you need to take up the patella. If it is a mid substance tear, then you can do a tension band wearing. There is no problem. Yeah. But as you told rightly that the results are poor because already it's about 10 to 12 millimeter or 13 millimeter patella is there. So and along with that, cementing has been done. So the regeneration, bone regeneration is poor. Yeah. But if it is a lower pole patellar fracture where the prosthesis is stable, when the patellar component is stable, you can fix it and it may unite. Sometimes also, if there's not much of extensor mechanism disruption, we tend to conserve these patients. Little lower pole patellar fracture, they have little maybe 5 to 10 degree of extension lag, but they manage with that rather than operating and inviting all these complications during post-operative period.
Yes, for the periprosthetic patellar fracture, the result of conservative management is much better than the operative fixation.
Correct. Yeah. Any other questions in the audience? Yeah. Thank you, Dr. Aswal. I think we'll move on to the next speaker. Dr. Rajiv, please.
Yes. I'll invite, thank you, Dr. Mohanty. I'll invite Dr. Mrinal Sharma our very good friend, to speak on a very important topic, the metafacial sleeves in total knee arthroplasty. Now, as we are getting the more and more complicated cases, I think the metafacial sleeves are becoming a very good support in very complex cases. And Dr. Manal will explain us how to deal with these complex cases in an easy way. Dr. Manal.
Good morning, Dr. Rajiv, Dr. Mohanty, and thank you, IA, for inviting me here for the lecture. And it's always great to be a part of delivering lecture at a place where you have done your MS. So I have passed out from SMS Jaipur, and it's pleasure to be among my teachers and colleagues there. I'll be talking today about metaphyseal sleeves in total knee arthroplasty, both complex primary and revisions. We need to know that the etiology of bone loss during a revision knee might be due to stress shielding. It might be due to osteolysis. Osteonecrosis might be seen. Infection obviously causes bone loss. Mechanical loss might be due to the loose implant causing the excessive bone loss, and bone loss might be due to iatrogenic causes when you are removing the implant. So obviously during a revision surgery, we preserve the viable host bone, reconstruct bone defects, try and restore the joint line to near normal, and maintain an adequate patellar tracking within neutral alignment, at the same time maintaining good ligamentous stability. If you see the defects which we see during the primary, difficult primaries and complex revisions, and you see that the type 1 according to AORA classification are minimal contained defects. The type 2A are contained damaged metaphyseal defects, and the type 2B are uncontained damaged metaphyseal defects. And the type 3 are deficient metaphyses, where you might need to use hinged prosthesis. Preoperative planning is of importance. CT scans usually they show all areas of osteolysis in which only 17% of cases would be identified on X-rays. The implant presence usually underestimates the deficit. Dr. Ing said that the surgeon could anticipate the worst scenario because often the defects turn out to be more severe than predicted. So if you see this case, you see the radiographs, you can see the tibial loosening, you can see osteolysis around the femoral component. If you are able to detect on the CT scan, you can see the voids around the femoral component, but when you open up during the surgery and see the large defect on the femoral side. So, you know, what X-rays show, you might find it might be 10 times more than what you see intraoperatively. And the management of bone loss, metaphyseal bone loss can be done using impaction grafting. You can use prosthesis augmentation, bulk structural allograft, metaphyseal cones, or metaphyseal sleeves. Now the sleeves, they usually are used to augment fixation in a revision, TKR or complex primary. They fill the metaphyseal bone defect. They provide an adequate zone 2 fixation according to Morgan-Jones zonal classification, and both cemented and uncemented fixations, they work well. This is the assembly of a MBT tray, where you can see that the tray is fixed with the stem and the sleeve is actually fixed with the assembly as a Morse taper. There are different sizes. The surface topography and elliptical contour of the sleeves neutralizes the axial bending rotational stresses and provides initial press fit fixation and immediate stability and long-term bone ingrowth. Sleeves usually they are prepared using, you know, reamers initially, and then the appropriate sized broach is used to seat the actual component. You need to have a fresh press fit fixation, very important, with the absolute rotational stability for the bone to ingrow. If it is loose, you will have fibrous growth, ingrowth, and you will have failure. Now, this is the case of a revision total knee, 60-year female. The index surgery was done 19 years ago. The same patient, you can see on the left side, there is loosening, aseptic loosening. There is osteolysis below the tibial tray and on the femoral side as well. And CT scans, they help you delineate the defects clearly. You can see the defects intraoperatively, large femoral defect, almost the whole of the metaphysis is gone. And on the tibial side also, you see a large tibial defect. And I did a revision surgery. This is the sleeve assembly which I used. And ultimately, this is the intraoperative picture where I've used an MBT tray with a rotating insert. And the immediate post-op picture you can see here, and a 5-year follow-up of the same patient. The implant is sitting pretty well, and there's no zones of any osteolysis anywhere around. Another case, 60-year female, revision. The index surgery was done 5 years ago. You can see the tibia having gone into a varus collapse and the femur is also loose. And I did a revision surgery. Intraoperatively, you can see the picture. The tibia is in varus and it's collapsed, it's loose. There is mediolateral instability. And the large tibial defect which you see when I removed. If you see the second image, you can see that the cautery is showing that the cortex is so thinned out that you can see the light passing through there, and the femoral component removal was okay. There was not much defect. So I did a revision. This is the intraoperative picture and the post-operative X-rays where I did a cemented femoral component on the with the stem on the femur side and a sleeve on the tibial side. This is another case of a complex scenario. A 28-year male with a fused knee, post-tuberculosis, almost 8 years ago. The knee is totally healed, but it's fused in a fixed flexion deformity of almost 50 to 60 degrees. And I used from Noyles. Now, this is something which needs a sleeve preparation on the femoral side. And you can see the assembly of the sleeves I used on the femoral side and intraoperative picture. And the patient has a straight knee immediately post-surgery. And the post-op X-rays are showing the component positioning in a neutral alignment. Now, these sleeves are not a panacea. You know, they can also fail. You can have failure to, they can have failure to osseointegrate. You can have a varus collapse, a stem cutout, a stem of end of stem pain, periprosthetic fractures, and if they need to be revised, they are sometimes difficult to revise. Osseointegration in sleeves was something I learned with Dr. Ranawat when I was there. Grade 1, you have complete osseointegration. Grade 2A, it is stable osseointegration with more than 50% porous coating being incorporated. Grade 2B is less than 50% porous coating incorporation. And grade 3 is no osseointegration with or without subsidence. So this is an example of grade 1 where you can see almost full incorporation in the AP and lateral planes in all the zones with the porous coating part. Grade 2A, you can see that there is fibrous tissue formation and you can see radiolucences in the proximal parts in the AP view as well. And in grade 2B, you can see on the lateral view, there is a fibrous radiolucent line and the sleeve is not incorporated in more than 50% of the part of the porous coating. So such cases, you might need to remove the sleeves, maybe due to a septic revision or due to fibrous union leading to loosening. It's difficult. You need, if the sleeve is well fixed, you have to, remove the bone all along with, K-wires or small tip burrs, and then make an interior window, which you can see here, and then push the sleeve out once you've disassembled the femoral component with the stem from the sleeve. If we review the literature, then you see that this article in Journal of Orthoplasty published in 2017, they had 280 patients with 393 metaphyseal sleeves. There were 12% perioperative complications, 6% intraoperative fractures, but these sleeves showed a free 5-year survival rate of 96% for the femoral component and 99.5% for the tibial sleeve. So the level of constraint, bone loss, sleeve or stem fixation and revision indication did not affect the outcomes. Mind you, this is a very important line. They even if you are not using a stem, the sleeves incorporated and it did not affect the outcome. Recent paper 2019 published from Endo Clinic with Dr. Garke and Dr. Echoes, with whom I've worked. They usually use cones there, but they have also published this paper of 1413 sleeves with a 4% septic re-revision rate and a 3% aseptic re-revision rate, although there was intraoperative fractures in 3% of the cases. But they reported high radiographic signs of osseointegration, low septic loosening rates, less intraoperative fractures, and good to excellent clinical outcomes. Another recent paper from Journal of Orthoplasty 2019 by Veres et al. Have a 98% survival at 5 years. 68% uncemented metaphyseal sleeves were used, and they are good to go in AORI 2A, 2B, and AORI type 3 defects. The good thing is they also allowed joint line restoration to almost 0.3 millimeters. So that is an accuracy you can achieve with these metaphyseal sleeves. So the take-home message is they help in managing bone loss in AORI type 2A, 2B, and type 3 defects. Excellent stability is provided in zone 2. They have 96% survival rates reported on the femoral side and 99% for almost 5 years in the tibial side. Both cemented and uncemented fixation, they work equally well, and the excellent clinical outcomes have been reported. Thank you. But before I end, I'd like to invite you for this IA webinar, and which I am convening with Dr. Mohanty. And we have got excellent faculty from across the globe: Dr. Faris Sadat from UK, Dr. Dan Berry from US, Dr. Sue from USA, HSS, and Dr. Deepak from Lancashire, UK. And we have excellent Indian faculty also who are presenting: Dr. Bhende from Bombay, Dr. R.K. Sharma from Delhi, Dr. Pradeep Bhosle from Bombay, and Dr. Anup Jurani from Jaipur. The topic is instability after total hip arthroplasty. All we wanted to know. It's on 16th of March. I would like every one of you to join. Thank you.
Thank you. Thank you, Dr. Mrinal. As Dr. Mrinal has shown in the last slide, I request all of you to join this webinar. It is totally free, and you just click on the YouTube channel, or you can click on the YouTube channel of Indian Orthoplasty Association. Directly, you can join this webinar. It is at 6:30 p.m. on Tuesday, coming Tuesday, that is 16th of March. And it was an excellent presentation by Dr. Sharma on the use of sleeves. One or two points, just let me highlight again that number one, that people always get confused between cones and sleeves. Remember, sleeves is used as a unitized component along with the stem extender and your prosthesis. So you put the sleeves first, assemble it on the table, then you put directly putting the cement in. Whereas cones has to be fixed first. Cones has to be, has to be put in the bone, and to achieve stability, cones has to be fixed first. Then you put the implant inside the cone, or cement the, implant with the stem extender inside the cone. That is the difference. So you want us to be very careful to know the difference between that while using them, because you cannot use cone as a unitized component, whereas sleeves can be used a unitized component, and that is always little easier to use the sleeves. Second point is, in Indians, most of the Indian ladies, we find there are very small bones, So the smallest size of sleeve is usually helpful for Indian females, especially on the tibial side. And the smallest size of sleeve is totally cemented. It's not, there's no uncemented component available. So one has to know about this, because sometimes the bones are so small, even you may not be able to put the sleeves there. So one has to, think about it and plan it properly before doing it on the table. But excellent cases, very good, outcome of these cases. Is there any questions from the audience?
No, I think it's an excellent talk, Mrunal. And
Thank you.
Welcome, Parag. Thanks for joining.
And I was listening to the talk, and the only thing is, if you can just tell me that when would you use a sleeve and when would you use a cone? Are there any indications that, okay, this case I want to use a sleeve and this case I want to use a cone? That will benefit me and also the delegates.
See, I am only using sleeves. I'm not using cones, although I was trained when I was doing a fellowship at Endo Clinic to use cones. But I think cones are more of, fillers for bone defects, and we have to cement them, and they osteointegrate, the bone grows into them, and they act as fillers. Whereas the sleeves, we can use them as a component, part of the component where like an uncemented stem, the bone ingrows, and, they just, osteointegrate. So the philosophy is totally different. One is a bone filler and the other is a bone integrator. So I think absolute stability is achieved on table with both of them. And it's up to the surgeon to decide what he wants to, whether he wants to use a cemented component, cemented stems, then he needs to use a cone. If he belongs to a philosophy of uncemented stems, then he needs to use sleeves. So both have excellent results. I have in my upcoming book, excellent paper, chapters are being written by doctor on, on sleeves as well as cones. So Dr. Amar has written on sleeves, and another doctor has written on cones. So the different philosophies, but the same, addressing the same problems.
Yeah. So I think just to add to that, whenever there are large bone defects, I think for the bone defects, if you use a sleeve, that might not be a good idea. You have to use a cone to build up, and then you can, do whatever the implantation. So that is, in my eyes, I see that as a major differentiator between the two. But thanks for the inputs, and I'm looking forward to your book.
I agree with Parag. That's a very good point. The cones are made up of trabecular metal. There is very good bone ingrowth into this trabecular metal, these cones. And one important practical point, whenever you are putting the cones, and the soft tissues should directly, you shouldn't oppose onto the cones. You should put a layer of cement. If the, if it is not totally contained inside the defect, suppose the cone is exposed somewhere, then do not just suture the soft tissues over the cones, because that will lead to extensive fibrosis of soft tissues, limitation of range of movement, and sometimes in the hip, situation, there is a possibility of nerve also getting, and that may give rise to pain post-operatively. So one has to put a layer of cement over it before opposing the soft tissues. Yeah, Rajiv, you had some question, and you can.
Mrinal, very well elaborated, difficult topic. And I think that in time to come, we are going to use more and more cones and sleeves. What Dr. Mohanty has also commented, my question is this in the similar line, that in the some of the small built patients, the smallest sleeve also becomes very big. So in these cases, what do you do in these cases?
So if I'm unable to actually put in a sleeve, the smallest size which we need to cement, I would probably do impaction grafting and do a cemented stem.
I think that's a very good idea. And if there is a not a very gross mismatch, then I find that using the high speed burr is very useful, because you cannot use the osteotome because the bones are so weak, and the defect may be significant, and using the osteotome may create a problem. So in these cases, probably the high speed burr, if you use, you're able to create a space for the sleeve in an easier way.
Commonly we use the burr for making a space for the sleeves.
Yeah, that is a very important point. One should keep the high speed burr always in order to accommodate the sleeve or the cones to be in the proper place and fitting tightly. Any questions from the audience at this point of time? Okay. So let's move on to the next talk. It's a pleasure and honor to invite Dr. Parag Sancheti, who is the director of Sancheti Institute of Orthopaedics and Rehabilitation from Pune, and he is the past president of Asia Pacific Arthroplasty Society, as well as past president of Maharashtra Orthopaedic Association. Thank you for joining today in this session. And he will be talking on severe, take care in severe deformities, which commonly we see in India. In many of the places, people neglect and land up with very severe deformities. Over to you, Parag.
Thank you very much, Dr. Mohanty, for this opportunity. It's indeed a pleasure to be at the mini IOACON, and also thanks to the scientific committee, the organizing committee, and the organizing chairman, Dr. Meena, for this opportunity. I think it was a good idea to have this hybrid conference. Since long we've been missing physical conferences. So it was a good idea, and in a couple of weeks we also have YROC. So looking forward to that, Dr. Mohanty, also. So thanks for the opportunity. And can you see my screen? Mohanty, can you see my screen?
Yes, we can.
Okay. So TKR in severe deformities is a different cup of tea. Normally, what cases we do are conventional deformities, 5-10 degrees of varus, valgus, and these don't really qualify to be called as a severe deformity. So whenever you're dealing with a severe deformity, the deformity is usually 25-30 degrees plus of the deformity, may it be flexion, may it be hyperextension, may it be varus or valgus. So whenever you're dealing with the severe varus or valgus, you've got to identify that the basic principles don't change. The tight medial structures in a severe varus knee have to be released. And there is a particular sequence you need to follow while doing that. And in the valgus knee, also the same applies. The important thing is you have to do a titrated sequential release. These are the two important words, titration and sequential. Because if you try to do something all in one go, there is a possibility that you may actually damage the structures, and that may lead to using a higher constraint of the implant. Whenever you're dealing with a severe deformity, varus or valgus, I always like to do what we call as a stress X-ray. So on a stress X-ray, we know whether the deformity is correctable or not. As you can see in this particular case, this was a single joint weight bearing X-ray. And when we give a valgus stress X-ray, this deformity actually opens up, and then you start seeing the bone defect. So actually the 35-degree varus deformity has come to just 5 degrees. So, that shows that the medial release much is not required, as well as the bone defect comes to your eyes, which needs to be reconstructed. Where this is the case where there is no correction of deformity, even when giving the stress view, that shows that the medial structures are contracted. The amount of release required is quite a bit, and you can see that this is the new bone formation here, which is a sign of the fixed deformities. Whenever we are doing a knee replacement, I think this is a basic slide. These are the three main cuts, and I am a philosopher of the conventional. Don't buy the theory where we are doing the kinematic knees or the kinematically aligned knees. So I am more of a mechanical alignment guy, and I cut the tibia at 90 degrees to the mechanical axis, the femur 90 degrees to the again the mechanical axis of the femur, and the appropriate AP cuts depending on what the joint is, and I follow the runabout technique. So this is the basic. But what I want to add is whenever there is a severe deformity, one always feels that you should take an extra cut to tackle the severe deformity. But friends, let me tell you, more the deformity, less the cut. Because more the deformity, more the release, and you're going to open up the joint. Therefore, more the deformity, minimum is the cut. That is one of the basic principles I want to tell you. Then you've got to do a sequential release when you're doing a varus knee. Start with the deep MCL, the osteophyte space, the medial capsule, semimembranosus, posterior release, and the last is the MCL. Nowadays, I actually don't even release the MCL as much I used to do about 5 years ago. I hardly touch the MCL actually. So, but if at all it has to be done in a severely deformed knee, then you may do it. Three main steps when we are dealing with severe deformity: release of the posteromedial structures, additional pie crusting of the medial structures, which is a little controversial, but I'll speak about it in a minute. And then, as I was just saying, superficial MCL release. What I do in the figure of 4 position, as you can see here, that the foot is externally rotated, that brings the posteromedial corner in view, and then the semimembranosus, the posterior oblique ligament, all the posteromedial structures are actually attached there, and that can be achieved very well by doing a figure of 4 position. Pie crusting is something I like. There are many people who don't like this technique and contest it with me, but I think if it is done carefully using a 16 gauge needle or using 11 blade, don't give more than 8 or 9 stabs, and then you should be all right. And that helps to, kind of slowly, gradually release the tension in the medial structures, especially the medial collateral. The superficial MCL, when you have to go subperiosteally. All of us know that the superficial MCL is attached about 8 to 10 centimeters below the joint line. So don't go beyond that. You don't want to blow the knee, because if you blow that, then you're stuck with a difficult problem, and then you have to go for a constrained knee. So this should be the last step, and very, very carefully done. Whenever we are dealing with severe deformities, you will always be having bone defects. So depending on the type of bone defect, the size of the bone defect, you can decide what to do. But generally speaking, if it is less than 4 millimeters, I do just cementing. Between 4 to 8, I would do cement and screw. And more than 8 millimeters, I like to use a bone graft. And I'm not much of a fan of augments. So this was the case of severe varus deformity, 25 degrees plus. This was the bone defect which was seen after taking the proximal tibial cut. We reconstructed it with the upper end tibial cut and the distal femoral cut, and could get a good correction. And in fact, this was the see that is putting the and even if there is cement there, don't worry, these grafts heal as long as your alignment is good. So remember, in a reconstruction of the bone defects, the bone graft you put, don't worry about the cement. The grafts is that if you don't what will fail the graft is if you don't have a proper alignment, then that can fail. I think it is important to also understand that reduction osteotomy is an important tool in your hand. So whenever there is a severe deformity and there is extra bone on the medial side, what we do is slightly downsize the tibial component, move it a little bit laterally so that the excess bone which is there, we can remove it. And this also helps in severe deformities. How it helps is it reduces the tenting of the medial structure. It also helps to correct the deformity. And since the medial bone, excessive bone is removed, the closure of the capsule is important and it becomes easy. And I'm a firm believer that you should be able to get an anatomic closure of the capsule, even in a severe deformity. Don't leave it open, otherwise the wound will ooze from the distal stitches, from the inferior stitches, and that's a problem. This is another case, a severe deformity of both the knees. This In addition, the patient also had a as you can see on the left side, severe deformity, partially correctable. This was the bone defect. And way to correct this is by the KHS slot technique, where we put a graft inside, and this graft is hammered into this. It is the press fit technique, and it is fixed with a screw, and the excess bone is cut. And this is a good way to reconstruct the bone defect. This was the final X-ray. This was at 1 year follow-up. You can see that the pathological fracture has healed. The bone is completely incorporated in the defect, and the patient went on to have an excellent result. So in summary, do a sequential release. I would definitely recommend a PS knee as compared to a CR knee in severe deformities. Keep a backup ready of constraint processes and long stems. I think this is very critical. So this was about the varus deformity. In the next 3 or 4 minutes, quickly, I will talk about the valgus deformity. Valgus is not as common. I see it in less than 10% of my practice. Mainly, these are rheumatoids or sometimes post-traumatic cases or metabolic issues of the patient, systemic metabolic issues. So these are the patients where you have to do again a titrated release. I particularly like to inside out release. I use a laminate spreader and distract the joint and give multiple stabs. Popliteus is the last structure which I release. As far as possible, I avoid to release it. I'm again a PS guy, and I always release the PCL. And more so in severe deformities, I think it's a good idea not to use the CR knee. And in this particular technique, I like to use the pie crusting technique. This was a joint where you can see the valgus deformity of 22 degrees. We did a correction of the deformity and did not have to use a long step. Sometimes you have to do what we call as an epicondylar osteotomy. You take a large chunk of bone and then you have to move it proximally and superiorly or inferior, depending on the deformity, is flexion deformity or an hyperextension deformity. I think, as I was telling you, the most important thing is closure. I just want to give you a tip here on closing the severe deformities knees. If it is a varus knee, what you do is you tag the medial structures with the Vicryl stitch. Keep pulling on this structure as you proceed with your TKR, because this can go posteriorly. And then we take the stitches in the end. You can see even in a severe deformity, we can actually get an anatomic closure of the capsule by tagging this posterior, the medial structures with Vicryl, and keep pulling them as we go on in the procedure so that it does not retract posteriorly. When we are dealing with valgus knees, be careful that a severe correction of valgus more than 30 degrees can cause a common peroneal nerve palsy. You've got to tell that. And also, whenever you are doing the release in the posterolateral corner, do not use the needle or the blade more than 1 centimeter in that corner, because at 1.5 centimeters lies the common peroneal nerve and you may damage it. So you don't know whether post-operatively it is because of the correction of the severe valgus or is it because of the damaging of the nerve. So you've got to be careful there. Another complication is the maltracking of the patella in severe valgus deformities. Do not hesitate to do a lateral release. Shift the component slightly medially and superiorly, gives you a better tracking. Slightly externally rotate the femoral component a little more. I don't find any problem in doing that, even though some people may not agree with me, but I like to do that. I like to get a good tracking patella before I leave the table. Otherwise, these are the patients who bother you later. Just a last case, Mohanty, this was a wind-swept deformity, varus on one side, valgus on one side. We did a bilateral TKR, same stage. Bone loss was reconstructed with the press fit technique. This was the final X-ray. You can see the alignment, the follow-up at 2 years. Patients are doing extremely well. So to summarize, whenever you have a valgus knee, it is partially correctable, and less than 20 degrees, you can use the medial approach. If it is more than 30 degrees, people do recommend using a lateral approach, the lateral parapatellar approach, but I stopped doing that. I did a few cases initially. You have to note along with the valgus whether it's a flexion deformity, hyperextension, or is it a lax or an incompetent MCL, or it's a fixed flexion deformity. I think these will help you to appropriately decide whether you need an epicondylar osteotomy, whether you need to distalize the femur, or whether you need to use a hinge component. In summary, I think stage sequential release is important. Ensure good maltracking, good tracking of the patella. Again, I'm a fan of PS and I always use a PS, and more so in severe deformities. Keep ready a backup of a long stem or a TC3 LCCK. And in severe cases where the MCL is incompetent, you have to use a hinged prosthesis. Thank you all for your kind attention.
Thank you, Parag. It's a very well explained, a very difficult topic. In fact, the tabulation that you have done probably will be useful even for experienced surgeons. Excellent presentation. And with your experience, we expect the same. Any questions for Dr. Parag?
Rajiv, there's a question in the chat box from Dr. Dheeraj Maruti.
Yes, Dr. Dheeraj is asking Parag that he is complimenting you with the nice slides, and he's asking in severe deformed cases, share your experience when you plan for bone grafting, tibial sleeve, and augments in severe varus defects.
So in severe varus defects, I have hardly used a sleeve anytime. I have not used a sleeve, to be very honest, in a primary severe. What I will do is I'll definitely keep a long stem ready, Dheeraj, and reconstruction for the bone graft. I just showed you the two techniques. I like the rectangular slot technique which was devised by KHSF, and it gives you good results. Augments are helpful, but what my problem is, why I stopped using augments is you have to cut actually more normal bone to fit in that augment properly. And I don't feel very comfortable doing that. So even in bone defects, what I would do is I would use screws, grafts, and then cement. Believe me, cement is a wonderful filler, and it as long as you have the alignment well, you get your mechanical access right. Even cement with screws and a bone graft, which is taken from the cut bones, or at times if you feel that in severe deformities you may not get bone, then you can use either an allograft or an autograft. We have access to allografts here, so that can be a good way. But again, I'm not a very big fan of augments. So this is my experience, Dheeraj. I would be happy to hear Rajiv and Mohanty, how they tackle and what are their algorithms for reconstructing severe bone defects.
Just want to add one point. Just for our cases, we are discussing about our Indian scenario. In our country, many times we face also poor patients, and all these augments and all this thing that costs money. As well as whenever in some system, if you're using augments, you have to use the revision components, where it has become more so expensive. So wherever it is possible, better we prefer to use the grafts, because already you have the cords in your hand from femoral cords and tibial cords. So you can use those one of the cords and then build up and use a primary component.
Dr. Mohanty, can I add something?
Yeah, please.
Yeah. So I have a publication of 54 cases on severe varus with bone defects reconstructed with the bone defect with the bone graft, autografts, and impaction grafting. It's published in IGO in 2013. So that's a very large series of such severe deformities, which I published when I was in Apollo, Delhi, and Dr. R.K. Sharma was also there.
What is the crux of that? What is the conclusion?
So we didn't have any failures. The grafts incorporated, provided you use stems and you make them walk immediately, so that the graft incorporates under the Wolff's law. So that is very important. If you don't load the graft, it will fail. It will go into varus collapse. So that's very important, and stem extenders are also very important to be used in such cases. And I have an excellent presentation, Dr. Parag. I have a question for you. What would you do in a very severe deformity like 45 degrees? You have released the posterior middle, released the reduction osteotomy, the undersizing of the tibia, and the superficial MCL, but still you are not able to balance such a severe varus. What would you do next?
So these are the very challenging cases, and for this sometimes what Dr. Ranawat has taught me is you just slightly release the popliteus and you'll be surprised at what the kind of release you get. So people are surprised that how can you release a popliteus in a severe varus deformity, but if you see the attachment, it goes all the way medially on the tibial side also. So release the popliteus, that is number one. And in spite of doing all that, if you really feel it's not getting balanced, I don't mind leaving the medial side tight 2 to 3 millimeters. It usually stretches out, it usually corrects. I am not a diehard fan, and I can say this publicly that I have to get it perfectly balanced. Couple of millimeters in a severe varus deformity, don't worry. It will stretch out, it will be all right. You can leave it a little tight if it's opening a little more. This is my personal view. I don't have any kind of a study to back this up, but I have not hesitated it in my practice. So this is my answer to your question. And then you don't want to move to a constant processes. Of course, then, you release it all the way and then go to a TC3 or a LCCK or sometimes a hinge, and then, you balance it. But then what is the point? You won the battle, but all your soldiers have been killed. That's my theory. I don't want to do that. I will, save all my soldiers and use, a little bit.
Very, very, very well said, Parag. That you can't sacrifice the MCL for the sake of releasing too much. And Mrinal's point is also very right that sometimes the virus is so much that you have to leave some amount of tightening of the MCL. Parag, I agree with your point that better than the augments, it is better to use the bone graft, because sometimes you fix the smallest augment, you have to remove some part of bone, which is not a preferable thing, because you want to preserve as much of the host bone as possible, because of the possibility of revisions in future. I think it's very well said. Parag, my question to you is that in the similar situations like what Mrinal is talking about, severe virus, you release enough of the MCL, and you know that beyond this, the MCL will become inefficient. Have you ever come across a situation where the lateral laxity was tightened um, by maybe a epicondylar osteotomy, which you are very fond of doing in some severe cases?
Yeah, so for varus knee, I haven't really tried that. In valgus knees, I use that more than varus knees, but I think that's a good point, which can be considered in severe deformities. If it is not correcting, then these actually you can do a medial epicondylar osteotomy and then correct the severe varus. I think that's a good point. I have no experience again with tightening the lateral side, what you're saying, and I haven't read much about it, but I think that's one more way to, the lateral side is always lax. So you can actually compensate by tightening the lateral structure. So I think that's a good point, but I have not read up or have any experience with it.
I've done a few cases. Mohanty, what is your opinion on this?
Let's move ahead, actually, Rajiv, because we are constrained of time, because we have to hand over at 11 o'clock. We have 3 more speakers. So is there any questions from the audience in the hall? Okay, if there are no questions, then we can move ahead. We thank Dr. Parag Sancheti for joining today. Thank you very much.
Thanks. Thanks, Brunal. Thanks, Rajesh.
Let's invite our next speaker, Dr. Smarajit Patnaik, who is a senior consultant at Apollo Hospital, Bhubaneswar, and is also a DNB teacher. And Dr. Smarajit will be focusing on the selection of stem in a primary THR, fully coated, proximally coated, the different shapes, and it's always confusion for a beginner when he starts arthroplasty practice. Over to Dr. Smarajit, please.
Good morning. It's a great pleasure and honor to be part of this program, the Indian Orthopaedic Association and Indian Arthroplasty Association. And thank you, President Sir, and my esteemed colleagues for giving me this opportunity. So the reason for which I choose this topic about why stems are important in a primary hip replacement arthroplasty and which stem we should choose is basically because whenever we are now talking about total hip replacement, we are no more talking about 15 years or 20 years of survivorship. We are talking about 30, 40 years of survivorship. And with this background, and in 2021, the 21st century, one of the most successful surgeries has been a total hip replacement. So with this background, it is for the new surgeons who are starting to do the arthroplasty and the surgeons who are even experienced and they are stuck with particular type or particular company, whether that's the right way to go or we should have a more sort of a practical approach on depending on the type of the patient to deal with these type of to choose our the prosthesis for the primary hip total hip replacement. So as I start doing my presentations, the first one is what is the purpose is basically there are a lot of types of femoral stems and there are a lot of companies which come, and at times we get stuck with a particular company and particular type of stems. And again, we have to be very sure, as I was telling, about what the next patient is, what is the best prosthesis for the next patient which we are going to do this surgery. And all this should be based on some principles and some philosophies. And it need not be always the market-driven stuff. So what is the scientific opinion? Our scientific opinion or judgment for a particular patient should be based on the age of the patient, the BMI, the quality of the bone, and the pathological anatomy which this particular patient has. Now, sometimes, even in a primary hip replacement situation, we have to use even revision prosthesis. So that is what we have to be, again, very clear about the pathological anatomy with which we are dealing. And all these should be based on published evidence and the registry data. And this is how we can scientifically choose a particular type of an implant or a prosthesis. And I am going to stick now to only the femoral side here for today's discussion. And to begin with, it's basic, the templates. We should template all our hips, because based on that also we can choose actually which type of a femoral stem is going to be ideal for this particular patient. And this is very important because we have to have the right size of the stem, the proper neck cut, and we have to have the proper offsets available with us during the surgery, the options available for us. Now, the three important concepts in modern day total hip replacement are the combined length, which has to be restored. Hence, we can predict the limb length discrepancy which is expected for a particular case, or we can equalize it in most of the cases. And we have to rely on the combined offset and the combined LT version. So these three things are important, and it's important for us to understand the hip as easily as it pops up when we are going to do the total hip replacement. Should that easily go inside also? There's no point in really tightening up a total hip replacement. There's no role for that. So that basically means the soft tissue balancing has to be, again, as important as in a total hip replacement. Now, how to choose your stems? So the workhorse for us has been the cemented stems. We started with them. It's been more than 40 years. They are the gold standard. And we are happy with these cemented stems. And for all the elderly patients, even now, I think that's got a definite role. And in some of the difficult cases where we can also take the cemented stems into our practice. So this is a stem which is a very well polished. It's a tapered stem. It's the Exeter type of stem. It has got very long-term data and very robust data. And this is just to show you pictorially how it's polished. It's a straight and polished stem and tapered. And because of this polish, the friction between the cement and the implant is less, so that the pressure on the bone, the integration is good in these type of stems, and they have got very good long-term data with us. So why do we have to think something else when we have a very good option with us? Now, it is again with these registry data, what we see at about 15 years, the socket site of the cemented total hip replacement does not do as good as the socket site of an uncemented total hip replacement. And that is where the concept of trying to go something beyond a cemented total hip replacement is to be considered. And because we are now more concerned about the survivorship of these procedures, the total hip replacement. So whenever we have younger patients, now more and more we are having these groups or subset of patients, and we are now come from the time where we used to think that the prosthesis is going to outlive the patient. Now we have come to a stage where the patient should outlive our prosthesis. So with this philosophy, now younger patients who are usually less than 55, the uncemented total hip replacement, especially on the socket side, it shows some good results, likely in terms of longevity. Because in younger patients, the bone quality is good, they get good press fit fixation, and the bone ingrowth is good, so probably they last longer, and that's what the registry data shows. And even in uncemented stems, we are having the option of using large size heads, so which definitely has a role in increasing the range of motion and the stability in the total hip replacement. Now, a flip side about the total hip replacement in younger patients. Now, whenever we have to revise this hip in younger patients, it becomes a very extensive surgery, which requires extensive osteotomies, And even beyond that, while removing the stem also, we might also have to remove, which may involve a lot of bone loss. So here, that definitely in younger patients, the uncemented total hip replacement, both on the socket and the femoral side, has probably advantages over the cemented stems when we consider in terms of longevity of 30, 40 years of survivorship. Now, when we come to the uncemented femoral stems, what are the different types of uncemented femoral stems we come across? We have basically a proximally hydroxyapatite coated ones and the fully hydroxyapatite coated ones. So these are the two different types of uncemented femoral stems which come across. And all these uncemented femoral stems, they are tapered and they depend on a philosophy where they fix proximally only, and they only fill the distal part, the conical part of the medullary part. So that's an important concept in uncemented femoral stems, where we start off when getting into two different broad types of a proximal hydroxyapatite coated or a fully hydroxyapatite coated ones. Now, and these are tapered. Now, we have gone through the AML stems, which are cylindrical stems, and they are associated with more complications and thigh pain, and hence we are more now happy with the tapered stems. So this is again a very example of a stem where it's an ecolate. So it's an example of a proximally coated stem. So this is an important to template our femoral side also, because we have to set the offset for this, whether it's a standard offset or a high offset. One is required for us. And the proximal area of this stem, as we see, is wedge shaped. And the metaphyseal bone between the greater and the lesser trochanter is also a wedge shaped. So a wedge gets into a wedge and they fit well. And that is very important in the survivorship and the results and osteointegration, which happens in uncemented stems. And this wedge inside a wedge fit gives a good rotational stability also for this uncemented stems. Now, a point to be noted about the corail stem, which is slightly different from the other type of fully coated stems. The reason for which is the corail low profile taper design, although it is a fully coated hydroxyapatite stem, it has got some advantages, and which we all have to understand, that corail does not depend on fitting distally. So it is basically a stem where the canal fitting is not desired distally. We don't aim at desiring at fit the corail stem distally. And this X-ray shows that this is the amount of gap which is required whenever we are sizing our corail. And compared to this high profile metaphysodiphyseal fully coated stem, which is very tight all and all through, the low profile, the corail should not fit into the distal part. So very important point in DORS, a type of femur where we have a very tight medullary canal. So this is very important for us to understand. In such situations, whenever we are using corail, we have to be very sure that we have not, again, having a metaphysodiphyseal mismatch here, because the corail can get easily fixed or fitted distally, and yet it is loose on the proximal part. Hence, we have to prepare these Dore types of femur where the canal is reamed and it is made so that widened enough so that we have a proximal fit, and the distal part is only a fill, it's not a fit. So before we go for the revision type of stems which are required in a primary total hip replacement, a note about the dysplastic hips. Now here in dysplastic hips, we have the anatomy which is distort. We have the shallow cups. The necks are also not, the anteversion of the femoral neck is also most of the time here the acetabulum are retroverted and the femoral neck is anteverted. The canals are thin. So here we have an option which is this is a type of a stem which we call SROM. In this SROM, this is again, there is a metaphyseal sleeve here which fits into the proximal wedge of the trochanter, and there is this neck part is independent of this fixation. Hence, we can adjust the version of the femoral component in these type of cases, in cases of dysplastic hips, which we should be again aware of. Now, coming to a very common situation in our country where we have failure of this type of and multiple surgeries. So here in this particular type of situation, the proximal fit which we are discussing, the wedge, is not there anymore, and the quality of good bone is there, or as we see in this picture, it is hardly present there in the metaphyseal bone. So here in these cases, we have to rely on a distal fit. Now the distal part, that is the beyond the proximal to the trochanteric area, femur is a cone, and hence we should use a cone. Putting a cone inside a cone will give us a good fit. So here the primary fixation area of the, as it is compromised, so we have to prepare the femur like a cone, and hence we have to prepare a we have to choose a implant which is a cone, which has a cone, and the mother of all these revision stems is a Wagner stem, and which are very ideal for these situations where again here the fit is on the distal part. And these fins which we have in this Wagner stem are very good. They give excellent rotational stability, immediate rotational stability, and they have got very, very good long-term results in the registered data, and they hardly have any complications in the event of breakage of these stems. So a note about the solution stem, which is slightly different from the Wagner cone. Now, Wagner stem is a cone, whereas a solution which we use is a cylinder. So that is very important for us to understand. And titanium in Wagner is titanium. And because it is a titanium, the modulus of elasticity is very similar to bone, and it has definite advantage, whereas cobalt chromium, the solution is a cobalt chromium alloy, and hence there are some reports of breakage of these solution stems which are less than a particular size. So, and the Wagner stems are grid plasted, whereas these stems are hydroxyapatite. The solution stems are fully coated hydroxyapatite coated, and the solution does not give us good rotational stability because these are cylinders, whereas the fins of the Wagner comb gives us excellent stability, and these are easy to prepare. Now here we come to a situation where we do a primary total hip replacement, but this is beyond a particular surgery like a hemiarthroplasty or a lot of implants where there is a blowing out of the proximal metaphyseal area. Then this blowing out of the proximal metaphyseal area warrants us to use a modular type of stem. And there are stems where, like this particular type of stem, which is redapt stem, which comes from a particular company. Here we have a modularity, and we can have distal proximal fit, which is independent of the distal fit. And even if the proximal diaphyseal area is blown out or ballooned out, we can use this type of modular stems to fill in those proximal medullary canal, and that is independent of the distal filling off by a fitting by the standard cone. And then we come to a situation where we have a tumor and we have to, and arthritis of the hip, where we have to do away with the proximal femur, the wedge, and also the proximal part of the femur, the diaphysis, which is displaced, which has gone because of the tumor. There is destruction of that. So in such situations, we have absolutely distal fitting stems, and this is a stem which we call as the reef stem. And this has also got distal locking screw bolts, which to give us immediate rotational stability. And this is how the entire the stem looks like, which is a fully coated one. And here the entire thing lies naked here, whereas we can use fibular bone grafts and all to attach this part of the proximal femur during our reconstructions. But in this particular case, it's being a tumor, we have to resect the entire proximal femur. And again, the custom mega prosthesis, they have a role in tumors and even pseudotumors and even non-tumorous conditions, like when we are dealing with defects or problems which are gross on the proximal part of the femur. So that's all I wanted to tell. And thank you for the attention, and thank you for giving me this opportunity to be a part of this elite course.
Thank you, Dr. Smarajit. That was an excellent exposition of different variety of stem, and you have rightly showed the indications, and it's a great learning points are there, and most of our upcoming arthroplasty surgeons would be benefited by it. Is there any questions at this point of time from the audience?
Yes, sir.
Yeah.
This is Dr. Nirmal from Ranchi, Jharkhand, sir.
Yeah.
Definitely a very good topic which you have covered, because this is something which I feel has always been neglected and we talked less about. So I'd like to ask a couple of questions, if time permits. The first one would be, sir, and that's to all the panelists, in fact.
Yeah.
How do you deal with short female or with, especially in ladies, with excessive bowing? I'm talking about, sir, cemented stems. And why I'm asking this question is, like I have come across one case where I didn't do proper planning and templating, and I landed up using CDH stem. So if you could just share your views about CDH stem in particular, and how do you deal with this kind of situations?
Yeah, Dr. Smarajit.
Yeah, it's an absolutely important point. So that is what, when we started with the discussion, we are very happy with the cemented stems, and we should try to like use the benefits of a cemented stem in most of our cases. And it is always better to have the backup of a cemented stem in all the cases which we are doing, and the long stems and the short stems and the CDH stems which you told. And that's the best way where we can deal with. And the most important thing about cemented stems is that even if we are using modular stems or uncemented stems, the amount of modularity which we are trying to increase by using uncemented stem is not a very good idea in terms of corrosion, in terms of typology, in terms of wear characteristics, development of pseudotumors. So if we are happy with a particular of our technique of cementing, and we are very good in cementing, I think there is no harm, especially for the femoral side, to stick on the cemented stems. And most of the time, without going for fancy uncemented options, we can, and again, it's a price, and the price is also a constraint for most of our patients. And it's not only price, it is even the longevity of the prosthesis. So I would definitely prefer a CDH stem, dysplastic stem, compared to a SROM type of stem, unless there is gross dysplasia, unless there is gross mismatch, unless we have to use that amount of modularity for doing a primary total hip replacement. And all these uncemented things, stems in both in total hip replacement and the total hip replacement, the concepts come to us in using them in the primary setting is because after we have done the revision settings. So once we have seen the results of the uncemented stems and in even total hip and total hip replacement in uncemented revisions, I mean in the revision scenarios, then we have come back and trying to use the uncemented options in a primary setting. Whereas, as you told, the cemented stems, I think they are the gold standard, and they are to be explored, and they are to be in the back table for all of our cases. And that is where it builds out for us in most of our situations. Anything else?
Thank you, Smarajit, what I would suggest that, before the surgery, you plan your x-rays well. If you fail to plan, you plan to fail. It is told like that. So at least you should have a proper size of the x-ray. If you do not have a, reduced size x-ray or something like that, then you have to multiply what is the magnification factor and see at the isthmus level, what is the diameter of the medullary canal there. And if the diameter is small enough, which you are feeling that untable, it may give rise to problem. Always keep the reamers ready, your flexible reamers, your canal reamers ready, and always keep CDH stem at the standby. The problem with the CDH stem that it will adjust the canal diameter, but your offset will be less. Then you have to put, you have to increase your offset. When you're increasing the offset by putting a longer head, then your limb length increases. So all this jugglery you have to do and think of before surgery while doing the planning. And of course, in Corel also there is size 6 stem is available. But please remember, do not use size 6 stem when the patient's weight is more than 60-70 kilo, because that stem is likely to break and that is not recommended by the manufacturer. So whenever using smaller uncemented stems, remember that patient should not be overweight. So with a permissible weight, you can use uncemented, smaller stem, or else better to go for a cemented CDH stem. And as you know, that cemented stem or stems have done, much better compared to cemented cuffs. So if you have done a good cementing, it will have a good long-term outcome. Any other questions? We are running a little short of time. If you have any question quickly.
Just taking the thing further, what Mohanty sir said, what's your take regarding high offset designs, high offset stems?
Yes, Maharaj, the high offset stems.
Yeah, high offset stems, again, that's what, like, it is important. We don't have that particular option in Corail. So that's a problem with Corail.
It is available now. Smarajit, it is available. High offset stems. It's available now. Yeah, in our country.
So it has come now. So that is what we have to be very sure in templating, which again tells us exactly what type of stems which are used. And whenever we are considering about the combined length or combined offset and combined version, the three important principles of modern day total hip replacement, we have to be very sure about our preoperative planning in these cases. And we have to execute that in the intraoperative setting by different techniques. I don't think we are dealing with that right now. Sometime later we can tell.
Yeah, yeah. While doing a primary hip, you have to restore the offset in three directions. Your horizontal offset, your vertical offset, and your anterior offset, or what is known as anti-version. If there are the three directions X, Y, Z axis, you have restored the center of rotation of the hip. That means you have restored the biomechanics of the hip, properly. That will give you a good long-term outcome. In a situation where you see the abductors are lax, or there is, their offset is less, but you are getting good limb length discrepancy, there is no limb length discrepancy, you have restored the limb length, or vertical offset is all right, but your abductors are lax and the hip is easily dislocatable. There you can use a high offset stem. Usually most of the systems now, the high offset stems are available +4, that is offset is +4. So the advantage of offset stems that you can achieve stability of the hip without impingement, without increasing the limb length discrepancy. So if you find there is some kind of impingement in external rotation or internal rotation or superiorly in abduction during the trial reduction, then you can increase the offset, use a high offset stem that will prevent the impingement and prevent the dislocation without affecting the limb length. That is the advantage of high offset stems. The only disadvantage of high offset stems that it may cause an increased wear, but that has to be weighed against your stability of the hip.
One more question. That's regarding, like, we always keep talking about in case of TKR, tibia first or femur first. But why do we want to talk about like femur first? In case of THR, I mean, do you have can you share your experiences? Like, how far do you find it practical or in fact useful to do the femur first and then go for acetabulum? Especially in uncemented. Uncemented.
Yeah, I understood your question. In fact, Professor Larry Durr, who is no more now amongst us, is a lovable man and he just passed away last month. Professor Larry Durr has taken out, he always does the femur fast, and now some of the Indian surgeons, they have started doing femur fast. The advantage is that you cannot adjust the version much on the femoral side. The femoral component, it fits in the proximal anatomy of the femoral component. So they do the femur first and then the acetabulum so that they can adjust the combined, anti-version there. So that is a good option actually. If you can do that in uncemented cases, you can do the femur first, then do the acetabulum and adjust the acetabular version according to femoral side version, so that the combined anti-version comes to around 35 to 40 degrees. I think we will stop the discussion here. We can discuss it further. Doctor, and we'll go forward because we are running really shortage of time. We have two more lectures.
Can I ask the last question, sir?
Quickly, just one sentence.
Sure, sir. That's a very short question. What is the legality of mix and match? Like, as you have been saying, sir, the whole talk was revolving around we have to go for the modularity and adjust the things according to the case need, rather than trying to fit the same thing in all the cases. So what is the legality of mix and match? If you're using different implants, the same patient, I mean, do you have any legal issues?
Yeah. No, there is no legal issues. You just must remember that the particular company cup, if you have to use their liner. And on the stem size, if you use a particular company stem, then you have to use their head, because that you cannot mix and match. That will lead to increased wear. But what we have done, we have used a particular company cup, but different company stem. That is permissible. There is no legality involved, because that sometimes mix and match you have to do. But never ever use a cup and liner of different companies or stem and head from different companies. Okay. So femoral component entirely along with the head can be one company, and on the acetabular side you can use one company. That is okay. That is permissible. Okay, I think we have to go ahead with the next lecture. Thank you very much for bringing out these questions. Our next speaker is Dr. Rajiv Sharma. He's a senior consultant orthoplastic surgeon from Mulchand Medicity, New Delhi. And also he is the president-elect of Indian Orthoplasty Association. He'll be taking over from me in November this year. And he's going to focus on mega tumor prosthesis. Dr. Rajesh Sharma, over you too, please.
Thank you, Shubhranshu. Thank you, Dr. Meena. Thank you, IOA committee, to organize this meeting, which is very interesting in this post-COVID time. And gradually we are limping back to our academic activities. My topic that has been given to me today is the mega tumor prosthesis, and I'll be discussing some few cases of the total femur replacement as well. Extensive bone loss for any reason, the mega tumor prosthesis can be used. It could be because there are bone tumors. It could be because of cases of the treated and healed infections with extensive bone loss, or bone loss while you are doing the prosthesis extraction, usually the cementless, like the solution stem, which Dr. Patnaik has very rightly mentioned in the last talk. Advantages of mega prosthesis prosthetic reconstruction is that you have an early stability, you have a rapid restoration of function, you have a good long-term functional outcomes. It's a high acceptance in patients and emotional satisfaction that you are not losing the length of the limb. A brief history, it has been used first time in 1965 by Vitalium endoprosthesis, then after in 1977, and now we have a much advanced prosthetic replacement implants available, almost from all the companies. But we must remember that it has a 5 to 10 times higher complication rate in as compared to the routine joint arthroplasties. Mechanical failures such as breakage or fracture of the implant is a possibility. Instability due to wear, or biological failures like infection, aseptic loosening, wound, or soft tissue breakdowns. Prosthetic related complications are infections, aseptic loosening, wear of the joint components, breakage of the prosthesis, fatigue fractures, and dislocations, which are very important to be seen. Although patients with a bone tumor usually required limb amputation in the past, but currently the limb salvage surgery and mega prosthetic or allograft reconstruction can be performed in almost 80 to 85% cases. Preoperative workup is important, radiological evaluation, bone scan, biopsy, you have to be sure about it. And most important is the support of the oncologist if you are dealing with the tumor situation. Procedure is before surgery, chemotherapy or radiation. Remaining tumor is rejected with the margin. Gap formed is reconstructed, equalizing the limb length. Prosthetic implants may be necessary when the joint requires reconstruction. The muscles and tendons are attached to the implant, and surgical site is closed in a normal way with the healthy soft tissues. We'll present you some cases which will make the things very clear. Like this young patient, 24 years, who had a bilateral femur done elsewhere, and we see that the bilateral if you see the bilateral femur replacement on the right side, you see expansile lytic lesion, which is not only in the proximal femur but is also in the middle part of the femur. And if you see the lateral view, you will see that it is extending right up to the femoral condyles. So in such a situation, only doing a reconstruction with a bone grafts and a large prosthesis is not a good option. So we prefer to do in this patient total femur replacement. And you see that in this the whole long cut is given. The tumor bone is removed. What you see here, carefully ensuring that the sciatic nerve and the femoral artery are managed well, and soft tissues are the normal soft tissues remain, and that's how you see the extracted removed femur along with the tumor mass, which you see in this proximal portion, and the hip implant. Then this is meshed with the trial prosthesis, what you see here. And then the meshed trial prosthesis is, and this can equalize the leg length very, very accurately. And you see here, now you see that and of course we are using the constrained liner because constraint liner is a very easy way. You see that it is fixed well now, and these roughened, the coated proximal implant, it takes very well the soft tissues, which you will see. That's how the femur is after the implantation. You can see that the femur is well stable on both proximal as well as distal side, and the soft tissues will be covering up like this. And that's what you see, that the X-ray, proximally you see the constraint liner, distally you see the rotating platform, total knee, a large incision, and patient in a comfortable position. 2 weeks post-operative, you can make the patient stand and walk almost the next day. 3 years post-operative, and you see the 4 years after total femur replacement on the right side. The patient does have a slight limp, which he can take care of the stick, which is very easy to manage. But probably this is a much better than doing the disarticulation or any other implantation. The other tumor processes, we should remember that the infection could be a major possibility, and that's what we'll show you some of the cases. Infections most often present within 2 years post-operatively. Approximately 70% of the post-operative infections presenting within the first year of the surgery. You see this patient who had a prosthesis done elsewhere, and you see that the prosthesis had failed. It was rotating at one of the juncture, which we'll see in next slides. This was the pre-operative X-ray. You see the failure was at this hinge, this junction. So we removed the prosthesis. We always send the implant wash, and surprisingly, the implant wash, as the literature also accepts, is the most reliable sample for seeing the bacterial growth. And this patient, the implant wash did show the bacteria, Staphylococcus, and that's what the extensive debridement and IV antibiotics for a period of 6 weeks and oral antibiotics for a period of another 6 weeks was given to this patient. And what we see now, this patient at 3 years, able to walk without any support, able to sit comfortably. And we'll see that how he's able to sit with the prosthesis with almost no support, and he has a good function. As I just mentioned, that we gave the IV antibiotics and oral antibiotics in this case, and this patient at 4 years. There is no recurrence of infection in this case. And we have many cases where the implant wash had shown the infection, which were treated well with the antibiotics, and it never recurred in most of the cases. See, the sitting of the patient is fairly comfortable. Another case I'll show what Dr. Patnaik was talking about, the solution stem, which is broken in this particular case. And this becomes a nightmare because the solution stem takes up so well with the host bone that removing the broken stem is a big challenge. And that's what we see here in this patient. It was almost the proximal bone was almost lost in removing it, and that's why we use the tumor prosthesis in this patient. And you see the way patient is walking at 5 years post-operative. Of course, he has to use the support for walking, but it's much easily doable. Last of the case where you see the dysplastic hip, which were treated badly, the proximal shattered femur with infection. It was treated in 2 stages, the cement block with the IV antibiotics. After the cure of the infection, the tumor prosthesis was used, and patient did well. I'll finish up my talk with the concluding that principles of surgery have to be followed very meticulously. Oncology support is important if we are dealing with a cancerous situation, a tumorous situation, and high infection rate must always be remembered. So that's why you have to be more careful, extra careful in these cases, because the infection will ruin all the support that you have given, an excellent surgery that you have done. Thank you very much, Dr. Mohanty.
Thank you. Dr. Rajiv. That was an excellent talk about all these difficult cases. You know, it looks so simple when somebody talks like Dr. Rajiv, but it is so difficult to handle it on the table that one who does knows. Any questions for Dr. Rajiv?
Sir, one question.
Yeah.
Audible, sir?
Yeah.
Yes.
Sir, actually, I am Dr. Jyoti Prakash, Ortho Kolkata. Sir, I want to ask regarding the reconstruction. Suppose the tumor case, what you have seen in the first case,
Yeah.
do you use mesh regularly? If yes, up to how much length? Or when you have got sufficient soft tissue, just cover with this one only and don't use the mesh?
Mostly you are able to save the sufficient soft tissues, and that should be your endeavor, that you remove only the normal margin of the tissues with the tumor. And this is what our tumor surgeons do. And then most of the time they are able to give enough coverage. I think that if you have if you don't have a soft tissue cover available after you have removed the tumor, then probably a tumor process also will not be the right choice in these cases. What do you say, Dr. Mohanty?
Yeah, that is correct. Actually, I wanted to ask you regarding, how do you restore the abductor function?
Yeah.
That is the most important group of muscles.
Yeah.
In a revision situation, like you told about tumor condition, suppose in case of gross osteolysis due to metal on metal reaction, abductors are lost. And how do you restore the abductor function there in those kind of cases?
I think that's very right, and that's the biggest challenge, because these patients they have the abductors are always at risk, and that's why where you see that the abductors are severely at risk, it's better to use a constrained liner than a normal liner to prevent the dislocation. And you see that all these patients they do have some amount of gluteal lurch. The reason is what you just explained. But the only thing that is in our hand is that we try to protect the abductor mechanism as much possible and suture it back very well. Like you see in the boy who had a revision of the tumor prosthesis, he does not have much of the abductor lurch, and the reason that abductors have been sutured very well. And surprisingly, to a tumor prosthesis, the tissues, the muscles, they take up very well. It's not what we expect, that probably the muscles will not function. They function very well. And I think one of the very important aspect in these surgeries is your tumor surgeon, because he will help you in excising the tumor in a meticulous way. I personally prefer that you must involve a tumor surgeon, oncosurgeon with you, with whom you are comfortable.
And have you used dual mobility hips in this kind of, which is now the new baby in the armamentarium?
Yes, I think that's very right. The dual mobility cups are very useful, especially in these cases where we are expecting that the gluteal lurch will be a problem. The abductor mechanism is not very strong and it is little attenuated. Probably the dual mobility cup is the only choice to prevent the future dislocations. So your option is between the dual mobility cup and the constrained liner.
Any other questions from the auditorium?
You are using total femur replacement, where in the knee it is a constrained rotating hinge.
Right.
On the other end, you are using a constrained liner.
Sir, can you please introduce yourself?
I am Dr. Sankarlingam from Chennai.
Thank you.
I am a main assistant once upon a time to Professor Mailvagunan, who is a known orthopedic oncologist.
Yes, he has done a lot of oncology work. Yes.
Thank you, sir, for introduction. Can you please ask your questions?
So the question here is, you are using a constrained rotating hinge below in the knee, whereas you are putting a constrained liner in the hip spot.
Right.
Anytime any failure on the hip side or knee side occurred because both are constrained.
Correct. In our short follow-up, we have not seen any failure. Because these patients have relatively lesser activity. And the failure that is possible is of the breakage of the stem. That is more common and a bigger challenge because these patients are active. So in first 5 years, I have seen the two stems which had broken. And the reason for that, when we try to elaborate our own cases, we found that if the stem is less than 10 millimeter in size, then it has more chances of breakage. If the patient's activity is more, like one of the boy started playing because he felt that almost like normal. So I think the more than the wear on the hip side or the knee side, my personal experience is that the breakage of stem is a bigger challenge. So we make sure that now that we use the stem, the prosthesis stem should at least be 10 millimeter if possible.
Thank you.
And it should be very well cemented because that is where the whole strength is coming from. So I think and the soft tissue balancing also is equally important.
Thank you. Thank you, Dr. Rajiv. If there are no more questions, we can move at the next lecture. May I request all the audience, so you can keep your questions ready after the final lecture, then we can have a general discussion about all the lectures or any other question pertaining to arthroplasty. Now I have the honor and pleasure of inviting Professor Amit Tolat from Kent, United Kingdom. He's the consultant orthopedic surgeon specializing in shoulder and hand surgery in Medway Hospital Trust. And Dr. Amit Tolat is the treasurer of British Indian Orthopedic Surgeons now, and he's also the president-elect for British Indian Orthopedic Society. And BIOS has been instrumental enough to train Indian orthopedic surgeons. They have a senior fellowship, they have a junior fellowship, less than 45, more than 45 years. And may I request all our members of Indian Orthopedic Association to apply this, take the advantage of this fellowship. It's an excellent fellowship, fully sponsored, and they really make it very interesting. I have attended once the year before. Now it's early morning in UK, and we are really indebted to Professor Tolat for joining here and deliberating about reverse shoulder arthroplasty, which is a hot cake in India, and we are seeing also many failures of this and how to get it right. He's going to focus on it. Professor Tolat, over to you, please.
Hello, good morning. Good morning, everybody, and good morning, Shubhranshu. Am I coming across okay to all of you? I hope everybody can hear
looks
me.
Fine.
Looks fine. Excellent. Excellent. So I'm absolutely delighted and honored to be able to talk in this very eminent group of people. I'm also wary that I'm within a group of knee and hip surgeons talking about the shoulder. So many thanks to Dr. Mohanty and Dr. Sharma for having asked me to talk on the shoulder. I think this, as Shubhranshu mentioned, is a very hot topic in all over the world, really. And 10 minutes is like a whirlwind to go through. But let's see what we can do. And hopefully there'll be quite a lot of things to follow or discussions. The routine disclaimer. So I think I want to address a little bit of this with the residents, trainees, and the established surgeons. We have to understand that the problem with cuff tear is the unopposed deltoid, which causes shearing forces across the glenoid. And this is a unique and effective solution where you reverse the ball in the socket, you lower the lever arm, and by that token, you lower the center of rotation. Simultaneously, you medialize it. So this makes it mechanically very much advantageous. And this is a thing for which we have to thank Professor Gramont, who described this in 1985. People thought he was a little bit crazy. This is one of his original diagrams of the reverse shoulder. And then between 1985 and 1993, the French went on implanting a lot of these and they kept it to themselves. But then it's now out in the whole world, and we are seeing huge numbers all over the Western world in particular, and possibly also in India. And this is the main indication, the cuff tear arthritis, where the head is superiorly riding, you get acromiohumeral arthritis, and dysfunction. On the right-hand side, you can see large irreparable tears with fatty infiltration. And in the older patient, it's really quite difficult to offer them anything else apart from superior capsular reconstruction, which sometimes is inappropriate if arthritis is slowly developing. And of course, the problem with cuff tear is that it's a spectrum. The cuff tear arthritis lies in the center. If you go to the left, you get the more stable arthritis form, and you go to the right, it's much more unstable. So there's a sequence of cuff failure, and you can get anterior superior escape, which makes it very unstable. And then there is with and without arthritis of the glenohumeral joint. So this is a chap I implanted many years ago, and he came to see me for his other shoulder. And he's absolutely delighted with the RSA I did 12 years ago when he was 72. And you can see that some of these movements I hadn't expected. But the question really is, if you look at the X-ray, it looks very good, but how can I get this outcome every time? So if you look at the complications of stemmed RSA, the historical ones relate to hematoma and infection. It's a large area of resection, and that risk is high. Scapular notching, which became a very important part of the first generation problems. So up to 43% of these, they can cause loosening of the glenoid and failure. Fracture was noted, instability and dissociation, which yet remains a problem, and breakage of screws. The problem with the reverse shoulder is that if you really get it wrong, the salvage options are very limited, and you're going to have very great risks of further surgery and how to manage bone stock loss. So 5 to 7 years ago, the UK government started this initiative of Get It Right First Time, GIRFT. And I think the purpose of this was to ensure that, first of all, the correct prosthesis is chosen, to decide and to ensure that the correct surgeon operates in the right facility. And of course, there is the correct patient selection. So we'll go through, I thought I'll deal with this in this sort of format, but of course, we can look at the importance of the metaglede and the glenosphere and the variations, the humeral neck shaft angle, the surgical issues and the surgeon issues, from the learning curve and the correct person to do this, to fixation, management of defect, particularly in the glenoid, and tensioning. And of course, we know that there are a variety of patient issues. Loading of the arm is absolutely a dangerous thing in the reverse shoulder. Patients may or may not be completely compliant, and comorbidities such as diabetes, for example, is a high risk for infection. So if you look at the prosthetic design, the humeral neck shaft angle has the largest effect on inferior scapular impingement, or notching as it is called, followed by the glenosphere position. Gutierrez found that out many years ago. And the one on the left shows the 170-degree Grammont cut, which is most stable, but with the highest incidence of notching, because as you can see, it's quite close to the scapular neck. The one on the right shows the 130-degree cut, which is anatomic. There is much less notching because of its angle, and it is a universal platform, but it is much less stable, and it impacts the central rotation as you shift it out a bit more laterally. The 150 is the middle angle, or the halfway house, if you want to put it. Positioning of the glenoid component is quite important, and Nifella found out that if you distalize the glenosphere by 5 to 7 millimeters, you would significantly improve the abduction and adduction angle. I'll also point out that the tilting of the glenosphere downwards by 10 to 15 degrees is also an important part of this, because it allows more congruency, more stability, and far less risk of notching. The third part of the equation, and with all the hip and knee surgeons, this is with the hip surgeons in particular, this is a known concept of offset. And we look at this offset now again in the shoulder. So Whereas the Cremor prosthesis was associated with a medial glenoid and a medial humerus, we are now looking at lateralization of the glenoid and lateralization of the humeral stem. Lateralization is achieved through a bio-RSA or by augments, but it aims to improve your lever arm and range of movement and reduces notching and enhances stability. And Pascal Boileau, in a recent journal article, established that as well. So when we come to the surgeon factors, I think the two most important things really are that, first of all, as we have evolved with the RSA, we have learned much more of the biomechanics. And of course, like everybody else, a surgeon has his own learning curve. When I first started, we were using the 150 cut short stem medialized humerus in 2006. And for a few years, we carried on. This is the typical Gremor type prosthesis, medialized components. And then after that, we moved to the anatomic platform with the lateralized humerus in 2009. So here, the big plastic gives you a 155 angle effectively, and that brings it closer to the more stable Gremor platform. So between 2006 and 2009, we did about 6 a year, 18. But then from 2009 to recent data, I have done about 230 of the anatomic platform. And this is an important curve because we've learned so much along the way. What I'm going to do is take you through a standard primary reverse TSA, and then we can look at all these factors, particularly with the glenoid side. So I use a beach chair position. It's important to support the scapula. I use a deltopectoral, but the Sperling modified incision gives great access to the glenoid. You must take out at least 20 millimeters of the head. Otherwise, you'll struggle, because remember that these heads are superiorly subluxated or lying very high, and you're bringing them 5 to 6 centimeters down to the glenoid level. So it's important to resect enough head. I use an anatomic cut routinely, and you need to, of course, make sure the metaphysis is preserved on the humeral side. I use 20 degrees of retroversion, but it could be anything between 20 to 40. I find 20 is suitable, and John Sperling uses the same. I follow that, and there's never been a problem. The glenoid exposure is really very critical. You do need to do lots of releases. You need to make sure that you can see and access and get an assistant, certainly, to help you. It's not enough just to use specialist instruments. The normal lineup is to mark it up on the glenoid face, and what you need to do is to make sure that you're about 10 to 12 millimeters from the inferior pole for the entry point. By and large, you'll be fine with that. And what we use currently is a base plate fixation with 4 peripheral screws, 1 central screw, with a standard offset, which is a small augment superiorly and a caudal tilt. A 36 glenosphere is generally adequate, and it's quite a good idea to offset it inferiorly, knowing that distalizing by 2 to 5 millimeters is quite a good idea. But mind you, it does make reduction quite difficult sometimes, and that has to be borne in mind. And I think the biggest issue now presenting shoulder surgeons and tackling it over the last 5 to 10 years is avoiding glenoid malposition. Even now, the risk is up to 48%. Recent article in the Journal of Elbow Shoulder Surgery, November 2020. So the first part is the work of Gilles Walsh, where you recognize the patterns of bone loss in the glenoid. Over here, I'll say the B2 and the C are the most important critical one, where you see this double concave effect in the glenoid in the B2, and the C where it is retroverted more than 25 degrees. And one must have a strategy for bone defect. So here we look that if, for example, you had a C glenoid like this figure, and you were to place the base plate onto that native glenoid without an augment or a bone graft, you'd probably be exiting the neck of the glenoid, and that would be really bad. So what you need to do is to make sure that you have a neutral position of the glenoid and augment it either with a bone graft. Similarly, the same thing applies when there's superior bone loss. You need to put either an augment or a bone graft. The preferences in the Mayo Clinic are to use bone graft, but now a lot of augments have come into design of prosthesis, which aids in that measure. So this is a 79-year-old male patient with a C glenoid, and you can see the glenoid is actually retroverted posteriorly by more than 20-25 degrees. And the solution for that really is to put a structural humeral head wedge graft. So the humeral head is available. You take a cutout of this and support the glenoid and put your base plate on it so it's more centralized, and it will avoid this malposition problem. So going back to the primary, I use a mini stem. You can use all variants of stem, but the mini stem and an uncemented one is a standard in 20 retroversion, and you put on your trial metaphysis. So here you can see that the poly is quite big in this anatomic reverse shoulder. And what you're looking for as a reduction is a nice smooth reduction with a single finger that can be inserted at the time of it. In fact, it must just pinch your finger, and you'll find that it gives excellent range of movement. This is the type of X-ray you want to look at after surgery. And here I will point out something that we are increasingly discovering or monitoring. So if you look at the line drawn along the scapula and project it through the glenosphere, you take a perpendicular to that and then intersect it with the bipolar line, which is running from the superior to the inferior pole of the observed glenosphere. That angle that forms is called the RSA angle. If your RSA angle is less than 5 degrees, it means that you're going to get a high degree of congruence. You've got the glenoid lined up properly in the tilt and the alignment plane. Of course, that does not exclude where the glenoid base plate is lying on the coronal plane, but this at least is an excellent sign that you will have great congruency and stability and very good range of motion. And we have seen this whenever this is reproduced on a post-operative X-ray, the patient does very well. And I think, like all surgeons, we wouldn't like to have mistakes, but I feel that this is one of the things that we all have to accept, that ultimately one must learn from mistakes. And look at this. This is a 75-year-old lady. She had a reverse TSA implanted by me some years ago. You can see one thing on this X-ray picture, and that is that the glenosphere is tilted a bit superiorly. And she had a reduction first, a manipulative reduction, but it came out very quickly thereafter, and we decided she really needs to go to theater and have a look at it. And when you look at the axial view, one of the things that you notice is that where is the screws used for the base plate fixation? They're exiting out. This is the scapular body, and the screws are going up posteriorly. So she's actually retroverted quite a lot, and she's tilted up, which creates quite a lot of point loading. The stem looks absolutely fine. When I opened it to revise it, I found that there was this typical metallosis, the dreaded sign, and you can see that the plastic is completely worn out on the medial side when this is actually the maximum size of the poly. And this is obviously not a very good thing. She needed a full kit revision to settle it. So I think the lesson learned really is that you must size and target the glenoid, taking into account the wear patterns, using either augments or grafting as required, particularly in the B2 and the C wear. You must avoid any superior tilt of the glenosphere. And what you want is a caudal tilt of 0 to 15 degrees. In this case, the patient was also, unfortunately, not totally compliant and was loading it, and you must not allow any axial loading by the patient. This is another one. This was an 87-year-old lady with a severe cuff tear arthritis. And we went ahead, this was done by one of my colleagues. The surgeon actually mentioned that it was a very tight reduction and he had great difficulty with the releases. But 3 months after implantation, without any significant trauma, she presented with the whole metaclete pulled out. And this is another point, that if you are going to be reducing these heads by implanting prosthesis from where they are lying so far higher than the plane where you want to restore the cora, you've got to understand that the soft tissues might be at great risk and you're going to have great problems going down the line. And this is something we yet see, unfortunately, an arthritic shoulder in a relatively young man who was treated by a cemented hemiarthroplasty. The surgeon resected all the tuberosities, and there's no surprise that with the cuff not existing, there is virtually no movement and he's in severe pain. So we had to take him to theater and revise him to a reverse TSA. And for this, an osteotomy of the humerus works very well. A sagittal osteotomy is a very good way of taking out these very well cemented stems. And one of the things that I found very useful is to do a cement in cement revision. There is very good evidence now that a cement in cement revision is very successful. Recent papers support that. This was him doing very well at 2 years, and everything looks excellent at this point of time, at least. But don't go after the cement, otherwise you'll be there all day in theater. A cement in cement revision is a very good option. And where are we as we move ahead? I think we're going more and more towards improving our positioning of the glenoid using patient-specific instrumentation. And the new kid on the block is the navigated glenoid. This was one of our first views we've done before the pandemic struck. And this is a Exactech Equinox navigated glenoid. It's a true navigated system, and Exactech promote it a lot by saying that this is the best way of not getting lost using a GPS marker, and you do put a marker on the coracoid process to help you. I personally don't know where we are going with it as yet, but certainly in complex cases, this would be very useful, I think. So final thoughts. Reverse arthroplasty is a unique and effective solution for cuff tear arthropathy and also the elderly complex trauma, particularly non-reconstructible 4-part fractures, head fracture, dislocations after trauma. The new generation of prostheses that we have, they have addressed all the biomechanical deficiencies of the first generation, and we have superb outcomes with more than 10-year data. Our complication rates are now dropped to below 10%. But it's important to note that this is a learning curve for a surgeon. It should not be carried out by anybody apart from a fellowship trained surgeon in a center with adequate equipment and laminar flow. Thank you very much for having me on this show. This is where I work in Medway. We're on the coast, actually, in the southeast of England, not very far from Dover. It's pretty cold now out here, 1 degree this morning, as most of you might expect in this part of the world. We are called Charles Dickens Country and the Garden of England, and I would invite anybody who wish to come over. And certainly, as Shubhranshu mentioned, at BIOS, we are supporting a number of fellowships from India, and you would be most welcome to apply as I take over the presidency next year. I'd also like to use this opportunity to mention about our virtual conference on the 2nd and 3rd of July of this year. This is completely free to register, and we are going to have a feast of symposia, roundtable discussions through the virtual studio, obviously keynote talks and lectures. And I'd like to ask you to put it all in your diary. But once again, thank you very much, all of you.
Thank you, Amit. Very well.
Yeah.
Yes, very well explained. Difficult topic, and you rightly mentioned that hip and knee surgeons and the shoulder. Let us have some questions from the floor. I can see that on the mic, please.
Already there are people near the mic, so please go ahead with the question. Yes, sir.
I am Dr. Sankarlingam from Chennai. My question is, if RSA fails and revision also fails, is there any chance of arthro disease in those patients?
Well, this is something I really wouldn't want any patient to get into, but this is, almost an impossible thing to do when you've got a reverse shoulder in and then you've revised it. The issue really is what's the bone stock left over there. So I think the situations where this has developed, and I've seen a few cases, the better option has been to leave it with somewhat of a flail shoulder, because the patients probably also have enough of it and they don't want to have anything further carried out. I think arthrodesis would be very difficult to perform in those circumstances. But personally, I have no experience of it and I hope never to have to do this.
Thank you.
Well, that's right. Amit, do you use the scan or image at the time of the primary surgery? Because I think that putting the screws in the right direction is a very big challenge. It's not that easy as it looks.
Yes, you're absolutely right, Rajiv. The position of the glenoid at the time of surgery can often fool the surgeon into thinking they're placing it into the right place. And the position of the metaglean or your glenoid base plate obviously dictates where your glenosphere will go on, and thereby the ultimate alignment of your prosthesis. And that's the reason why it's important to do a complete preoperative analysis. You need a full set of x-rays, you need a CT scan and an MRI, and the axial sequences are important to assess. At the time of surgery, you have to be very wary of the position of the scapula. And that's why I talked about the support to the medial border. Otherwise, you will get rotation of the scapula and the position can suddenly alter without you realizing it. And this happened in our early numbers as well. Of course, we can use PSI, which is helpful in complex deformity, and now navigation or tracking of the live tracking during surgery would help you to ensure that you place it in the correct alignment. But I think it's a difficult problem. 45% of glenoids are yet malpositioned, not by huge amounts, but a little by some degrees in inclination or in their alignment.
Right. Dr. Shubhanshu?
Yeah, there is a question from the audience, I think. Yeah.
So going back to hip again, this is Dr. Nirmal from Ranchi, Jharkhand, sir. So regarding cemented bipolar or cemented THR stem with aseptic loosening, what's your call regarding revising it with again a cemented stem? I mean, how do you go for cement within cement? What's the approach basically?
I'll take that question. You know, there is a cement prosthesis interface and there is a cement bone interface. If you have an aseptic loosening where the cement prosthesis interface is affected, you can easily take out that stem. But you see the cement bone interface is quite intact. That means that there is a good micro interlock. So those are the cases you can do a cement in cement. So what you do after you take out the prosthesis, you have to do little burring of the cement in order to create a space for a narrow stem. There are special cement in cement prosthesis available with Exeter, you know, the very narrow stems. So there you do little burring, do a thorough lavage and make the cement rough, then mix another packet of new cement and put it inside and put your stem in. And there you give a desired degree of version. While doing a cement and cement is difficult to give a proper version unless you have burred out that much amount of cement in the anterior part of the femur. Okay, so there you give a desired degree of version and you can restore your vertical option and do. And it has got a good outcome also from the Exeter group. And in selected cases, it is a very very good procedure and with a less of hassle and less time consuming as well.
So one more question related to hip again. In case of failed osteosynthesis, especially with suppose DHS in situ, so how do you approach if you want to go for a cemented stem again?
Yeah, Dr. Rajiv, you want to take up that?
Thank you, Shubhanshu. The only way that if there was a cemented prosthesis before and you are revising a cemented prosthesis, how much of the cement, as Dr. Mohanty was talking about, that what is the cement bone interface? Now, to put a cementless prosthesis, you have to ensure that you scrape off, use the high-speed burr and various curates and osteotomes to ensure that the cement is removed. And that's why if you find that the cement is very strongly inter-attached with the host bone, then probably it's a better idea to do a cement in cement revision. If you want to do a cementless stem, you have to remove the cement significant amount. At least 2/3 of the cement should be removed. Then only you can use a cementless stem. What's your opinion, Shubhranshu, on this?
Yeah, you are correct, entirely correct. His second question actually was there that regarding the failed DHS. Then the problem while doing a cementing is that cement extrudes out through the screw holes as well as from the DHS hole. That is the problem. If you see the literature, people have described putting some small bone grafts there into the DHS holes and all these things. Actually, nothing usually works out. And usually what we put our thumb at the DHS hole itself. That is a big hole, so you can put the thumb or your assistant put that significant amount of cement come out through that DHS hole. Whereas the small holes, whatever little comes out, that is all right. You can just, after the cement sets, you can take a curved osteotome or something like that. You just take out that cement. That's all, and it serves the purpose. Don't have to worry about it. And always use a distal cement, like having restrictor or some kind of bone restrictor or something like that. One restrictor should be there, and you pressurize your cement well so that to achieve a good cement mantle all around the prosthesis. Now,
the one problem remains that the area left is very, very narrow, and what Shubhranshu was talking very, very rightly earlier, that you have to create this space. You have to burr out the sufficient amount of cement to fix up the revision processes.
Thank you.
Thank you, sir.
Now I have a question for Amit. We have a couple of minutes as well. Amit, I'm talking all for my Indian patients. If you see Indian patient, the glenoid is very small, and it's really difficult to put that glenoid component, which is given by the company, as Rajiv told, that how do you pass those screws and all these things, and it is to accommodate that component, even the smallest glenoid component, into a small Indian lady, it becomes difficult. What is your take on that, and how do you address that?
Yeah, so thanks, Shubhranshu. I think the issue of the glenoid is really well established in the sense that you can have different sizes of the glenoid. And as we move to the Asian patient, the Indian patient is likely to have very much smaller glenoids than the Western patient. But we see that again over there too, young, elderly ladies with very tiny glenoids. So a lot of the manufacturers have come out with a mini base plate. This mini base plate is about 25 millimeters. So the standard base plate was between 28 to 30, and they reduced the size to 25. What we found was that it was far better to use the mini base plate as a routine for all our glenoids, even though there would be a perimeter, because that would give us a slightly more better fixation rather than have an overhang. Yeah. But I think even the 25 millimeters for the Indian patient, and particularly small Indian patients, might be a problem. And there is a definite role for, what I think the lower limb surgeons described as the Japanese knee, for example, or the Asian knee. And similarly, they probably need to have the tiny glenoids. I do think that the sizes can go down even further. And we've been talking to them about taking it down to 22 millimeters. But of course, these are very big international companies. They seek their sort of thoughts from different sources and then decide whether it's commercially viable. I do think it is, not a great idea to implant a big base plate. So if you got a glenoid, which is very small, you put a glenoid which does not, a base plate which is overhanging by more than 2 to 3 millimeters, you're probably likely to seek failure. And the other problem is you might even break the glenoid intraoperatively. If you get a fracture of the glenoid, that's a complete disaster at the time of RSA, because the pilot hole is quite big. And It's like your heart is in your mouth if you got a small glenoid and you're trying to drill through. Thank you.
Thank you.
Yeah.
Thanks a lot.
If I can ask a last question, Shubhranshu?
Yeah, the last question, then we conclude, yeah.
Amit, the one problem is the small size of the glenoid. The other could be the osteoporosis. The very weak bones, that's what quite a few times you encounter, especially when you have a stiff shoulder, patient is not moving it enough. So that also induces more osteoporosis. What is your trick on these patients where the bone is not very strong?
Yes, Raji, that's absolutely right. I have a few rheumatoid patients where we have had great problems because there you obviously got the inflammatory background, which increases the osteoporosis. But with cuff tear arthritis, which is the primary indication, it's not a glenohumeral osteoarthritis where the bone stock's not so bad. You got an acromiohumeral arthritis. So the glenoid has been unloaded for a long period of time, if you want to put it that way. And therefore, osteopenia is very common. This is the reason why 4 perimeter screws are required, because you need to have as much of fixation as possible. The central screw is by and large not so vital. It's the perimeter screws, because we know that all the good bone lies in the perimeter, in the cortical cancellous junctions over there. So I think, yes, the fixation is a big problem. Cement is not a great idea, particularly in small bones. We know that in the experience in the upper limb, if you look at the hand and the wrist and so on and so forth, the evidence is that, cement is not a very good idea. But at times, I must admit, used a little bit of cement on the perimeter of the glenoid base plate, even though it's not meant to be done, just to improve fixation when you find that your screw fixation is not very good.
Thank you. Thank you, Professor Amit. That was a great talk and great discussion. And as you know, for the benefit of the delegates, I tell Indian Arthroplasty Association not only covers the hip and knee, though it covers 90 to 95% of hip and knee, but we do also encompass shoulder, elbow, as well as other joint arthroplasties. And Professor Amit Tolat has been kind enough to join as a guest speaker today, and this gala audience of Indian Orthopaedic Association conference at Jaipur. We thank you, and we are really grateful to you for joining early morning with 1 degree centigrade temperature out there. Now, let me conclude this session, because we are running really short of time, and we are really grateful to the organizers of IOACON, Professor R.C. Meena and Dr. Amit Sama, who is already there on the dais, so I can see there, for permitting us some extra 30 to 40 minutes to have a good discussion among the delegates. And I just received a message, the hall was entirely full and people were really listening to our session here. And we are really grateful to you, sirs, for permitting us to conduct the session yesterday as well as today. And we thank all the speakers of this session, starting from Dr. Ashish Singh, Dr. Mukesh Oswal, Dr. Mrinal Sharma, Dr. Parag Sancheti, Dr. Smarajit Patnaik, as well as my co-chairman, Dr. Rajiv Sam, our President-elect of Indian Arthroplasty Association. We thank you all, and we conclude the session and hand over the proceedings to Professor R.C. Meena and Dr. Amit Sama, please. Thank you very much.
Thank you, sir, Monty, sir. Thank you, Rajiv. Thank you, Amit. Thank you, Mrinal. So nice of you. I am happy to see Rajiv here. He is my contemporary when the AIMS senior residency interview was there. Assistant professor and senior residency interview was there.
Both fought for the same seat. They both fought for the
we
same
both
seat.
were for the same seat in 1989.
Now they are joining shoulder, rubbing shoulder.
Exactly.
To bring their respective association to a higher pedestal.
Mrinal is our lovely student from this institute, West Fellow of Dr. Bisal Kundanani. And Amit, of course, we are signing India and the UK. Great.
Thank you.
Thank you, Amit.
Thank you. I really enjoyed it.
And Parag is thanks to those who are not on the screen, off the screen, and abroad the country and across the world. I must congratulate all them. I thank them. They have spared their valuable time to make this session a memorable session in this dark, difficult period of COVID-19 where everybody is inside the house. But we are outside the house, out of the world. Thank you, everybody, sir. Thank you.
Thank you.
Thank you.
Thank you, sir. Thank you. Thank you so nice, sir. Thank you. Thank you.
Now I must call our next speaker, Dr. Vishal Kundnani, who is already raring to go. I was just asking him because the session went long. So I just asking him, Jara sabar to kar mera yaar, just be little patient. Jara saans to le dildar, take a deep breath. Vishal and his team, Rab ne bana di jodi.
Thank you. Thank you, Arun. Thank you, Asmina sir, and thank you, IOACON, for having me here. Again, on behalf of ASSI, we had a wonderful spine session here. And changing the gears from joint replacement to spine, it's not easy, because so far you have been playing with joints, joint replacement, the most intricate and the most attractive part of orthopedics. And now suddenly I'm bringing you to boring disc and back pain and leg pain and slip disc. Can I have my slides coming up, please? So slip disc surgery is probably one of the most commonest surgery today performed in spine. And I think every orthopedician at least sees minimum one patient a day of a patient of sciatica. And it not only makes the bulk of work for all established spine surgeons, but also it forms probably more than 50% bulk of orthopedic OPD practice also. And the good part is that more often than not, 90% of these patients do get better with whatever treatment I give. So when I say whatever treatment we give, it just brings out the mystery or the dilemma or the problem of plenty of options in treating prolapse intervertebral disc disease. And we often worry and wonder, what is that guru mantra that makes 100% success in slip disc patients? What is it, that one thing that can help us to get 100% success in treating prolapse intervertebral disc? I hope that at the end of these slides, I'm able to come up with some consensus grounds to establish the G of Guru Mantra there. Degenerative disc prolapse, it has been a mystery since the evolution of it. Degeneration is an ongoing process. The unfortunate part is that the presentation is so varied that sometimes a patient may present with a similar looking radiology with back pain, or he may be asymptomatic. So for example, an axial picture like this on an MRI, you cannot really predict whether this patient will be at some moment asymptomatic. Sometimes he may come to you with back pain, and on the other month he may have radiculopathy, and sometimes even to cauda equina. So for a similar looking radiology, varied clinical presentation is still understood. Why does same looking MRI produce different symptoms in different individuals? And vice versa is also true. A patient with radicular symptoms of leg pain may not necessarily have similar looking MRIs. So if there are 10 patients with same symptom, their MRIs would look completely different. So it is still completely ununderstood. Why does the same symptom have different radiology? And this mystery still continues to remain a big enigma to be solved by physiologists. And I don't think any research will ever prove the which symptoms and radiology happens. The biggest dilemma for us boys, orthopedic boys, happens when it's about management. The problem is so huge that we really don't know which of the plethora of options is the best for a particular given patient, because some surgeons vouch by conservative treatment. Some surgeons I have seen arguing about injection therapies, and out of injections also there are 20 different type of injections, be it sodium channel blockers, sural blocks, thumb blocks, injections, transforaminals, and various other type of blocks, and for that matter steroids and medicines and intradiscal therapies, and also surgery. When it comes to surgery, open surgery, conventional, minimal invasive, endoscopic, microendoscopic, and all these options only create a confusion without giving a common consensus ground there. So where is the consensus? I mean, we still in 60 years of treatment of degenerative disc disease are only left with questions. Which patient presents in this particular manner, why, and what is the best option for this particular patient? How do I ensure that this patient goes home 100% of times happy with this particular symptom, like in this case scenario? So I think some grounds are established. I mean, there is no question on them. And these are some grounds where there is no doubt about. And if there is one slide you want to carry home, this is something that we all know and we should carry home from here, is that the only few consensus points in degenerative disc disorders are that cauda equina syndrome is an emergency. There is no doubt about it. A patient presenting to you with the cauda equina syndrome symptoms has to be operated. There is no second thoughts about it. The second most commonest thing is that the natural history of disc is to resolve. 99% of these slip disc patients will resolve with conservative treatment, and that should be the thumb rule for all other patients who are not into cauda equina, no matter how bad their symptoms are. And then if surgery is required, which is probably for select group of patients, it is required only for less than 1% of patients. And these are that 1% of patients where success depends on clinical acumen, surgical skills, understanding of the problem, counseling skills, and above all, it is patient selection. So if there is one thing that decides the 100% success in treatment of PIVD patients, it is nothing else but patient selection, meticulous patient selection. And it comes from clinical acumen, it comes from good years of experience, and it comes from understanding of the pathology, physiology, radiology, and various other aspects of patients' lives. So we must emphasize so much more time on this one aspect of surgical treatment, which is patient selection. And that is the success mantra. And this success mantra doesn't come without certain disciplined rules. So if tomorrow onwards you want that your patient should have a guaranteed 100% success with treatment that you offer to this patient of slip disc, you should follow these rules. So carry home these rules with you. So if the second slide you want to carry from this whole plethora of 15 minutes that I have here is this, that unless and until you follow all these 6 rules of treatment, your patients will not be 100% satisfied. And what are these rules? We'll be taking them one by one, but to simplify, we must understand the rule number 1 is the natural history of disc is to resolve, and conservative treatment is the thumb rule for all patients. Failure to conservative treatment, mind you, failure to conservative treatment is not a good indication for surgery. I repeat, failure to conservative treatment is not a good indication to surgery. A good indication to surgery is when your diagnosis is correct, when there is excellent clinical radiological correlation, when the symptoms are progressive in nature, and you have counseled about the expected outcome to the patient truthfully. Unless until these rules are followed, your patients are not going to be happy at the end of the day, and you will continue having bad name to yourself, to your branch, and to your fraternity. So let's take rule number 1, natural history is to resolve. We all know that 95% of these patients, you don't treat them, you just tell them, 98% of times they'll be better. So it's only those less than 2% of patients who will not resolve by nature. So the best doctor for slip disc or with back pain and radiculopathy is nature. It's not us. So by the time nature works, we just have to give them pain management, counseling, supportive treatment, so that nature works the way it does. And we have to just support natural treatment to them. And as I say, natural history is to resolve. That is why the thumb rule is all patients with acute or chronic symptoms, thumb rule is to give them conservative treatment. I'll not go into the details of conservative treatment. I'm sure we all know about it. It's all about pain management, conditioning, stabilization, various kind of exercises, but conserve them as far as you can, and most of them will get better. And there is no duration fixed to it. Some people say 3 weeks, some say 6 weeks, some say 12 weeks. But I say that discontinue therapy of conservative treatment only when the symptoms start affecting the activity of daily living. If the symptoms start affecting my activity of daily living tomorrow, I will stop conservative treatment for myself. However, for a low demand person, if his activities of daily living are not progressive, are not getting affected, you may continue conservative treatment even for a long period of 6 months as well. So you can continue doing it till the ADL is not affected. So what to do next? If, for example, we have to discontinue treatment, shall we do a surgery for this kind of patient? Shall we do endoscopy or microscopic? No. That's where the rule number 2 comes. If conservative treatment has not worked, it is not the right indication for surgery. Mind my words, just because your conservative treatment has not worked doesn't give you the right to poke in surgery in these patients. Because if something that works 95% of times has not worked, a question should arise in your mind: why has my patient not got better? And that's what you have to evaluate, that why my patient has not got better. And so if the symptoms are not improving, you better go and evaluate why nature has not worked in this particular patient. And that's where comes the rule number 3. Rule number 3 is to establish correct diagnosis. What do I mean by correct diagnosis? The answer to this is rule out all extraspinal causes. To prove my point, I'll just bring a case scenario. A 23-year-old male with low back pain and right leg pain with pain going down the leg, having difficulty in walking, sitting, sleeping, having MRI which shows right-sided annular tear with a disc pinching upon the traversing nerve root, and the report is prepared by 3 radiologists, and it proves that the SLR is less, right leg pain, young patient, MRI showing some disc herniation and some compression. So that is probably the cause of it, and the conservative treatment is not working. So shall we go for surgery into this particular case scenario? The answer to this is straightforward, no. Why? Because this patient had an extra spinal cause. And unless and until you have seen this patient as a whole, unless and until you have established and examined all the extra spinal causes of pain also, you have probably not really done the justice, and you have not followed the rule number 3. And we all must acknowledge, appreciate, and emphasize that the list of spinal masqueraders, which is non-spinal conditions which mimic spinal pathologies like slip disc, is huge. It's huge, as huge and common, more than what we actually think about. Facet syndrome, facet cyst, sacroiliitis. Young patients with avian can come with symptoms mimicking slip disc. Patients with non-compressive myelopathies and radiculopathies, peripheral neuropathies, even greater trochanteric bursitis and piriformis syndromes, all can lead to similar symptoms like what PIVD can be there. And mind you, PIVD can still be present and contributing to symptoms, but your patients will not be better unless you have ruled out extra spinal causes and made a correct diagnosis out of it. And this is our duty, that you got to make correct diagnosis. Now you have tried conservative treatment, you have established a good diagnosis, and conservative treatment is not working. Does that gives me a right to operate upon this patient? The answer to this is also no. Unless until in a patient where natural history has not worked, you have established a correct diagnosis, and there has to be a matching of clinical symptoms to radiology. There has to be a structural compression noticed and noted and documented for the symptom that you say. What do I mean by this? For example, a 57 male with right leg pain and L5S1 PIVD, pain going down to the calf more than thigh. Will this patient get better by any kind of surgery, Turi sir? Probably not, because his pain is on the right and the disc is on the left. Yes. Exactly. So I think you have seconded my first point, that correct diagnosis and ruling out extra spinal cause is important. Here, establishing an excellent clinico-radiological correlation is also important. In this case scenario, the pain is on the right, the disc is on the left. No kind of surgery will help. Another case example, left anterior thigh pain and left L4-5 PIVD. Will any kind of surgery help this patient? The answer to this is also no. We all know that anterior thigh is not supplied by L4-5. And that is why no matter how bad a MRI is looking, no matter the conservative treatment is not working in this patient, we have a correct diagnosis of PIVD, but because the symptoms are not matching the radiology, no matter how good a modern or endoscopic or microscopic surgery you do, your patient is not going to be happy. So on one hand, correct diagnosis is important. On the other hand, you also have to ascertain that the symptoms of this patient are matching the dermatome. We all know that sciatic nerve supplies below the knee, and unless until L4-5 5S1, which makes maximum of sciatic nerve, L4-5 5S1 disc is there, that means the symptoms must travel below the knee, and dermatomal pattern has to be given due importance. This is what we just spoke about, that pain below the knee or in the calf is something in dermatomal pattern. That's when we say that it is from 4-5 5S1, whereas discs of L2, 3 and 3, 4 create pain above the knee, and that's what we contribute in the femoral nerve area. And this is something that comes by leading questions to the patient. Fifth point, now I recommend that symptoms which are regressing, like in this patient where he had left leg pain because of left PIVD, had already 50% better at 6 weeks, and his 50% pain is persistent. Should we operate on this? My recommendation is, please do not operate on any patient whose symptoms have already 50% regressed. They will never appreciate the benefits that you have given them. They will never give you a good word of accolades. And that is why surgery should only be done in patients when their symptoms are progressive or are affecting their activities or daily living. And this rule is something that is the best rule that one must follow, and never operate on partially relieved pains or resolving symptoms at all. And rule number 6, I think this is one thing that differs significantly from joint replacement surgeons, where joint replacement surgeons spend 5 minutes in counseling and 30 minutes in surgery. I would say in spine surgery, it's vice versa. Your counseling time should be 6 times more than your surgical time. So if your surgery lasts 1 hour, you should call the patient 6 times before the surgery to counsel them about the minimum expected outcome versus maximum probable benefit. Now, this is something that we all must understand, that numbness or EHL weakness, or for that matter, even hamstring tightness, or for that matter, residual back pain, or for that matter, foot drop, may not improve by your surgery. Surgery is primarily and only meant for pain relief, and probably the added advantage may be recovery of neurological function, but that cannot be promised and should not be promised. And that's why you must counsel the patient about the true outcome of the surgery. Unless until you have done this, the patients may continue cribbing, Dr. Saab, numbness abhi bhi baki hai, EHL is still not moving, my SLR is still not better, I still have some back pain. And so it is your duty to tell them about not only the course of recovery, but also what to expect exactly from the surgery. And once you have done this, after following these rules, there is no way you will have any unsatisfied patients ever. And this is what I always try to mention, that the rules of 100% success are these 6 rules. And the moment you start following these 6 rules in your practice, I'm sure your worst done surgeries will still give you a wonderful result of outcome in these patients. But that doesn't mean that we should do a worst surgery, because surgery, though on one hand is a dilemma, how to do is already established. Whether you do an open discectomy, you do an interlaminar discectomy, or like me, I do micro discectomies and microendoscopic minimal invasive discectomies. But the answer to this is how much to do. The simple plan is that your nerve root should be free at the end of the surgery. Whether you are doing a fragmentectomy, subtotal discectomy, whether you're doing an open discectomy, whether you're doing a microscopic discectomy, whether you're doing an endoscopic discectomy, the compressing structural fragment of disc herniation that is causing nerve root compression must be removed. The compressive element should be removed, and the nerve root should be visualized to be being free at the end of the surgery. How you reach there by doing laminectomy, laminotomy, hemilaminotomy, or endoscopically, that's not important. Of course, they have its own advantages. I have been doing minimal invasive surgeries for so long, and each has its own pros and cons. On one hand, open surgery has its pros and cons, endoscopic surgery has its own pros and cons, and microscopic surgery has its own pros and cons. I would recommend that you get prepared in your armamentarium and start becoming microendoscopic or endoscopic surgeons for future, because it surely has added advantages in rehabilitation and post-operative course. But that should not deter you from doing open surgeries, at least in the beginning course of your days, when the end point of surgery should be achieved. Even the most efficient minimal invasive spine surgeons sometimes may have to convert a minimal invasive surgery into a frank open surgery, because sometimes MIS may not be possible in those patients. So I recommend that you should, end point should be the same. The principle of surgery should be decompression of the nerve root, and how you do it is again secondary. These are just some examples where we have been doing these surgeries in daycare procedure. Nowadays, actually, we do awake spine surgery with minimal invasive microendoscopic discectomies, not only for slip disc, but also for lumbar canal stenosis, and even for spinal fusions. They have gone into an extent that with minimal invasive technology being available, all these surgeries have become very, very simplistic, not only pre-operatively, post-operatively, but also in mobilization form. Last question. Sometimes we are asked how long a bed rest should be given after the surgery. There is absolutely no need and no evidence to support prolonged bed rest after surgery. In fact, there is the only one recommendation that helps maximum and brings maximum satisfaction among patients is that immediately after surgery, allow patients to do mobilization or activities under their own pain relief. So who's the best physiotherapist for the patient? Patient himself. If patient says I am in pain, might as well just take a rest for a day or two. There is absolutely no rush in getting you out of bed and sending you home to prove that I am a best surgeon. There's absolutely no fun in doing that. However, promoting them, counseling them, motivating them to start doing activities of their own leisure within pain limits is something that we all should be promoting. And this is something that we all must pay attention to. Last but not the least, my last slide here. 1 out of every 10 spine surgeons in future will be surely doing a wrong level surgery, and it's a disaster to happen to you. It has happened to me. It has happened to the most senior spine surgeons here, but I really wish that you learn from our mistakes and you don't have this mistake of having a wrong level surgery. And that's why always without fail, even today, like now, it's a principle that always check the right level of surgery intraoperatively before giving a nick on the annulus. And that's what is absolutely mandatory to prevent yourself from landing into the zone where we stand from here. With this, I really thank you all for a patient hearing, and I sincerely recommend that we all follow all the 6 rules of patient selection, and natural history should be given due importance and respect to. Thank you so much, gentlemen. Oh, yes, I'll be more than happy. Yes, sir.
Well, sir, you have emphasized very emphatically about a very difficult problem.
Thank you, sir.
You said, make a correct diagnosis. Today, we are making a correct diagnosis. and the cause is something other than the disc itself, as you said. But tomorrow, if the same disc, which is caudal or cephalic migration and massive one, may lead to symptoms below the knee, L4, 5S1. You have not mentioned about ligamentum flavum. Ligamentum flavum is one of the most important cause of compression of the cord and the roots. How do you say, because you have not probably mentioned a word about ligamentum flavum except the disc. So I think that is also a very great contributory factor for peripheral migration, peripheral symptomatology. So I would like to know that today the cause is something else and not the disc, but tomorrow the disc may exaggerate itself and can lead to cauda equina symptoms, which is an absolute indication for
Dr. S.S. Yadav, thank you so much for a wonderful question and bringing out one of the most emphatic points in the compressive problems of lumbar spine. Unfortunately, in this meeting, the only topic that they gave me to speak upon was prolapse intervertebral disc disease. In a true prolapse intervertebral disc disease, ligamentum flavum probably contributes nil to the symptoms of radiculopathy. And if ligamentum flavum hypertrophy is contributing to the radicular or claudication symptoms, we know that we are not dealing with pure radiculopathy due to PIVD, but we are actually dealing with a different problem called lumbar canal stenosis. And it's a completely separate chapter, separate book to be written, separate lecture to be taken. Ligamentum flavum hypertrophy causing symptoms of radiculopathy is extremely rare. However, ligamentum flavum hypertrophy causes more of claudication symptoms, more of lumbar canal stenosis. Yes, if it is present on radiology in a patient with radiculopathy, while going inside dealing with the disc, you do remove ligamentum flavum and only then will you have access to disc problem. I hope that solves the query.
Can I ask?
Oh yes, Dr. Lisa.
Vishal, I'm happy to listen to you.
Thank you, sir.
It has given me a hope of bright light in the care of spine patients.
I'm humbled to hear kind words, sir.
I wish you produce more Vishals in the country.
Thank you so
You're
much.
Absolutely correct. It is not the MRI or even the X-ray findings, the indication for surgery. It is a clinical feature which are the indication for surgery. And if you are operating, by any means you do mechanical decompression must, without disturbing the stability of the spine. I pray you keep it up. If you have any prints, I'll be happy to receive them.
Thank you so much, sir. I'll be happy to share them.
Probably utilize them for the longer purpose.
Humbled, sir.
Thank you. Thank you.
Most of the time, we see L4, L5 or L5S1 disc in MRI. For some reasons, if you are operating, more than 50% of the time, there won't be any disc. Patient may not be satisfied post-operatively also. Then they go and take another MRI through different consultant. The same picture again comes. What causes this shadow in MRI?
So I beg to differ on this, sir. In fact, I was about to tell you this, that wrong level surgeries can be diagnosed intraoperatively also. There is nothing called shadow on a MRI. MRI is the true picture of patient's spine. If a disc is seen on MRI, it will be found intraoperatively. If it is not found intraoperatively, either your MRI is old or you are at a wrong level. There cannot be a third reason to it. There is nothing called regressing disc syndrome or a absent disc syndrome, or I operated on the disc, there was no disc found there, patient still had radiculopathy. There is no such entity at all. If intraoperatively you have not found a disc which was seen on the MRI, then you should go back to your MRI and check whether this MRI is less than 6 weeks old or it is older. If it is 6 weeks older or even older, you know that the disc was there and it has regressed. that means that you are at fault of not getting an MRI during your surgery. And that is why yesterday someone was talking that you always get a fresh MRI before surgery, at least never older than 6 to 8 weeks time. And I think I learned it from Dr. Ramchadda also, that he emphasizes. Now we work like a team in Leelavati Hospital, and I literally sometimes have a fight with him. Sir, abhi 6 hafta to ho gaya patient ko, abhi MRI karaya, kyun karne ka wapas? And he emphasizes this point again and again, that what if we do not find a disc there, or what if the disc has already regressed and there is something else which is causing the symptoms to this patient, like Dr. Yadav mentioned, whether it is ligamentum flavum causing the symptoms at all. So if you have not found a disc intraoperatively, have a look at the MRI if it is older, or do a C-arm check again by putting a needle there in the disc, whether you are really at a right level or at a wrong level there. I hope that answers the question there, sir. Sir.
Kanabar from Ahmedabad.
Sir.
How often do you use EMG nerve conduction studies?
So EMG and NCV is a completely different enigma in patients with radiculopathy. As I said, so the surgical decision making, whether to operate or not operate, is based only on these rules where EMG NCV doesn't have any role. I repeat, the decision whether to operate or not to operate is primarily decided by whether patient's symptoms are worsening or not, whether his activities of daily living are affected or not, whether his functionality is affected or not, whether he has a structural defined compression on that particular nerve root with excellent clinical radiological correlation or not, and whether patient has been counseled or not. Now, after these 5 points, if for your own satisfaction, you want to rule out if there is a confounding or contributing peripheral neuropathy, you may do a EMG and CV for patients of high risk. Or if you want to find out that the paresthesia or motor weakness that this patient has had is chronic in nature, or is acute in nature, or is going to have a recovery potential or not, all these questions can be answered by EMG and CV. However, for surgical decision making, EMG and CV in my books has no role to play. Thank you so much. Thank you so much, sir.
Thank you, Vishal, for such a wonderful talk. There was a lot of anxiety for me as an organizer, whether he would be able to deliver his talk, but it was like a Hindi film. There was anxiety if we would be able to get him on podium, but at the end of a Hindi film, they all have a smile on their face and sometimes tear in his eyes, but everybody's happy. He woke up every soul in the house. Now we got Dr. S.M. Tully as the next speaker, the powerhouse of Indian orthopedics, living legend, Dr. S.M. Tully. I would request him to. Absolutely, sir. Absolutely. I'm sorry for that. That always take more time. Absolutely. But for few new boys, I spoke few words. Now I request you to come, sir. No problem.
Drama karne ki aadat hai. Drama karte hain.
Right, sir. So the topic of the talk is a journey through orthopedics, 1959, then now next. Professor Tully. I would stay here to help you. I mean,
yeah, I may need. The dignitaries on the dais.
Thank you, sir. Dr. Seva, Dr. Sandeep, please come on the dais, chair the session. Welcome, sir. Legend of the IOA, our father, our mentor, teachers of teachers, our editor. Please.
The dignitaries on the dais, my learned colleagues, and the new generation. Nature has given me a privilege of traveling through orthopedics since 1959. So here are glimpses of what I saw where reversals took place. Something like a U-turn taking place during the journey in the care of some of the conditions. I won't be able to give you details, it's just a glimpses. And the U-turn taken by orthopedic fraternity in this period has been, when I entered, external surgery for every case. Today there's a change. Then there was arthrodesis for any infected joint. Today again it has changed. Then came the AO philosophy, rigid fixation of every fracture. And I could see the boards in a clinic. This clinic treats fractures without plaster. That were written on the clinic. Then came certain small things like electromagnetic stimulation of fracture healing. And then, of course, a very important subject, fibulectomy for leg compartment syndrome. Such a precious thing like fibula being thrown on the dustbin. And then again, colonial intellectualism, every vertebra plana was considered to be eosinophilic granuloma. Today, we think differently. Then en-bloc resection of giant cell tumor, of course, in the last 20 years, there are different thoughts. I'll try to give some glimpse for all of us to learn. We are dealing with a biological system. We are not dealing with chair and commode. We are dealing with a biological system. We have the facilities developing to treat many modalities without surgical intervention, without major cuttings, using less invasive procedures. This is how I started, putting every patient in a plaster. TB, put in plaster, plaster bed, plaster jackets, a hip spica. Aim was fuse the joint. Not today. Today's physicians have the facilities to make a diagnosis at a pre-destructive stage. And if you can do it at a pre-destructive stage, you can obtain a healed status with a reasonably good function of tuberculosis of any part of the body. This is the effect of arthrodesis. The joints were fused. I have done it myself. But any arthrodesis of a major joint, maybe hip, maybe knee, even an extensive arthrodesis of the spine can lead to juxtafusion, premature degeneration, and pain. If it is a lower limb, hip, knee, contralateral side, as well as the ipsilateral side. If it is spine, adjacent segment of spine can show you symptomatic degenerative disease near the junction of mobile segment and a fixed subject. This was quite a common thing. I've seen all this, performed all this, fused the joint, tuberculosis of the joint, tuberculosis of the hip joint. But today we learn that arthrodesis of any major joint, hip, knee, or spine can lead to juxta-articular extra stress and limitations of activity. Today we can, in an infected hip joint or an infected knee joint, replace these joints, give them a mobile joint, provided you are doing this procedure after minimum of 1 year of healed status, not only in the joint alone, but also in the body as a whole. Here is an example, tuberculosis of the hip joint. Today you can make the diagnosis at a very early stage. But here, though the diagnosis was made at a late stage, look at this one. This is the destruction, essentially of acetabulum. Here is a MRI showing you destroyed hip joint, collection of pus inside, a separating lymph node inside, in front. Treated by anti-TB drugs at home, functional treatment of the joints, put the joint into mobility as soon as the pain subsides, and you can have a healed status which will last for at least 15, 20 years easily, so long as the joint space is maintained, and then she may be fit or he may be fit for a replacement procedure. Another example, 4-year-old child diagnosed in 1966 and followed up to 2006. At the time of presentation, he had tuberculosis of the lungs, tuberculosis of the hip joint, treated by so-called functional treatment. Anti-TB drugs, rest in the functional position, pain subsides, put them on exercises, active exercises. Here it is, 15 years after the diagnosis and treatment, roughly 40 years after the diagnosis and treatment. This is his function, and having enjoyed a 44 years of a mobile, painless hip joint for tuberculosis, he may be fit for a replacement in due course of time. Fracture healing. Fractures have been healing since the arrival of man on the earth. They were healing by a natural process, which was given the name secondary healing. Who gave the name secondary healing? Probably the people belonging to the AO group. Instead of calling it a natural healing, give it the name secondary healing and call primary healing. We produce primary healing by what? Rigid fixation of every fracture, whether it is displaced or not. This was the philosophy brought in by AO. They might have some good points, but the weakest point to my mind, disturbing the natural biology of healing, converting them into primary healing, rigid fixation. Because it's a rigid fixation, no callus will form. There is no motion, no callus will form. Judgment of union was difficult, and many of these people got fractures under the fixed rigid implants or adjacent to the rigid implants. The same philosophy, juxtafused area is under stress. Bone is viscoelastic. Bone is not rigid. To keep the bone healthy, maintain the viscoelasticity. To make it weak, convert it into a rigid stock. And here is an example of a patient, a rigid fixation done so that we don't see any callus. Has the fracture united? I don't think a simple man like myself can judge. And sometimes it has happened, you remove the plate, under the plate, the bone has become flattened. The fracture is still there. It is not visible because it's covered by the plate. And sometimes adjacent to the rigid plate, while doing something or observation, you can get a spontaneous fracture. Any metal can break. If the underlying tissues don't get stabilized, in a critical time, any metal will break. But if there is a callus formation, callus has healed, callus never breaks. Adjacent to callus, there may be a fracture, but it is seldom you will see a fracture occurring through the united callus again. It's very, very rare. Okay, let's see some other minor things. This is Kawes disease. When I entered, I was taught, I probably even might have taught my next generation. Oh, look here. Here is a flattened vertebra, vertebra plana. It is due to eosinophil granuloma. And it was given the name Kawes. Well, he observed it, he thought of writing, and he succeeded in publication. Today we know, at least in the Indian subcontinent, if you study them, it can be tuberculosis, it can be osteoporosis, it can be metastasis, it can be myeloma. This is vertebra plana. Young students or young people, this is vertebra plana. The whole vertebral body is flattened. But the cause in this case is not eosinophilic granuloma, but tuberculosis. Here is a tuberculous lesion in the same patient. There's a cold abscess due to posterior spinal disease. This is another recommendation. It came in the literature. Leg compartment syndrome, remove the fibula. What a silly thing to do. And why to remove the fibula? By a single operation of fibulectomy, you can decompress all the 3 compartments of the leg. This was the recommendation, and it was published, and my country, my people followed it. Tragedy, throwing away fibula. Can't we do a decompression? You can do a 3-compartment decompression if you want. If you do not want to make multiple incision, make a large incision, cut the deep fascia in the anterior compartment, cut the deep fascia in the lateral compartment, cut the deep fascia in the posterior compartment. The decompression will take place without any complications. So here, the great surgeon has removed the fibula and throw it away. To my mind, fibula is an excellent bone, living bone for most of the activities. Preserve it, respect it. I appreciate the role Professor Yadav keeps on playing on fibula, and he always say, I don't praise the fibula. I say, I praise Dr. S.S. Yadav, even if I don't praise the fibula. Okay, then here is the fibula. This is the fibula. This bone was lost at the time of injury. There was an extensive wound, but the foot had the sensation. And I keep on repeating ad nauseum. If the foot has sensation, every orthopedic surgeon has the potential to save a sensate foot. It may not be easy, but all of you can do it. And this is one method of doing it. The fibula was transferred, it got incorporated, and followed the rule of function determines form. This is the basic rule. If the bone is living, function will determine the form, the size. Look at the fibula, which is unloaded. This is unloaded fibula. Here is the unloaded fibula, and here is the loaded fibula. It has hypertrophied almost to the width of the tibia, which is required. It has developed a marrow in it to substitute for the function of the tibia. Let's look at back. Now, excuse me here about backache. I think one of the most intriguing subject being discussed at this time all over the world is non-specific degenerative changes, backache, indications are non-indications for surgery. Surgery is being done, PLF, ALF, TIF, post, etc., etc. This is from a book. It is plagiarized. This picture is plagiarized. And you can see same ethnic population, England and America. This is the number of surgeries being done in America, the number of surgeries being done in England. Why? Is back surgery being performed for the benefit of patients or for? I think one has to study, think, and I was so happy to listen to Vishal. In next generation certainly gave me a bright hope. Not a standard laminectomy. There is no convincing evidence, if done well, no functional mobility without instability for more than 10 years after standard laminectomy. Advocating liberal indications for extensive operations seems like elitist arrogance. Here is an example of a patient, standard laminectomy done for a lumbar canal stenosis. 15 years after, you can see the movements, and we permit them all movements. We put no restrictions after having done a laminectomy or spinoplasty. We go to giant cell tumor. It was called osteoclastoma. The nomenclature has been changing. When I entered, every osteoclastoma was supposed to be resected and replaced with a bone, whether from the bone bank or from the fibula or even from your mother. Fathers never did it. Always a mother donated the bone if at all needed. Again, the same formula. If the bone gets incorporated, it will undergo the remodeling. Function determines form, but at the cost of we have lost the joint. This is another example of fused knee for a tibial giant cell tumor by a hemicylindrical graft taken from the femur downwards. Today, the thought has changed. It is considered, giant cell tumor is considered as a locally aggressive tumor. Here is a giant cell tumor, curated, bone grafted, and followed up for 20 years, and it has not recurred. It has healed very well. However, the basic requirement for this success is jam-packed bone graft. So you have to evolve or develop, make available allogenic bones so that you can pack it like a gunny bag with almost like hammering them down. If you can pack them tightly with the bone graft, there are very bright chances that you get a success and leave behind a functional joint. To my mind, orthopedic has reached the peak and plateau in instrumentations, implants, imaging and lab in investigations, operative exposures, techniques, anesthesia, resuscitation. However, wisdom has remained the same. We are, after all, human beings. None of us is perfect. Wisdom has remained the same. During the last 50 years, only 2 clinically significant biological advances are mentionable for orthopedic procedures. One of them is Elizaro's technique, which told us slow distraction can produce bone transversely as well as longitudinally if you know the technique how to do it. Marshall Urist brought in demineralized bone on the basis of contents of bone morphogenetic proteins. This is demineralized bone served in our bank containing bone morphogenetic protein. And here is a synthetically available graft. Synthetic available graft only acts as a osteoconductive material. Future challenges and opportunity, less invasive techniques, biological replacement for arthritis, repair and degeneration of osseous defect, recruitment of stem cells and genes for tissue engineering and disease control, and control of super bugs. This is the future challenge, and I'm sure the millennial generation will find solutions to take care of the future challenges. As I mentioned, any metal will break, any metal, wherever it is, if the underlying tissues don't get stabilized in due course of time. And this is what we should get. We should evolve biological modalities to replace or repair bone by cartilage, bone by bone, and cartilage by cartilage. These were my mentors. I just mentioned my name to pay my respects to Professor Grewal, Dr. Sankran, Dr. Duraiswamy. Mentors are there, but there's a role of mentee as well. And one of my colleagues from Bombay did mention once, if you couldn't get a mentor for yourself, you become a mentor for the next generation. I request you all to consider that orthopedics is a biological process, not a technical or mechanical process. Thank you, sir. Thank you.
Thank you very much, sir. Journey of Dr. Tulis since 1959 has been a wonderful journey and Herculean in the field of orthopedics. On behalf of IOA, I request all the dignitaries and all the delegates in the house, please give an standing ovation to Dr. Tulis, sir. Thank you, sir. Be obliged, sir, with your kind presence and your oration. Next oration lecture is by Dr. S.S. Yadav, sir. I request Yadav, sir.
I just want to convey that I'm still a student of orthopedics, and it is my students who ask me questions. It is my students who prod me, and they induce me to continue as a student of orthopedics. I'm probably the most chronic student of orthopedics in this country. Thank you, sir.
Thank you very much, sir. Now I request Professor Yadav, sir, Chief Patron of this conference, please deliver your prestigious talk on the management of fibular hemimelia with long-term follow-up. A wonderful gift to the IOA, to the orthopedic fraternity, to the surgeons, those who not having the facility of latest medical equipments and technologies, they can do a very simple surgery and operation to save the limb. And now request to Yadav sir, please give the lesson.
Chairman on the dais, ladies and gentlemen, I thought and thought again and again as what should I deliver what subject should I speak on. Then I thought that common subjects are being discussed at various scientific meetings, academic conferences, but we do get cases which require our attention and are generally not attended. I do not know if I ask the students sitting on the back benches as what is fibular hemimelia. I feel it is essential that you don't discuss about the joints and the spine, but some of you have to take care of those conditions because they are our patients. Where will you send them? Where will you refer them? From one place to other, they keep on going and finally they settle down that I have to learn to live with this condition which Almighty has granted to me. It gives me pain. I am pained to learn that not many people in the country are takers of such conditions because they are not taught. It is not the fault of a postgraduate students. So I go on to, because these are I stayed in Pondicherry, as I told you yesterday, for 14 years. And because of consanguineous marriages, there had been a lot of congenital defects with which the children were born. So I learned to live with these patients and learned as how this is a child with fibular hemimelia, with valgus ankle, and the lateral rays are absent. There are two basically paraxial deficiency of the lower limbs, tibial hemimelia and fibular hemimelia. Hemimelia means when a major part of a vertical limb is absent. I have dealt with tibial hemimelia and I have produced fibulo-calcaneal arthrodesis, that also bilateral. Ladies and gentlemen, it is the modern teaching. Never fuse both the joints. Never fuse both the joints, both the knee joints, knee joints. I fused both the knee joints, both the ankle joints, and bilateral. I sent this tibial hemimelia where tibia was absent. Bilateral tibia was absent by birth. I fused these joints, sent this paper for publication in JBJS American. Refused. We Americans do an amputation and artificial replacement. In my anger, I wrote to them, and it's a fact. that you Americans do not know that these limbs can be saved. We have saved them, and no parent would like that his child should be amputated on both sides, because they are given no choice except amputation and artificial limbs, so they agree to that. We told them. They said refused, can't be published because we Americans do an amputation and artificial limb. I said, you Americans do not know as what damage you are causing to the child and to the parents indirectly. As Dr. Tuli said, no sensate foot. If we can save these limbs, the child will have a foot with sensation and proprioception, which no artificial limb can give. Till this afternoon. So they said it is accepted for publication as an alternative to amputation and artificial limb. I wrote back, thank you very much for accepting the paper now, but this will be the principal method of treatment of tibial hemimelia, and amputation and artificial limb will be an alternative, which they also accepted. So a message to the younger colleagues is that if you think that you can do it and you have done it, you can do it. It was done and published in 2019 in JBJS American. This girl is there as a teacher, 36 years. She's a school teacher. She can climb the stairs. She is married. She has got a son. Now coming to the fibular hemimelia, we have also got a couple of patients who have been treated by the way we wanted it to be treated, and they are doing well. These are the conditions. The fibula may be short, the fibula may be very short, the fibula may be absent. We had 12 cases, 14 limbs, age 1 to 18 years, unilateral and 2 bilateral. I'll show you both the bilateral. Other features are as listed here. They are absent polysyndactyly, syndactyly, lower epiphyseal valgus limb, and absence of rays. The management goal. The goal of treatment is to get a functional limb equal to the limb of the normal size, one. Second, correction of the deformity, and plantigrade foot, which has sensations and proprioception. A very important thing. Never amputate a foot which has sensation. Before 1961, reconstruction to obtain the normal limb had many problems and failed. Recent view is to recommend treatment as an amputation and prosthetic replacement. That is what the literature said so far, not now. So these are the deformities and problems which the patient had. These are a couple of children with fibular hemimelia. Tibia is there. Fibula is, look at the hypertrophied tibia. Absence of rays on the lateral side. In tibial hemimelia, there is absence of rays on the medial side. Now these are the children which are the fibular analog which was there, was excised. We have, these are the children. This was the patient. A patient, 9 years of age. He was looking like this. Look at that. That is tibia. The patient has been walking on the stump of the tibia and the feet have gone on the lateral side. This is the fibular analog which has to be excised. Look at that. You rarely see such picture, bilateral fibular hemimelia. This was the patient who was treated by, we have 3 stages. Stage of loosening on the lateral side, including the excision of the leftover, that is called fibular analog, and lateral loosening. Then we have the lengthening. We apply traction or we do a double oblique diaphyseal osteotomy. One of our procedures described as an innovative, published in JBJS British in 1993, double oblique diaphyseal osteotomy, dodo. You see the outcome, the same patient after 10 years. Otherwise, he would have gone in for amputation. He goes like this. Now, this is a patient who came to me like this. One of my very senior colleagues, he was Director General Health Services. He is no more. He wrote to Elizarov, Gavril Elizarov in Kurgan, Siberia, to treat this patient. He came to me on artificial limbs, and his father said, this patient happened to come to Maulana Azad Medical College, where I was working at that time. One of my senior occupational therapists told him that there is a man sitting on the first floor. If you want to consult him, you can talk to him. He came to me. He showed me the letter written by a very senior man in our country for Elizarov to treat. I told him that we can try. If you agree, we will start the treatment. And as I said, destiny prevails. He agreed. He said, yes, I'll get my son treated here. He was 15. This was the picture when the artificial assistance was taken out. No, not this. This one. This was a 15-year-old boy on way to Kurgan, to Elizarov. As a matter of fact, howsoever you may stress your gray matter, you will not be able to describe these deformities anatomically. It is beyond consideration. Nobody can describe these deformities anatomically. I think there is something. Yes, this was the X-ray on the left side and right side. We used to do a lot of angiography in those days, and angiography should be done in these cases because it's possible that while doing surgery, you might be able to damage the principal artery and go in for. This is our dodo, which was published in 1993 for treating severe limb deformities and shortening. These were the steps for surgery. Now you see here, the left side is treated. The right side continues to be defective. Here we did, I said, loosening, lengthening, and stabilization. 3 stages for tibial hemimelia and for fibular hemimelia, both. And there you are. He was treated. It will take long time for me. This is the dodo. You gradual lengthening. The principle is same as a wonderful principle of Elizarov, gradual distraction of the soft tissues and bone, histogenesis and osteogenesis leads to bone formation. This was after Dodo, the same patient. He had loss of 3 rays congenitally. This is the patient, knees almost at the same level. The boy now puts on his own shoes and touches the motherland soil with his own soul and not with artificial soul. This is a picture 28 years later. He is now in Dehradun as a engineer, software engineer, and look at that. This is 28 years follow-up. This shows that results have not deteriorated with time. Generally, it is said result will deteriorate with time. If a patient who comes like this and goes out like this, ladies and gentlemen, I don't think I have to look to my left and right, be it USA, be it UK, or be it Japan. That is why I said, if your challenges are opportunities for youngsters, your challenges are opportunities to solve the problem. These are the stages: management, loosening, lengthening, and stabilization. There are lots of, still orthodesis is very important, ladies and gentlemen. I have appraised particularly the youngsters with the condition called fibular hemimelia, which I think deserves your attention, and let these patients not go from place to place. And finally, they learn to live with the condition and spend their time with that deformity, with that. These type of children never come out of the house. They develop an inferiority complex. They stay inside 4 doors because people laugh at them. These patients, they come and tell me, sir, I never used to go out because I was highly abnormal. So I have tried to convey a very difficult subject, of course, uncommon. It is uncommon, but it takes place. And they are our patients. Where will they go? And I can tell you, the foreigners, Far East and West, they have no treatment for these conditions except amputation. I can dare say that because they have never seen such cases. They believe in amputation and artificial limb fitting. Thank you very much for giving me the chance.
Thank you very much, sir. No word. We don't have any more word to express our gratitude and appraise your gesture. And you have proved God made the man a deformed, but you have corrected them as a gentleman. And you have really proved that if anybody is ahead to the God, that is the doctor. And you are real that doctor. So I request the house to give a standing ovation to Dr. S.S. Yadav so that we can follow his guidelines, his traditions, his culture for the poor society and the real needy persons, those who cannot get treatment anywhere else, the India. Thank you very much, sir. So nice of you. The next speaker is
Dr. Sanjay Chaturvedi. He'll be talking on epidemiology of knee osteoarthritis in India and related factors. Dr. Sanjay.
Thank you. Thank you, sir. It is difficult to speak after giants of orthopedics has already spoken, but this is a topic which has been given to me is epidemiology of knee osteoarthritis in India and related factors. Epidemiology is nothing but evidence-based orthopedics for new ones. What is epidemiology? It is the study of distribution and determinants of health-related states or events in a specific population. and the application of this study to the control of health problems. Epidemiology is also used to search for determinants, which are the causes and other factors that influence the occurrence of disease and other health-related events. It is must for all to know about all the diseases, whether we are treating a person is being benefited or not. Is there any benefit? Is there are any risk factors attached to this disease? And how can epidemiology help us as clinicians? Science is a process of systematically collecting and recording data about the physical world, then categorizing and studying the collected data to explain observed natural phenomena. The scientific method provides a way of understanding the world around us, and its purpose in medicine is to attempt to get at the truth. We need to judge the claims about the treatments, various treatments, as rightly said by Dr. Tuli. He has seen those changes over the years. So whether those treatment was right or wrong, well, the time will tell, and it needs to be claimed by epidemiologists, or you can call evidence-based. We need to find the risk factors. These are the patients which were taken as, these are not the patients, these are the general population which was covered in the study. Osteoarthritis is a degenerative joint disease involving the cartilage and many of its surrounding tissues. In addition to damage and loss of articular cartilage, there is remodeling of subarticular bone, osteophyte formation, ligamentous laxity, weakening of periarticular muscles, and in some cases, synovial inflammation. These changes may occur as a result of an imbalance in the equilibrium between the breakdown and repair of the joint tissue. Primary symptoms of osteoarthritis include joint pain, stiffness, and limitation of the movement. Disease progression is usually slow, but can ultimately lead to joint failure with pain and disability. Again, we can define osteoarthritis as radiological, clinical, or subjective. There have been many attempts to accurately identify and grade radiological disease in osteoarthritis, and it is most widely used in studies using the Caligna and Lawrence scores. The overall grades of severity are determined from 0 to 4. Is there any association of clinical and radiology? Individuals with early painful osteoarthritis may be free from radiographic changes, and conversely, those with severe radiographic changes may be entirely asymptomatic. We have seen many patients with gynoverum walking very fast. There is a correlation between the severity of radiographic disease and symptoms. However, the association is not very strong. Osteoarthritis is the most common joint disorder now. Among adults 60 years of age or older, the prevalence of symptomatic knee osteoarthritis is approximately 10% in men and 13% in women. The number of people affected with symptomatic osteoarthritis is likely to increase due to the aging of the population and obesity, which is now at present is an epidemic. If we see the prevalence of osteoarthritis knee in the world, the Asian countries is topping that list. And you can see that in Japan, it is somewhere around 45 to 49%. Prevalence of knee osteoarthritis changes with age. As you can see, men and women and total is keep on increasing as age grows, but women surpasses the men in every age group. We have seen with the KL grading of knee x-rays also, and we found a difference between the big city, small cities, town, village. Why this difference was there, nobody knows, but the difference was there. We try to find this question. This study was done by Agra IOACON. We found that there is a change of this change is corroborating the world data. There is a sex distribution also. Prevalence in women was more as compared to the men. The sex ratio was not that significant. So there was 28.8 in our study percent of the female who was found to be osteoarthritic with KL score, there is a BMI difference. So the obesity has a significant effect on the osteoarthritis, 35:26. Whether the physical activity, as we keep on saying that the worker who is doing physical activities much more as compared to the sedentary workers will have more osteoarthritis. So here we found that sedentary worker was having more osteoarthritis. So if you don't use your knees, there are chances that osteoarthritis will be much more as compared to active and physically demanding person. We have done this study also, the toilet type of toilet use. So Indian toilet versus Western toilet, and surprisingly, those who were using Western toilet was found to be more osteoarthritis. Converse to our perception, as soon as patient comes to us and we say that don't use Indian toilet, go to the Western toilet. The swelling on knee and osteoarthritis status, swelling is most of the time present in 36.9%, but it is never found or sometimes found in majority of cases. So swelling is not the sign to look for in osteoarthritis. Grinding of knee is again not a good sign to find. If it is there, it is good, 39%. It is corroborated to the osteoarthritis, but it was not found in 33.7 plus 25% cases of the osteoarthritis. Whether catch is important or not, it is sometimes important. So catch, if you are finding catch, that may be because of the loose body. Pain severity from getting up from sitting and its osteoarthritis status. If there is a pain is very severe, then the chances of getting osteoarthritis is much more moderate. Moderate and severe you can find in the osteoarthritis category. While going upstairs, climbing staircase, if you are finding pain when going upstairs, the chances are that you are having osteoarthritic changes. Bending knees, if it is there, the chances are that you are having osteoarthritis. Pain severity while getting off the toilets and osteoarthritis status, if it is there, it is again like same, it is moderate to severe, then chances of having osteoarthritis is much more higher. Then comes the demographic characteristics and family history. This is the paper which showed that 2 new studies showed that having a parent with total knee replacement was associated with greater knee pain prevalence and worsening, as well as greater medial joint space narrowing over time. Obesity and metabolic syndrome, as I said, that obesity has a definitive reason to have more osteoarthritis. So this paper presented that obesity accelerates progression of knee osteoarthritis, and higher baseline serum leptin was also associated. So this means that obesity may be working with some metabolic type of pathway. So we need to find the ways and means by which the serum leptin level can be reduced. This was also, there is a strong evidence for higher serum lipids and moderate evidence for obesity as risk factor. So if it is found that serum lipids are in the patients, if serum lipids are high, the chances of getting osteoarthritis is higher. We can work on those lines also. This systematic review found strong evidence for high serum lipids as a risk factor for knee bone marrow lesions among individuals with asymptomatic pre-osteoarthritis and established osteoarthritis. If the role of lipid is confirmed, this may be an early modifiable risk factor. Nutritional and vitamin factors. Greater baseline milk intake was associated with less joint space narrowing over 4 years among women. So we have started saying that milk is not compulsory, but now orthopedician may come and say the milk intake may reduce the chances of getting osteoarthritis. Individuals with osteoarthritis showed an association between vitamin D deficiency and greater progression of symptoms and joint space progression. The latter was accentuated among individuals with high parathyroid hormone. We also see that if patient is having osteoporosis as well as osteoarthritic changes, you correct the osteoporosis, chances of getting better is much more higher. Individuals with extreme high bone mass had a greater prevalence of radiographic hip and knee osteoarthritis than control population. Smoking, it is a finding which is not corroborative to our understanding, but smoking confers moderate protection for knee and hip osteoarthritis. However, smokers have a somewhat increased risk for painful osteoarthritis. So osteoarthritis may be less in smokers, but if it is there, the pain will be more. Bone and joint shape. The study found difference in hip shape between knees with and without lateral knee osteoarthritis. Also found related sex differences in the hip shape that may help to explain sex differences in lateral knee osteoarthritis. Knees with lateral compartment osteoarthritis were associated with reduced femoral offset and increased hip height center, more valgus neck shaft angle, and increased abductor angle compared with knees without osteoarthritis. Women also had reduced femoral offset and more valgus neck shaft angle than men, potentially clarifying sex differences in prevalence of tibiofemoral osteoarthritis. Injury, as we know, that traumatic joint injury is a major risk factor for osteoarthritis, particularly at the knee, that is meniscal damage, anterior cruciate ligament rupture, or direct articular cartilage injury. But there is a recent systemic review of 20 studies supported that osteoarthritis linked by demonstrating the patient with anterior cruciate ligament deficient and reconstructed knees had altered synovial fluid biomarkers levels indicative of osteoarthritis compared with the controls. So reconstruction or no reconstruction, in both cases, there are chances of getting osteoarthritis. Surgical reconstruction as a strategy to protect against knee osteoarthritis is questionable. So saying patient that you will be better off if you get your ACL reconstructed is not right. In the National Swedish Patient Registration, the hazard of knee osteoarthritis over an average of 9 years was higher among patients with reconstructed cruciate ligament injury than those treated non-operatively. Muscle strength and mass. Recent reviews concluding that muscle weakness may confer risk for knee osteoarthritis, onset and progression. The specific role of muscle strength and mass in osteoarthritis, structural development and progression is still somewhat unclear. Muscle strength appears to play a role in knee symptoms. Joint loads. Overweight women without knee osteoarthritis found an association of varus alignment with incident radiographic but not symptomatic knee osteoarthritis. Greater odds of structural knee osteoarthritis progression with increasing knee adduction movement. Although knee alignment is clear predictor of knee osteoarthritis progression, findings are inconsistent for knee osteoarthritis incidence. So having a varus knee or valgus knee should not be operated on this pretext that it will reduce osteoarthritis. Now it comes to occupation and physical activity. The study confirmed that meeting physical activity recommendation was not associated with radiographic or symptomatic osteoarthritis compared with less activity. Individuals who met physical activity recommendation were not more likely to have either radiographic or symptomatic osteoarthritis than those who were less active. Limb length inequality, an important relationship between limb length inequality and prevalent radiographic knee osteoarthritis, particularly in shorter limb. So, great joint level risk factors, greater infrapatellar fat pad, maximal area was significant and beneficial associated with change in knee pain. Tibial cartilage volume and risk of medial cartilage defects among women over about 2.5 years. So those having a fat pad, good fat pad, chances of getting them pain is less. Squatting, this is, we always ask patient not to do any squats. But here is a study which says the apparent high risk for degenerative changes such as osteochondrosis dissecans of the odd facet in deep squats, as suggested by Escamilla, seems unfounded, and it is unproven. In deep squats, neither anterior nor posterior shear forces may be expected to reach magnitude which can harm an intact anterior or posterior cruciate ligament. So you can always ask patient to continue squatting if he is doing that. Conclusion, the traditional epidemiological studies and mining of large health administrative database show a large and increasing impact of osteoarthritis. Risk factors with strong evidence for osteoarthritis onset or progression include age, sex, socioeconomic status, obesity, family history, joint injury, joint alignment, and occupational joint loading. Risk factors with emerging interest or evidence for osteoarthritis onset and or progression include metabolic pathways, serum leptin levels, joint shape, bone density, limb length inequality, muscle strength and mass, and early structural damage. Osteoarthritis is a complex and multifactorial. Future epidemiologic studies should consider interrelationship among potential risk factors. The thing which I wanted to say was that in this, it is not supported. These studies are not supported by market. So we need to support these studies from Indian Orthopaedic Association. These epidemiological studies is must for the association to learn. Thank you for patient listening. Thank you, sir.
Thank you, Sanjay. You have covered extensively so many variables which affect the outcome or the osteoarthritis, especially the one you talked about, the knee flexion or squatting. You said rightly that it will not affect the osteoarthritis. Yes, the cartilage gets its nourishment only by the movement. And if you stop doing that movement, certain part of the cartilage will not get the nourishment. Then that is the reason why people who squat probably get the osteoarthritis little later. Thank you very much. We have the next speaker, Dr. N.J. Karne, Secretary of Maharashtra Orthopaedic Association. He will be talking on, we also need justice, appeal to all doctors to and consumer forum. Yes. Yeah, Pradeep. Dr. Bageja, yes.
It was a very good talk, Dr. Chaturvedi. I want to ask you as a practitioner, what do you advise now to a patient? What is to be avoided, do's or don'ts for OA at 55 years female coming to a clinic?
About the squatting or about the obesity, you have many things which a patient wants to know.
Only 5 tips.
5 tips. Reduce your weight. Continue whatever work you are continuing. For osteoporosis, get the best possible treatment. If there is vitamin D deficiency or if you need bisphosphonates, that can be started. Those things can be given.
My question is, like you just shown one paper. In Indian toilets, knees are better, right? In our scenario, I feel, in my knowledge till now, if you do the knee movement from 0 to 90 degrees, it's very comfortable. Like 90 degrees right now. If you cross the degree more than 90 degrees, it becomes painful. You're overstretching all the ligament, meniscus, degenerative, everything. So what is the takeaway? You advise them to go for cross-tech or Indian toilets right now after the paper?
This is what Dr. Shivshankar has told.
No,
that
I'm asking your opinion now.
In my opinion, in my patients, I always allow, if the patient is continuing sitting on this Buddha's position, squatting, and she was doing that, I will not ask her to stop doing all those activities. I ask her to continue all those activities.
Thank you.
You can go here.
The debate between the squatting and the cross-leg sitting in the knees in Indian scenario, it depends whether you are getting up from the sitting position or the squatting position. If patients do the same activity on the bed, they are squatting on the bed or they are sitting cross-leg on the bed, they don't get up on the bed. So I promote them to have all these movements on the bed so that they can get down, but not when they are sitting on the floor. So they should avoid getting up from this position. Then there is loading and there is more osteoarthritis. And rather than just that particular movement without any loading.
For that purpose, there was a squatting paper also. If you see, that is for the weightlifters. So they are doing all those weightlifting with squatting. And even after that, there is no problem. So if somebody is doing those movements, we can ask them to continue. Need not to stop. That is the thing.
Paper need to be changed here. It's the wrong one.
Dr. Karne.
Sir. They have put the DVT practice in India here. That's why I said.
They have got as per the list.
You put two later. Well, I thank at the outset to the to Honorable Dr. Meena, Dr. Shivashankar sir, and the team Mini IOACON for giving me the opportunity to give this little bit out of the box presentation. That we always see that the consumer forum looks after only the consumers, but then the time has come that consumer forum should look after the doctors also. So here the cry of the doctor that we also want justice is a doctor's sincere appeal to the consumer forum. Well, initially, I disclaimed that I have got utmost respect for the judiciary and members of the consumer forums. There is no intention to criticize these highly respected institutions. But whatever I'm going to say has come out of the observations of the verdicts of last few years. In the Indian scenario of the infrastructure and the affordability, most of the doctors are trying to give the best possible treatment for their patients. But somewhere there is a gross disparity in actual cause of the patient grievance and actual reason for which the doctor has been held guilty. Maybe because the lawyer of the doctor may not have pleaded precisely, or maybe the doctor wasn't aware of the importance of certain non-medical issues as compared to medical issues, like adequate documentation, thorough counseling of the patient, and precision in taking the consent. Well, Consumer Protection Forum was created to protect the customer from cheating by the vendor in quality, quantity, or the cost of the product which he buys from the vendor. Later on, the service sector was also included in this, but surprisingly, lawyers are excluded from this. This act was great relief for a common man to address his grievances. We agree that everybody has to abide by the law of the land, irrespective of his position and the status. Everybody has to follow the basic norms in the service sector also, including healthcare. We agree that there are some black sheep in every field, and they should be found out and be punished to maintain order and the discipline in society. But, Your Honor, the doctors are supposed to be the intellectual cream of the society. They're always topper in their academics. They do a huge study, hard work, and total dedication of more than 10 to 15 years to become a consultant. Their real earning starts at the age of 35 years, while all other IT people, they start at the age of 20, 25. Doctors are trained and always try their best to understand, analyze, and diagnose any condition and follow the procedures meticulously. In practice, most of them are honest and try their best for the society. They are one of the most law-abiding citizens. In the recent pandemic, it is seen that they have risked their own life as well as family members' life for treating the patients. Your Honor should understand that there are different kinds of hospital, corporate, government, and small to medium nursing homes. And there is a huge difference in infrastructure, management, and the work responsibility and accountability of doctors as well as other staff and the management. Small nursing homes can't have all these facilities. They can't have high-end equipments, huge staff as in corporate and big hospital, but still they are giving the best possible results. Again, in the teaching institute also, a resident is just a trainee doctor and he's not responsible in decision-making as well as for the management decisions. But still, they are slapped or beaten due to faulty CT or delayed MRI scan. In big hospital also, it is wrong to hold consultant guilty just because oxygen was not made available to the patients by the management or CM or drill malfunction during surgery, because doctor has been held guilty by consumer forum for this reason. A doctor shouldn't be held guilty when the correct order is written by him, but the nurse in the night duty gives wrong injection. You can't hold doctor guilty if the patient jumps from the top floor or if a night staff molests any patient, any woman in the government hospital, especially in the government hospital. Because if this happens in the court premises, whether judge will be held guilty for that? Why this vicarious responsibility only in the medical profession and not any other profession? It is the responsibility of the government actually to provide the reasonably good healthcare in the minimal cost to the citizens. We have got a right to the health. But government is spending hardly 1.25% of GDP on health as against 10 to 15% by developed countries. We are fourth lowest in the world. In real life, all of us are knowing what is the situation in the government hospitals. It is a failure of the government that they can't provide the cheaper and good quality health care. But this gross lacuna is filled by the small and medium nursing homes. 80% of the Indian population is treated by them at the a reasonable cost. They are the backbone of the healthcare in India. But its existence is now getting threatened by the wrong government regulations and undue expectations from the judiciary. This small nursing homes is the once upon a time was the dream of every doctor, either by himself or by the group of doctors now. But now the situation has become very pathetic. On one side, it is considered as a very noble profession, but on the other side, all laws of the government like industrial establishment are applied to the nursing homes and the hospitals. You have to have a commercial land infrastructures where there's 200% increase in the cost of this. The doctors and the whole hospital have to follow all the rules of the labor, pollution control, bio-waste management, as well as the FDA and whatnot. They have to pay all the similar taxes, similar to the lawyers, CAs as the architect, but nobody expects charity from these lawyers, CA or the architects or the hotel owners. Doctors now have to follow all the draconian laws of the government like CA, Epidemic Acts and MESMA. Still in these small nursing homes, it's better for the patient because they get personal attention and affectionate treatment. The bills are much, much less, even less than 20% as compared to corporate hospitals. But of course, patients are alleging there also that doctor is looting and the society also feels like that, and that has an effect on the judiciary. The doctors in the small nursing homes have been trained to take the utmost care while treating patients on medical grounds, and they have to keep themselves updated till the end of their life. As Dr. Tuli has said, we are students forever in our life, even at the age of 90 to 93. But in the medical curriculum, nowhere it is taught that what medical legal precautions have to be taken when they become a doctor. They are not taught what laws are applicable to them. There are 139 laws are applicable to the doctors or to the medical profession. How many of you are knowing this? They are not taught how to do the hospital management. What is ideal consent? What are the documentations? Most of the doctors have learned from the previous judgment which had gone against the doctor, where doctors are penalized. Doctor wish to abide and follow the laws in the best possible way. But he's held responsible for anything which is happening in his nursing home, so-called vicarious responsibility. So he has to be dependent on the God. He prays God every day because he's in stress at every moment, 24/7/365. He has got his nursing home infrastructure according to norms of the local municipal body. He takes a permission from that, and it is adequate for treating his own patients also. But doctor, he's not sure whether the court thinks that this particular infrastructure is sufficient to treat his patients. They decide that the hospital was not properly sufficient. There are no definite guidelines. What a MS orthopedic should treat, what a D ortho should be treat the patient. There are again role of nature into this, which is not there in any other field. The nature doesn't follow human laws. There can be unpredictable results under different turns of events while treating the patient. Judiciary should understand this. The diagnosis of the patient involves many steps. It is a process where many investigations may be necessary. All patients may not afford all the latest investigation which may be required for precise diagnosis. Sometimes accurate diagnosis is not possible in spite of all known methods of evaluation. Sometimes certain symptoms and signs can show up later in the management. There is ambiguity in diagnosis also, especially in the imaging like X-ray, ultrasound, MRI, even biopsy also can change from doctor to doctor. These are interpretations, and human error is possible that has to be understood by judiciary. Sometimes the diagnosis is very obvious, spot diagnosis, but in few cases there is a gray zone, and because of there are different interpretations even by the experts, and that is called as a differential diagnosis. Of course, the final diagnosis is going to be only one, even though there is a differential diagnosis. And sometimes when the last doctor, he proves to be correct over a period of time, in such circumstances, is it that all the remaining doctors, previous doctors, are criminals because their diagnosis did not prove correct? Dr. Street tries to treat according to protocol which is decided by the current medical science, and errors of the judgments, all professionals, rather they are far more in judiciary. Now, in need of the ICU for all surgeries. It is not possible to have ICU in every nursing home. Every doctor is trained for giving emergency life-saving resuscitation, but for further continuous management in the emergency, ICU may be required later on. Even though this happens exceptionally, doctors have been penalized that he operated a patient when he did not have in-house ICU. So if judiciary feels that for every surgery, ICU facility is mandatory and it has to be implemented strictly, the whole healthcare system will break down. Glimpse of it has been observed in the current COVID epidemic that India has got hardly 5% ICU availability than required one. How patients will get their surgery done? There are limitations for medical treatment. When a thief acts, his basic intention is criminal, but a doctor is basically not a criminal in nature. When patient comes for treatment, doctor doesn't have a criminal intention to spoil the patient. There were days when doctors were so much confident that when we have done medically perfect management, we need not have to fear if the results desired result has not been achieved. Sometimes a known complication can develop, for which further management is also required, but doesn't mean that the concerned doctor has done negligence during the previous treatment. Complications happen during treatment by everybody, whatever his competency, his experience, his knowledge, and his qualification. And this is a known fact in the medical management, which a judiciary should understand. It's not like a machine. The results of the given treatment are predictable. Anything can go wrong. There are many lacunae in existing knowledge also of the medical body, human body. We can say that we have understood very, very little about human body. Sometimes response from the patient for a given treatment can be unpredictable. It is all probability. There are a lot of individual variations. The effect of one drug may be totally different in different persons. Same drug may not act in certain patients, while in others it can give excellent results, while in others it can produce serious complications. Same for fracture fixation. It can heal fractures in most of the patient, but in some, healing takes very long time. And while in some, healing doesn't occur at all if it is not intervened by the second operation. The other limitations are like this, that it is like a classroom. The teacher teaches same to all the students in his class. Some excel brightly, while some fail miserably. But just because the agreed parents had paid same amount of the fee, they cannot expect and demand same result for their failed candidate. And judiciary also doesn't punish the teacher for the failure of their candidate. Why, doctors? Errors of the judgment are there in every field, even judiciary. A lower court finds an accused completely guilty, while the higher court finds same person not guilty and releases the accused. It has happened in many cases, even in Salman Khan it has happened. Now, is it that when the higher court overrules the judgment of the lower court, in toto, the lower court should be punished for the error or the wrong judgment? And same situation can be there in medical field. But when there is an error in the judgment, a doctor is punished. Non-complication is taken as a negligence. It is always said reasonability in the treatment is required. But then who decides this reasonability? Actually, it is supposed to be the medical expert committee who is supposed to decide that. But there are problems with the expert committee as the limitations. Sometimes there is a forensic expert in this medical legal committee. It is not correct to take his opinion in the clinical management. The forensic experts are expert in the forensic science, like homicide, suicide, and the rape, etc. They are not expert in the clinical management. Sometimes they are mainly administrative in nature rather than the academic one. They may not be aware of the new technique or the view. Because why I'm explaining this, because one of the cardiothoracic surgeon, renowned cardiothoracic surgeon who is in practice for more than 30 years, was held negligent in a highly complicated cardiac surgery by the forensic expert in the expert committee. And he was the only one who gave negative opinion that was taken by the judiciary. There can be a bias of jealousy against the private practicing doctors by the expert committee. The judiciary should understand this, that science is rapidly expanding with grassroots change in the norms, just like COVID, that the norms are changing every now and then. Whether doctor has done any fault of the omission or the commission, only expert having the experience and the knowledge in that field should tell that. It has happened that one of the renowned senior orthopedic surgeon has commented that simultaneous bilateral TKR should not be done, and the doctors there were penalized, their registrations were cancelled for 1 year when that particular doctor who has never done joint replacement in his life. So expert opinion should be done by the expert of that particular field and the technique. So what I suggest that better take opinion from the associations at the state or the national level, which are mainly academic one. On top of that, even when the expert committee relieves the doctor of his negligence, there is a Bolam rule, which is a draconian rule, that judiciary can override the medical expert committee opinion. They are deciding what is correct and wrong. They are the one who are now become medical expert about everybody else. And sometimes they say on humanitarian ground, we are giving the compensation to the patient. No, what is this humanitarian ground? Doctors don't require any humanitarian view. So that is situation. Another part is Western norms. Western standards may not be reasonable for Indian scenario in this condition, especially at periphery. They are saying don't operate if there is no accreditation. They say you require in-house ICU, you require only highly polished joint replacement OT to do those things. There is the different quality in Indian infrastructure, and the civil norms are meant for that. Another part was that all nurses should be JNM. Are there adequate number of the JNM nurses in India that they should be given to every nursing home? Doctors say to recruit them, but are they available? Then again, super specialty conflict, like whether spine surgery should be done by an orthopedic surgeon or the plastic surgery should be done by them. We fully agree. Another part is the documentation. Yes, we are poor in documentation, and we agree that adequate documentation is a must. But there are no guidelines anywhere. What is adequate? How much is adequate? Even for a minor lacunae of the change in date, or there is no sign, or even if there is a CT all, minor investigation has not been sent, the doctor has been made guilty and punished. About the consent, what should be the ideal consent of the blood transfusion and the rare complication? Because the complication which occur in that patient, if that is not mentioned in the consent, then doctor is guilty. But if that complication mentioned in the consent, even if the patient has got that complication, doctor is not guilty. So what is important? Documentation is important, or the medical management is important? Doctor is sued for alleged negligence in the medical management if it is especially if it results in the death or the undesired result. And doctor is punished severely and extremely, not for negligence in medical management, but for the minor lacuna in the documentation. But this has occurred especially for the ultrasound, examination, a form. If you don't sign the form, you are held guilty of the female infanticide, not sex discrimination alone. And doctors have been punished for 2 years. Is it that if the lacuna had been filled, patient wouldn't have died or the complication would not have occurred at all? Is it so? Another part is the ridiculous quantum of punishment. Many times huge penalty or even a small error while treating. There is no specification of the quantum of the penalty for a given error. How much is a minor omission in the consent and how much is the for no consent at all? There has to be some difference in this. Even after taking utmost care, if the minor investigation is not done, he is punished. There is some clerical error, as I said, even forgot to sign on the paper, they are held seriously punished. The quantum of the penalties are already high. And now there is a 10-fold increase in the penalty by the consumer forum. It will be almost impossible to practice now, because a small error in the documentation can ruin whole life of a doctor. Doctor is more worried now about the medical risk than the medical risk. He has to take care of a legal care first. He has a concern of the legal problems before thinking of the medical issues. This is one of the most important reasons for increased number of the expensive investigations for which doctors are alleged. But if this fear among the doctors is not addressed, those who have got choice will opt for other fields. Once upon a time, the intelligent cream of society was choosing medical field, which was resulting in the high quality care to the society. But now there are more of a capitation students than the merited one who are seeking admission to the medical line. And merited students are either opting for other fields or the doctors are going outside India. On one side, there will be more commercial hospital in future and doctors will become slave of these people. On other side, there will be only government hospitals to get treatment from. Results, the individual doctors and the small and medium nursing homes will perish over a period of time and a common middle class will suffer seriously. Its effect on the society will not be seen now, but around 20 to 25 years later, it will be seen and then it will be too late. Thank you very much.
Thank you, Dr. Karde. You have elaborated all the points very meticulously and so clearly. Yes, it's with so many laws now we require to follow as a small nursing home owner. It's really difficult day by day to run the setup. Thank you very much.
Thank you.
May I invite Dr. Jyoti Prakash for his. Yeah, I miss. Yes, Tuli sir. Karne, Dr. Tuli sir wants to ask a question. Yes. So Tuli sir first.
I'm standing here first.
Yes, correct.
Yadav.
And you are senior,
Thank you
sir.
very
You are
much.
elder brother
I was
Yadav.
standing- I think whatever you have said is absolutely relevant to the present doctors. I think how do we convey it to the judiciary? I'm not quite sure. But if you look at the broad scenario, most of the time, it is one of us who denigrates the other people. I would make a plea to all of us. Let us not denigrate a colleague. And that is one thing on which we have a control. If we are going to denigrate people, then it's going to be a very tough job. I would just give one example here. One of the orthopedic surgeons in Delhi was treating tuberculosis of the ankle joint. A patient goes to the court. Sir, tuberculosis cannot be treated by an orthopedic surgeon. It should go to a tuberculosis specialist. I'm just telling you what the society is capable of doing. Ultimately, the case went to the court asked some experts, by chance they asked me, how is this orthopedic surgeon writing tuberculosis? I said it's tuberculosis of the bone, not tuberculosis in general. So ultimately, my book acted as a defense for the doctors.
Yes, sir.
But somebody must have told the patient, "Arey, ye tuberculosis hai, it should be treated by a TB specialist. Why an orthopedic surgeon is treating?" So this is where I think we also can protect our own.
Yeah, thank you, sir, because these are the two issues sir has raised. Actually, one issue is about the who should decide what is the correct treatment given by the orthopedic surgeon. So I appeal the apex body, that is our Indian IOA, that we should form a definite protocol that if the doctor follows that particular protocol, then he should not be held guilty, and that should be taken by the court. Now, I had discussed with you because this lecture was first given to the law college, where even the judges of the consumer forum were there. It was appealed to them at that time. What I came to know that this should happen only at the national level. So our association should talk to the either law ministry or the government or the Supreme Court. They should have an across the table discussion. It is for the benefit of the patient as well as for the doctors. And then they should form such a protocol that if doctor follows that protocol, he will not be held negligent in that particular case. That is one part. Second, as you said about the tuberculosis, that is a problem. We are only concerned as a surgeon of the tuberculosis. I mean, tuberculosis of the knee should be operated by orthopedic surgeon, but he should not decide the medical management. Then he should be referred to the tuberculosis expert, the chest expert, and who decide about the medical, this particular management. Of course, up to certain limit, even in my case, the primary treatment is given by us only when it is a resistant tuberculosis. We refer it to the chest physician for the further medical management. But then if this protocol is decided by our apex body, Indian Orthopaedic Association, then the doctors can practice fearlessly. Thank you, sir.
Thank you. Well, I must congratulate you for bringing out some of the important points to protect the doctors. And I would request the president to ask Dr. Kame. Dr. Kame, you should send a copy of your presentation to the president so that Indian Orthopaedic Association can take care of all these things to protect the doctors. I think it's a very good presentation. I must again congratulate you.
Thank you, sir.
And you should send a copy. Mr. President, please take a note of that.
Yeah, definitely, sir. And incidentally, Dr. Karne is the legal head also, chairman of the. Yes, Dr. Kanabar, sir.
In late 90, I had written a paper, Doctor-Patient Partnership, in IMA journal, which is very important. I think I'll send you the copy. One more thing, earlier we were publishing white papers, IOA. They were done for the purpose of courts to know that this is what IOA is advising. Unfortunately, we have stopped doing that. So you can redo it.
I got experience also because I am a member of the IMA Pune as well as the Hospital Board of India IMA Pune. There I insisted them that we should concentrate more on the problems of the individual doctors of the allopathy, like violence or these medical legal issues, but they are more concentrating on the cross patches rather than this particular part. So they have different priorities. But if they take up these issues, then the doctors will be definitely relieved. Thank you, sir.
Thank you, Dr. Narayan. Yes, Dr. Jyoti Prakash for his talk on limb salvage surgery in osteosarcoma. After this talk, Dr. C.P. Paul will be giving a virtual talk on primary THR in difficult situation. By the time we can also break for lunch at that time, so that we can see from all the screens put up everywhere. Yeah, please.
Many thanks to the organizing team and organizing committee for the chance to speak on the podium. My topic will be the limb salvage surgery in the osteosarcoma. We have traveled a lot. When there was the tumor of the limb extremities, 100% most of the cases were treated with the amputation. But now the scenario has changed. 90%, around 90% cases of the tumor are being treated by the limb salvage surgery with success rate of around 65 to 80%. So what is the limb salvage surgery? It's a set of surgical procedure designed to accompany removal of a malignant tumor and reconstruction of the limb with an acceptable oncological, functional, and cosmetical result margin. So all the word that is oncological, functional, and the cosmetical result are important for the complete definition of limb salvage surgery. So what is the oncological aspect? After the tumor surgery, we should achieve adequate margin. What is the adequate margin? It's a matter of controversy. Earlier days, it says to be called quantitative margin, so that someone will say 2 centimeter of the normal tissue, someone will say 3 centimeters, someone will 5 centimeter. But now we are the general opinion, according to the Kawaguchi classification, the margin have been two types, thin barrier and the thick barrier. All the tensor fascia lata, cartilage, joint capsule, muscle, sorry, vascular sheath are considered to the margin, adequate margin. And the cartilage per se, if the cartilage is preserved, it is taken to be the 5 centimeter of the adequate margin. Now comes the functional aspect. After the removal of the tumor, the remaining limbs will be functional. So when to go for the limb salvage surgery? The bone tumor of extremities in which surgical margins are achievable, local recurrence should not be greater than the amputation, and survival should no worse than the amputation. The treatment or its complications should not delay the adjuvant therapy, as we know that after the intervention of radiotherapy, chemotherapy and all, the tumor survival rate has increased a lot. That reconstruction should be enduring and not associated with a large number of complications which require secondary procedure and frequent hospitalization. So what are the barriers to the limb salvage surgery? The first one is poorly placed biopsy incision. Biopsy, which is considered to be the eyes of the oncosurgeon, it should be done properly. It can be done by the junior resident, but should be done under the direct supervision of the treating surgeon. When there is a major vascular involvement, when there is encasement of major motor nerve, we should not go for the limb salvage surgery, because after that we won't give the functional limb. Also, when there is a pathological fracture of involved bone, there is an infection, and there is chances of inadequate motor after the resection, we should not try for the limb salvage surgery. So if summarizing this, if any of the four, that is the bone, nerve, vessel, and the soft tissue envelope, any of the three is involved, according to 3-strike rule, we should not go for the limb salvage surgery, directly go for the amputation. So talking to the osteosarcoma, this is the final protocol what we follow in the daily practices. After the first neoadjuvant chemotherapy, it can be different cycle will be there. It can be MAP, that is the methotrexate, adriamycin, cisplatin. There can be AP regimen, APIM regimen, or IEP regimen. After the neoadjuvant chemotherapy, you have to assess if there is a tumor improves, we have to go for the limb salvage surgery. After that, again, we have to go for the adjuvant chemotherapy. So neoadjuvant chemotherapy, what advantage we will get? It will reduce the tumor and the surrounding inflammatory edema reaction area, and also it will control the primary lesion and kills the distant micrometastasis, what we see in case of the osteosarcoma very commonly. But it has got the disadvantage of it can reduce the physical health of the patient as a side effect of the different oncological medicines. So after the neoadjuvant therapy, when we should assess whether we to go for the surgery or not? It is advised at least 2 doses of the medicine, or at least 1 cycle should be done. Then we should assess for the clinical symptom, whether the pain and swelling has improved or not. There is a sign of the ossification in the matrix of the tumor or not, and imaging modalities where we are getting the resectable margin or not. So if we are well convinced, yeah, the chemotherapy is sufficient, so we should go for surgery. It should be done priorly within 3 weeks of the last dose of the cycle. But if the tumor grows in size for more than 30%, and if brought the pseudocapsule, the surgery should be done immediately. So coming to the limb salvage surgery, the first step of the limb salvage is resection of the tumor. In this step, we have to follow the principle of surgical oncology. After the resection, we will get the gap, which should be reconstructed with the proper implant, proper other methods, where we will follow the principle of orthopedic surgery. And after the reconstruction, the job is not over. We have to get the functional limb, though, so the rehabilitation should be properly. So coming to the reconstruction, it can be non-biological or the biological. Yesterday, we have a Diamond Jubilee audition talk with our Yadav sir. We are very well convinced. In the past 40 years, we have seen a dramatical result, very good result with the use of the fibula. This was a part of the biological treatment, but now I would like to add some points, sir, for the non-biological therapy also. So non-biological part, most commonly what we use the endoprosthesis. It is a large metallic device designed to replace the excised length of the bone and the adjacent soft tissue. It has got the hinge. Nowadays, design is made of the hinge joint, which is made of titanium, either or cobalt, chromium, the molybdenum material. there is a lot of evolution in the process design, starting from the modular, starting from the custom made to now modular processes. What was the problem with custom made? It was the cheaper in the cost, but it was the time taking. It may take up to 2 to 3 months for the preparation of the exact size of the processes. Now we have available with the modular processes, which give flexibility for the surgeon, and any defect can be handled on table without any waiting time. Earlier it was first generation, now we are the second generation. What we use is the saddle window processes for the pelvic tumors. We can use MSRS, that is a modular segmental replacement system, or GMRS, that is a global modular replacement system. In India, what we are using a restore system. So what are the advantage? What we get over the biological therapy? It is cemented stem fixation. So early mobilization and early weight bearing can be started. There is the multiple diameter stem, so we can use the maximum size of the diameter so that fixation with the bone will be the utmost. Also, we have got the circumferential porous coating, which permits ingrowth of the bone into the processes and makes a pseudo capsule so that which will isolate the process from the periprosthetic fluid. We have got the rotating hinge joint so that there can be the circular movement also. And we have metal loops which permits dependable soft tissue reattachment and fibrous ingrowth into the processes. So these are the common processes what we have see, that is the proximal femur, saddle processes, proximal humerus, proximal tibia, and the distal femoral process as well. So at the advantage of the non-biological treatment, I already told, it will lead the immediate stability, quicker rehab with immediate mobilization, increased durability with the better implants, and the incremental limb lengthening. But every good thing has got the minus point. So it has got the negativity of the polythene wear. Also, there may be a septic loosening, implant failure, fatigue fracture. So this is the case of the osteosarcoma of the distal unit of the femur. Resection resection was done and treated with the modular processes. So we have some literature which support that the modular endoprosthesis replacement in the lower limb is doable long-term reconstructive option, with the implants generally outlasting the patients. Also, there is the complication rate. Revision required in 70% at the 5-year, 33% at 10-year, and 58% at the 20 years. So with this, now we're going for the biological reconstruction. The main part has been discussed yesterday. I will just other part, what we can use the viable bone or non-viable bone. In the viable bone, we have the option of the vascularized fibula graft, rotation plasty, resection arthrodesis, bone lengthening. The non-viable option, we have revitalized tumor bone, which can be done either by the radiation or by the cryosurgery or autograft or allograft. Coming to the vascularized fibula bone, as you can see in this picture, we can use the proximal fibula with the peroneal artery supply. It is safe and reliable for the intercalary defect, but it has the disadvantage when it comes to the joint tumor. Then it has got the immediate recovery of the physiological blood supply, but it has the disadvantage of scar supply. We have got the limited amount. We cannot construct the larger length. There is a chance of the late stress fracture. There is inadequate adaptation for the recipient, and also it's technically demanding as we need the help of the microvascular surgeon and the plastic surgeon. So another one is resection arthrodesis. When there is a large defect in earlier days, when the chemotherapy and the radiotherapy are not available, we used to go for the arthrodesis of the joint. As our Tulis already shown the lot of slides. Here defect is covered with the vascularized or non-vascularized fibula or iliac crest graft and allograft if applicable, and fixation is done with the plating or the nailing. What will be the final result? We will get stiff limb and the non-mobile joint. So functionally poor and need a prolonged immobilization so that graft should be incorporated. Another one is rotation plasty. It was first used by Salzer in 1974. What we did, the whole of the tumor limb has been taken out, and under the lower limb, the tibia is used in opposite rotation manner, so that the ankle joint will act as a knee joint, and after that we have to put the processes. Now we have the allograft, which is used for the biological fixation, and which provide the site for attachment of the soft tissue as an anchorage. But the problem is with the availability, because we don't have a lot of the bone bank in our setup. Also procurement, storage, immunological response, because there is a chance of the graft rejection a lot of times, and infection are the one of the major limiting factor. So coming to the devitalized bone, what are the option? Autoclave, of pasteurization, irradiation, and the liquid nitrogen. Nowadays, because constant, we are not using autoclave pasteurization. What we commonly use that is called extracorporeal irradiation. It was first used by Spira et al. In 1968. It is useful, convenient, and the cost-effective method. What we do, there is the in-block removal of the tumor-bearing bone segment. From there, all the soft tissue is being taken out. The tumor is nicely wrapped in the plastic wrapper, at least 3 centimeters of thickening. Then send it for the radiotherapy. There they use normally what they use the 50 gyre of the radiation for the at 6 megavolt X-ray for 10 to 15 minutes. There are studies which says it can be used up to 300 of the gyres, but still in which there will be large chance of cell death, but higher risk of the what we can say is the graft rejection. So this is the X-ray after this was the case of the GCT of the distal proximal tibia. After doing the DCRT, ECRT, this was the implant. Then after implant removal, this is the final outcome. So complication of the ECRT is your safety of the. It has got the advantage of safety of the healthy bone. It needs high dose. It gives us the size match graft, cost effective, and psychological advantage, so that patient is using its own bone. While it has got the disadvantage of wound infection, graft absorption, as we can see in this picture, the proximal humerus has absorbed, and also the implant failure of the graft. Now another option is cryosurgery. It was first used by the Markov and the Miller in case of the breast cancer treatment, breast cancer patient which has the proximal humerus. What we do is here, there are the 4 pillars of cryotherapy, that is excellent monitoring, because throughout the process we have to monitor the healthy tissue. Because if the liquid nitrogen will fall down over the healthy tissue, it will cause the devastating effect. What we do is a fast cooling, slow thawing, and repetition of cycle for at least 2 to 3 cycles. What will happen if you go for the slow cooling and the fast thawing? The desired amount of cell death won't be there. So how it works? It will cause the intracellular ice crystal and the membrane disruption, electrolyte changes in the cells, denaturation of the cellular protein, and the microvascular failure. We need at least 3 cell cycle for death up to 2 centimeters of the cavity. It has the different complications of the fracture, infection, skin necrosis, joint degeneration, and the nerve palsy of the procedure. So what are the newer recent advances in the treatment of the osteosarcoma limb salvage surgery? We have got the aspirin as adjuvant for the neoadjuvant therapy. What the dose is, commonly we use 100 micromole of the aspirin or 300 milligram. It acts via the NF-κ cell pathway. It will lead to the cell death. We have the extracorporeal shockwave therapy, which was originally used for the renal calculi. Here we get the sonobsorption of the tumor cell, and there will be the cell death. Also, we have the advancement in the evaluation of the evaluation, where we use HUFI, that is the high intensity focused ultrasound, which cause thermal effect and the cavitation effect. It also has got the anti-tumor immune system, which will lead to the cell death. There is the microwave ablation, where we use 900 to 2450 megahertz radio waves, which will cause a coagulation necrosis of the cells. As we have seen, there is the computer knee replacement, joint replacement. There is a CNS also, computer assisted navigation system for the tumor. Here we are getting the resection of the whole tumor, cutting of the allogenic bone, fixation and implantation of the prosthesis with the CNS technique is very much accurate, and chance of recurrence or chance of getting a negative margin is very high, so that recurrence will be very less. Which disadvantage? It includes the navigation facility heavy, experienced operator is required, and the operation cost is very high. So as we have since processes, if there is processes, the chance of infection. So how there is some advancement in that? We have got the silver coated processes, where there is the less chance of infection. In addition to that, research are going on for the iodine plated titanium alloy processes. There is a ketosine methotrexate titanium processes. So we are using the chemotherapy material in the process itself. So there should be less chance of the infection. So after the after surgery, our job is not over. Patient will follow up 3 monthly for the 2 year, then 4 monthly for the next 1 year, then half yearly for the 4th and 5th year, and yearly for the next 10 years. So concluding, the modern modular mega processes have allowed for the limb preserving surgery being the gold standard in the oncological orthopedic surgery. Biological reconstruction concepts are in trend, which needs further research also. However, additional improvement and advances are awaited in order to further improve the result of the surgery. Thank you.
Thank you very much, Dr. Jyoti Prasad. You have brought out very nicely that modern modular mega processing is the way to go now with all these cancerous conditions of the bone to save the limb. Since we are running late, any question will be taken with you directly. Friends, we have organizing chairman, Dr. Meena, and co-organizing secretary, Dr. Bansal, but there is no organizing secretary for this conference. But we all know the person behind Dr. Meena is none other than Dr. Arun Sharma. So I wanted him to give the talk because I requested him to give the talk because he wanted to skip his talk. I said, this is the only chance you are getting to speak as a speaker. So I request Dr. Arun Sharma, the undeclared organizing secretary of Mini IOACON 2021, to talk on DVT management in orthopedic, current trends and protocols. Please.
Thanks, sir. These are mind-boggling compliments. Actually, I don't know if I deserve all those credit and accolades from a stalwart like you. But the thing which I know is that I thank all the organizing team and the scientific committee lead, that is Dr. Rajiv Raman, Dr. Rakesh Bhargava, Dr. Sandeep Kumar, and all to allow me to speak and give me a chance. And the thing I know is that I am the person between lunch and us. So I will finish it very fast. So DVT, very pertinent topic, very large topic, very elaborate topic. It is very difficult to finish it in with 5 minutes, but I'll try my best to cover few bases. Venous thromboembolism is pathological entity comprising DVT and pulmonary embolism. Venous thromboembolism is a silent killer. Often it is detected too late. 80% cases of DVT are clinically silent. 50% of all cases of total fatal pulmonary thromboembolism are detected prior to death. The age-old varicose triad, we all know, we read in pathology. Pathological driver of VT, venous thromboembolism, there are 3 factors: vascular injury, venous stenosis, hypercoagulability of blood. And unfortunately, by the orthopedic surgery, that surgical trauma, it propagates all 3 factors. So these are various changes, pathological changes. Acute DVT symptoms, we all know: swelling, pain or tenderness, increased warmth, red or discolored skin. Orthopedics and DVT. Post-op swelling and pain is common after total knee replacement. Duplex is investigation. D-dimer can be falsely raised. Cough DVT has been reported with an incident up to 70%. Fatal pulmonary thromboembolism is a rare event after TKR. Inappropriate treatment of suspected venous thromboembolism is associated with significant morbidity. Hip and knee replacement surgical patients are at the greatest risk for venous thromboembolism. These are the diagrams showing the venous thromboembolism incidence. Rate of thrombosis in Asia is similar to patients in the Western countries. That is the crux of this slide. DVT in India, an under-recognized condition. Incidence of DVT in Indian patients is as common as elsewhere. Asian patients, Caucasian patients, Western patients, African patients, is all the same. 41.4% of the DVT patients were asymptomatic. Because of the silent nature of the disease and low autopsy rates, prevalence and mortality rate of DVT remains elusive. 2/3 with symptomatic VT manifest DVT. Prophylaxis in India is very low as compared to Western population. But the disease is no longer rare. This is data showing comparing South India, India and Asia. There is a landmark study by Dr. Sanjay Agarwala. DVT in Indian patients undergoing major limb surgery. Thromboprophylaxis by dalteparin sodium in elective major orthopedic surgery. This has been a prospective, open, non-comparative, multi-centric study with fragmented patients planned for THR, trauma patients and TKR interventions. There is another retrospective clinical data from SRMC Chennai. The result says the overall incidence of DVT in Indian patient was comparable. That is what I earlier said. Problem of compliance with VT prophylaxis guidelines in hospital. Diagnostic tool: a D-dimer assay, compression, ultrasound, impedance, plethysmography, MRI, and contrast venography. Other routine investigations, that is chest X-ray, ECG, ABG, ventilation perfusion lung scan, CT, angio. Other clinically relevant outcomes are reoperation for hematoma, joint stiffness, deep periprosthetic infection, bleeding related deaths, neuraxial anesthesia complications, heparin induced thrombocytopenia, epidural analgesia with indwelling catheter, and renal dysfunction. Treating DVT. Treatment of DVT can help reduce the risk of complications such as the fatal pulmonary thromboembolism. The main goal in treating DVT are to help stop the clot from getting larger, reduce the chances of having another clot develop, prevent the clot from breaking off in your vein and moving to your lungs. DVT prophylaxis, there are drugs, there are practical measures, then there is compression stocking, mechanical compression devices. Anticoagulant scenario has changed from 90s to this century. At present, there are direct inhibitors, oral epivaxaban, rivaroxaban. Issues of venous thromboembolism in orthopedics, whether to use VT prophylaxis, what prophylaxis, first dose, whether pre-op, peri-op, post-op, duration of prophylaxis, and other questions. Timing of anticoagulant therapy in orthopedic surgery. In Europe, the first dose of low molecular weight heparin is commonly administered the evening before surgery. In North America, the initial dose of warfarin or less common low molecular weight heparin is not administered until 12 to 24 hours after surgery. So these are two different school and different philosophy of thoughts. Increased thrombin generation, thrombus growth after 1 week. This diagram is showing it. Duration of thrombin generation is THR. This line diagram is depicting that. This is one of the largest clinical research program in anticoagulation, expands 60,000 patients across 45 countries. Appraised to clinical trial in patients, the ACS was stopped earlier due to an increase in bleeding, which was not offset by clinically meaningful reduction in ischemic events. The author of the advanced program includes Advanced 2, Advanced 3. Now coming to AAOS guideline, AAOS level of evidence, AAOS grading of recommendation. So AAOS clinical guidelines on prevention of symptomatic VTE in replacements, aspirin, low molecular weight heparin, synthetic pentasaccharides, warfarin. AAOS hip fracture surgery. For patient undergoing hip fracture surgery, the guideline recommend the routine use of a low molecular weight heparin, fondaparinux, or at the usual high risk dose, adjusted dose VK. The guidelines recommend against the use of aspirin alone. In surgery, if surgery is likely to be delayed, then it is recommended that prophylaxis by either a low molecular weight heparin and LDOH could be initiated during the time between hospital admission and surgery. Mechanical prophylaxis is recommended if medication is contraindicated. Extended prophylaxis is recommended following hip replacement for 4 to 5 weeks. Then there is ACCP recommendation, thromboprophylaxis for at least 10 days with medicines. There's the ACCP recommendations. Is outpatient treatment safe? Low molecular weight heparin at home is at least as safe as inpatient treatment for DVT. Little evidence exists regarding outpatient treatment of pulmonary thromboembolism. This is level 1 evidence. Bed rest or ambulation. Early ambulation preference is in preference to initial bed rest when this is feasible. Optimal timing for prophylaxis initiation depends on optimal efficacy of anti-thrombotic and risk of bleeding. Pre versus post-op first dose, concern perioperative thrombi. Key lessons learned. So I'm summarizing my talk since timing is very less. DVT is frequently underestimated. No one can disagree with this thing. Failure to provide appropriate thromboprophylaxis puts patients at risk. No matter what prophylactic regime we choose, we can reduce but not eliminate the occurrence of venous thromboembolism in this population. If we look for it, we will find some veins have clotted after surgery. We actually want our patients to stop bleeding after surgery. There is a trade-off between bleeding and clotting, and nobody can, not every patient can do these acrobatic stunts like this girl, but at least we should make our patients ambulatory as soon as possible. That's the end of my conversation. I can take questions in lunch. I am the person between lunch and us, and like an obedient housewife, I would say that lunch is downstairs ready, and I would request but that memento ceremony. Memento, please.
Mementos, please. Dr. Sanjay Chaturvedi is here. Dr. Jyoti Prakash.
At time is
Dr. Karne and Dr. Arun Sharma.
Yes.
I request Dr. S.S. Yadav sir to give the memento to Chairman Dr. Sandeep Sharma. Sandeep Kumar.
Sir, I would request our chairpersons to hand over another memento to Dr. S.S. Yadav and then we will do it other way rounds. Sir. Now, could we felicitate Dr. S.S. Yadav for delay? Dr. मेरा भी हो गया. We can break for lunch for a while, and 2:30 we will have foreign faculty sessions. So all the delegates I request to come back, and in between we will give audience to Dr. C.P. Pal. He is online. Dr. C.P. Pal, I am here. I will stay with you with few of my friends, and we will have a strong deliberation. Don't worry, nobody is going away from my team. I'm just as an host. I am allowing my other guests to have lunch. But there are many interested people who will give you audience and will aspire with you and will discuss with you THR in difficult situations. You are online, sir. Give line to Dr. C.P. Pal. We will have foreign important announcement. We will have foreign faculty session. You will have Dr. Vijendra Singh, BIOS chairman, Dr. Jirkal, and Dr. Manish Bhatia, Education Secretary of British Indian Orthopaedic Association. Dr. Jirkal, the inventor of Sigma nail, Sinus nail. So I request you to please come back at 2:30. We're gonna have a brainstorming session. And now I guess Dr. C.P. Pal, is he ready? Team Grover, ready? Let's set go.
Actually, hello. Hi, Arun. I'm really fortunate that I'm not able to join over there due to some health reasons. Basically, I just want to share my few experiences how to tackle difficult situations in primary arthroplasty in a setup, in a government setup where I'm working. I have my few experiences with me, and just I want to share. And this is, and you know, a total hip arthroplasty is a frequent procedure for orthopedic surgeons nowadays, and especially lower extremities. There are more than 1 lakh replacements going in India per year. And what is that is the biomechanics of hip is necessary to restore the center of the rotation, restoring the lever arm. These are basic things. Correct positioning of the implants to limit the impingement in the and wear. Okay. So what is difficult THA? Am I audible? Hello? 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 Am I audible? Hello? Hello?
Yes, sir. Yes.
Hello?
Sir. Continue. Yes, sir.
Hello?
Please
Am I
continue.
audible, please?
Yes, sir. Yes, sir. Please continue.
Yeah.
So,
So,
slide show your presentation, sir.
what is difficult THA? Totally arthroplasty. And am I audible?
Yes, sir. Yes, sir. Please continue.
Yeah, that increases the functional, infectious, and neurological risk, or that involves the technical difficulties, and the former we will link to the later. And okay.
Blank presentation given. I want to
Please,
conditions that resulting and difficult totally arthroplasty. Okay. That is yes. That is obesity, neurological diseases, vestibular dysplasias, vestibular protrusions, ankylosing arthrodesis, congenital dislocations, and anomalies of operated hip, like significant lateral offset, coxa, traumatic sequelae. And that is very common, and we often got so much of neglected cases in our setup that they cannot afford, and they come to us after a year or two, and may result in bone loss anterior, superior, or posterior acetabulum like this. These are few examples. This dysplastic, neglected neck of femur, post-traumatic sequelae, protrusio, infectious cases, dysplastic hips, or infectious like tubercular hips. And the question arises, that is how to tackle these problems. First of all, obesity. This is the use of a specific retractor to overcome the depth in these cases. A classical surgical approach is there. A classical use of specific retractor to overcome these depth in these cases. A classical surgical approach is recommended while paying careful attention to the hemostasis, and the risk of instability should be evaluated in these cases. More obese and with any other pathology, while doing preoperative assessment, and specific hardware should be available if necessary, or techniques to stretch out the gluteal muscles to decrease this risk. Importance of hardware should never be ignored. Next, like congenital hip dislocations, traumatic congenital hip dislocation. The goal is here, these are very important cases and very tricky cases. The goal is here to insert the cup into the true acetabulum. Smaller diameter cups must be used with or without cement. It is often necessary to reconstruct the acetabulum, especially in highly dysplastic cases, like these pictures, where you can see preoperative and postoperative. And we have traumatic sequelae, and here the bone defect is treated by bone grafts harvested from femoral head, and if necessary, an allograft from a bone bank, and stabilized with a metal cage and a screw fixation. And in acetabular protrusor cases, initial resection of the femoral neck to facilitate dislocation and extraction of the femoral head, peripheral acetabular reaming, only to avoid perforating the acetabular floor. Bone graft of the acetabular floor to restore a normal center of rotation by lateralization using an acetabular reinforcement ring to prevent secondary cup migration. This is a very important, we often get acetabular protrusor, especially in traumatic cases with traumatic sequelae. And we have to be very careful while cup placement in these cases. Okay. Difficulties are meant to rouse, not to discourage the human spirit to grow strong by conflict. That is an important saying. I have some important, interesting cases like this. Like case 1. This is a case of 37-year-old male presented with the pain and deformity at a right hip from last 6 months and limping after trauma due to fall and drown. He was diagnosed as an elsewhere treated case of central fracture dislocation of left hip 6 months back and upper tibial skeleton for almost 1 month. So this is the preoperative picture. You can see, and he was a very poor guy. Coming to us, and as I'm working in a government sector, I used to get these type of cases. And here is a deficient medial wall creates a greater difficulty in placement of acetabular component of THR. This is a picture. You can see. Next. You can see. So what are the options with us? And theoretical, there are too much options available, but with me, with the affordability of patient, and I have very limited options. Challenges: the vision medial wall protrusion had shortening, affordability of the patient. And initially, I planned that to fill the medial wall defect of the acetabulum with the help of acetabular supporting cage of the titanium mesh. And what I did initially, I planned not to remove medial dislocated head from the acetabulum and to ream the acetabulum as such with the head after cutting the neck. But after reading the CT scan carefully, there is shows there is no body fusion with the medial wall of the acetabulum. I decided to take an option of removing the head from the fractured acetabulum. And these are various options available. And one of the important, that is unaffordability of the patient of the medial wall support discard above could not be used because we plan to fill it with a bone graft. As 6 months there is enough callus at the fracture site to prevent it from migrating. So I manage it. Uncemented THR with bone graft harvested from the head itself, and as when I was operating this patient, I got the good superior lateral stouty portion, so I put it this, and these are pictures after 4 weeks, and almost there is a follow-up, no shortening, and it was managed very well. And another very stress type of cases with May 35-year male presented to us with an pain and deformity of the limb from hip from 2 years. He was diagnosed as an old case of tuberculosis of the right protrusio stabili, managed elsewhere by IND, right hip, and well-documented case of tubercular hip. Anti-tubercular was started, 18-month course was completed by the patient. There was global restriction of movements. This was the X-ray. And as usual, unaffordable, completely deformed head and acetabulum. See. These are CT scan images of the patient. X-ray shows grossly distracted, deformed head of the femur with loss of joint space on right side, deficient middle wall of the acetabulum, right side, and proximal femur migrated upwards. See, CT scan shows anterior, inferior, medial acetabulum with loss of joint space and deformed head of the femur. Suggestions, planning. Initially planned for reconstruction of medial acetabular valve by either mean of the titanium mesh or cage. Since the patient was poor, not able to afford the cage, then I decided to reconstruct the medial acetabular valve by titanium mesh supported by bone graft harvested from neck itself. Posterior approach, biopsy was taken, cemented total hip replacement, titanium mesh and bone graft, repair of acetabular valve, and I used cemented stem. Why? While patient was young, I decided to go with cemented because of thin cortex, diffuse osteopenia, proximal femur, wide medullary cavity. These are perioperative pictures. This is post-op, and this was operated almost 5 years back, and I'm having a follow-up of almost 5 years. These were immediate X-ray. Advances. Total hip replacement can be done in active tuberculosis. What recent papers shows, and patients with 2 weeks prior starting anti-ATT and post-operative coverage up to 12 to 18 months. We don't have to wait for 18 months. And as this patient was, when he came to me, he had already taken 18 months of TT, but we can start do THR after just starting the ATT for 6 to 8 weeks. What shows? And one interesting case is there. It's a case of with some fixation was done elsewhere with stubulum, and screws was there, presenting complaints, severe pain on weight bearing, not able to walk on performing movements, impingement of screw, and had felt by clicking sound. Almost everything was damaged. CT images are there. Uncemented femoral stem was used, and uncemented anteroposterior mesh was used in these cases. And though acetabulum was very much damaged, that it cannot be appreciated on X-ray itself. And just I want to show a very interesting case with me. A 50-year female patient sustained injury due to fall in her 4-year back and presented to our OPD with complaints of pain, deformity. Right hip patient is unable to walk even with support, and also deformity of bilateral knee also. This is the X-ray of the patient. Dysplastic hip, neck, femur, and it was a really challenging case for me, with deformed spine, everything. And to have proper rotation of the cup and version, it was really difficult in this case. These are the X-rays. You can easily see the spine, the patient. This is the condition of knee itself. So I told her that I'll first go for the hip and then for the knee. And she most probably from 2 to 3 years back, I operated her hip, and she will come next to next month for her knees also. This is the orthoscanogram of that lady. And this is the diagnosis of the patient and the clinical picture of the patient. Challenges: very thin medial wall, deformed knee, shortening of 8 centimeter, deformed spine, severe pelvic tilting. The deformity spine poses a great difficult challenge to decide the version of the SW. What to be done? STST applied on right side, cylindrical POP cast left side to minimize flexion deformity. Total hip replacement, cemented with mesh on right side. This I could do that in this lady. Yeah, this is the clinical picture, and most probably she'll go on her next surgery for knee in a couple of months. This was really a very challenging case for me. And this is another case, displaced and neglected injury. A girl, a lot of shortening, spine. Patient coming to our setup, actually they come after a lot of negligence and after a lot of time. This is picture. Thank you. And we get usually the obstacles that are in your way aren't meant to stop you. They are designed to point a way to new route, new possibilities, and new doorways. Thank you for your listening. And these are very difficult. Actually, in our setup, the cases come to us, and with we have got very limited options with me. It is very difficult to decide, and affordability is one of the very big factors for these patients. So you have to do something for their pain and their rehabilitation. Thank you so much. Thank you. Thank you. Thank you, sir.
Thank you, sir, for your excellent presentation. Any questions from the floor? If there is no question, I will ask one question, sir.
Yeah.
In your first illustration, you showed some Muller or Bush-Schneider type of cage.
Yeah.
In the primary setup. Usually they are done in revision setup. And at the passage of 10 or 15 years, all of them mechanically failed. There is a report like that.
Yeah.
What is your opinion on it?
You are absolutely right, sir. But I know the affordability, and usually the patient who come to us, they are very poor. So I could not. They could not afford so much costly cages, and though I don't want to do, but there is limitations. Financial constraints. Yes. So you have to do something. Patient to as I'm working in a government setup, and I often see these type of cases. Though I do in 10 coming to 1 or 2 cases, but though literature, there is a lot of advancement, lot of stable cages are there, but you cannot help in these situations.
Because the patients are very poor.
Yes. So
one another question, in one of your cases, hip was very high riding, just like a Crow's type 3 dysplasia it looked at. Though it is a post-traumatic case. Did you do any femoral shortening in that case?
No, sir, I didn't do femoral shortening. First of all, I apply STST traction, and I put some corrective cast in the knee, and it was really difficult to maintain the version. Basically, it was a dysplastic hip with fractured neck of femur 4 months back. She was walking on this very deformed spine. Okay. So I really got difficult to get version in that case. I didn't do any shortening, femoral shortening in that case.
Also, in such cases, due to fusion and deformity of the spine, their approach and the lack of spinopelvic motion, nowadays they do some form of different calculation to put the cup in particular position so that it doesn't dislocate. Whether you take it into account all these things, or you do it routinely?
Almost routinely.
Okay. Yes. Thank you, sir. Thank you very much. Any other questions from floor? I think we shall close this. Thank you very much, sir. Thank you.
सर ज्वाइन करो, विजेंद्र सिंह को ज्वाइन करो, डॉक्टर विजेंद्र सिंह। हाँ, रिकॉर्डेड टॉक, उनको लाइव ले लो, टॉक शुरू कर। हेलो हेलो, so we are starting foreign faculty session. We are already running late. So first talk in this extremely interesting session is from Dr. Professor Vijendra Singh. He's President-elect of British Indian Orthopaedic Society, a prolific upper limb surgeon. He has been to IOACON 2015 and delivered an interesting talk. Now, he has again kindly agreed to join this session. So we are starting with recorded talk of Dr. Vijendra Singh. I would invite our chairpersons, Dr. K.K. Mukhopadhyay, Dr. Utpal Bandyopadhyay, and we also have gracious presence of our organized chairman, President IOA 2020, Dr. R. Simina. Please, sir, come on stage so that we can start the proceedings. Professor Vijendra Singh is already online. He has joined the Zoom meeting virtually. So his talk will be delivered as recorded, and thereafter he can take questions.
सर का इंट्रोडक्शन देना है कि we insist on giving them because people don't know about them.
इंट्रोड्यूस कर देंगे उनके टॉक से पहले। ठीक है, हाँ। Play. Team Rover, let us go.
Greetings from UK. I don't do this thing. I'd like to express my gratitude to IOACON giving me this opportunity to present on the use of stratigraphic proximal fractures. There's no conflict of interest. The reason why I'm talking about this is to avoid failure. Failure of fixation in the proximal humerus fracture can be patients or the fracture factors, but generally it's a combination of one or more. Certainly the patient and the fracture factors are difficult to manage, but we can use techniques by where we can reduce these. Patient personalities is a smoker, and there's a higher incidence of fixation, and this is an example to show that patient with 60 displaced fracture, two-part fracture, very unstable. Had a fixation by a colleague of mine. I agree that it's not the best fixation, but it was reasonable. Unfortunately, the patient kept picking on the wound and did not settle into infected. Surgeon personality is an important factor. Is an example of a 30 sustaining this fracture dislocation of the shoulder. Unfortunately, the surgeon who did this a few years ago when people was involved thought they could do a unfortunately did not produce the fracture very well. And one could say that this was the day one failure or on table failure. Can be seen later on. This patient went on with the first. The third example of a slightly older age patient with a fairly complex fracture. Unfortunately, the surgeon operating on this did not pick this up and fixed it in position, whereas I can anticipate that there was a medial continuity which the surgeon did not appreciate. This was what the outcome was eventually. The number of proximal humerus fractures that we see that rise. The epidemiological study showed about 75 to 80 per 100,000. And about 20% of these will present some challenge for management, whilst majority are managed normally. We look at the anatomy of the proximal humerus. This is conceptualized on the three growth plates. Has a greater tuberosity, lesser tuberosity in the head. The head shaft angle is about 135 to 140 degrees, and the humeral head is in retroversion of 0, neutral to about 20 degrees. The blood supply is quite vital, and this is one of the papers that is commonly quoted by one of my previous bosses, who showed the posterior circumflex humeral artery and the anterior circumflex humeral artery, which forms the arcuate artery, have an anastomosis which supplies the humeral head. And they found that if the head fragment extends distally below the articular surface, then the medial may persist. If not, then there is a greater risk of avascular necrosis. A study in 2010 looked at the blood supply again, and this showed that the posterior circumflex humeral artery actually contributes 2/3 of the blood supply to the humeral head, and the anterior circumflex provides only 1/3. And they also found that the posterior circumflex femoral artery is more flexible and has more branches, and hence less likely to disrupt the blood supply to the humeral head, which may explain the not so many numbers of ABN that one would expect based on the first study. So how do we know which patients will have a poorer outcome? Various surgeons have used different methodologies to predict this, and the common one is the reduction, osteoporosis, and restoration of the medial cortical continuity. These two papers highlight what this number of papers highlighted the same. Now, unfortunately, the osteoporosis is beyond our control, but certainly the reduction and the establishing of the medial continuity and medial support we can help with. This study by Chow et al. Showed what I'm going to talk about. So they looked at fresh frozen paired humeri and used the humerus, used a fibula as an intramedullary graft. They removed a centimeter wedge from the surgical neck, performed the osteotomy, and then loaded the fixation after fixing with a lock plate. And then it took 25,000 cyclical loading. And you can see the specimens which had the augment one, except one, all of them sustained the 25,000 cycles, while in the non-augmented one, only 2 out of the 8 sustained. In fact, none of them got over 10,000 cycles. And they concluded that fibular allograft augmentation increased the ability of the locking plate to withstand repetitive varus loading. And they hope that this may help clinically as well. Based on that, there was this study published in 2018 by Kim et al. Looking at 164 patients of it was retrospective cost allowance study, with those looking at 3 and 4 pump fractures in the age of 1600 more. These 2 years follow-up, and the two groups had nearly half of fibular allograft, and half of them had a medial calcareous screw. The patients were well matched for age, sex dominance, interval to the operation, and the mechanism of injuries. However, they found, interestingly, that there was a significantly better VAS and constant score in the 4-part fracture in patients who had allograft. And in the image post-op radiographs, they found improvements which is maintained up to 12 months and the 2-year mark in both the 3-part and the 4-part fracture, more pronounced in the 4-part fracture. And they concluded that use of a fibular allograft technique is considered a primary additional procedure for medial support in patients with 4-part fractures involving medial metaphyseal convention. A smaller study looking at 50 patients with a fairly wide age range with a minimum of 12-month follow-up, and they found similar results, that the neck shaft angle was better maintained towards the humeral height and was better with the strut graft. I generally tend to use a deltoid split approach, but equally deltopectoral approach could be used. I always identify my landmarks, especially the axillary nerve, and isolate during the procedure. Just show you a couple of examples. So this is a young 45-year-old male who on first view looks like a fairly innocuous looking fracture. But if you look closely, there is a double shadowing of the humeral head, which raises suspicion. And a CT scan does show a head split fracture, although most of the articular surface is intact. It's a fairly large chunk going into the lesser tuberosity, and further splits across into the humeral head. So this patient, when taken, you can see the split further into the humeral head, which was fixed with headless compression screws, and you can see there is no varus continuity. And once you put an allograft, that gets established quite nicely. Although we started with a better position, the final fixation, the reduction did go into slight varus, and at 1 year, the fractures healed well, and the patient had a reasonable outcome functionally. Second example is that of a slightly older age group patient, 55, with a fracture dislocation of shoulder, multi-fragment shape, these 4 parts. And this again, on the first view, looks that it's has no medial continuity, there is medial combination. This one, in fact, the medullary canal was fairly wide. I ended up using 2 allografts, and this was to a point where one could argue about doing something placement-wise, but given the younger age of patient and demand, decided to proceed with the fixation. And we did get a reasonable fixation, although it went in slight varus. Overall, it's healed well with a reasonable outcome. Example of a 52-year-old female who fell from a height, 3-foot height. And again, this looks quite innocuous, but I suggest that if you want to treat them longitudinally, these kind of injuries always get us to look at the fracture more closely. Again, despite it going into varus, we thought maybe give it a bit of time to see if this gets better. And at 2 weeks, the fragment had in fact gone into more varus, and then we decided to take that for surgery. And again, you can see that the medial calcar is broken, and this was an unstable fracture. And applying this wedge allograft, we managed to reduce and make the fragment quite stable and get a good reduction in fixation. Just going to show you a short video of the technique that I used. So this is showing the 2 positions where the reduction is possible, but because of the medial combination, it's really unstable. We decided to proceed with introducing the allograft. In my hospital, we have the allograft on shelf, which is a freeze-dried one, and we can use that. I mark out about 8 to 10 centimeters of the length. We generally have a split femur or a split tibia. Do a blunted oval shape or half an oval shape graft. I always mark them, draw them on the bone first. Longer taper, which goes into the medullary canal and makes it easy. Mark it out with some K-wires, so there's less chance of slipping of the saw. And then using an oscillating thin saw, use a wider one, then it's likely to rattle around and can cause split of the graft. So once I have the graft, I will insert that into the medullary canal. So what this does, it sort of wedges in between the shaft and the humeral head. Because it's wedged in the shaft, it cannot collapse and stop the humeral head from collapsing into varus. And you can see that's the position. On the left, may have to adjust it to get the adequate position. Then you cover the tuberosity on top, and you can see I can manage to get a decent reduction. Once the reduction is achieved, then you can either tie the sutures on top, as I'm going to do here, or you can pass the sutures to the plate. But on this one, I'm going to suture this, which makes the upper end, fractured upper end, back into a normal looking humerus, and then it's almost akin to putting a neutralization plate at the end, or once this has been reduced. Sometimes, because of the anesthetic, the rosity can be quite mobile, and care needs to be taken that you don't distalize the greater tuberosity too much. So here I'm tying the sutures to flow the hook, so to say, or the tuberosities. Once I've done this and I'm happy with the position, I will take a locking plate and gently put it under the axillary nerve. Now, if there are less numbers of sutures, you can always pass more sutures to the cuff. But I feel these are vital in the stability and fixation of the proximal humerus fractures. This is the suture on the top. Now I've got three sutures, one at the back, one at the top, and one at the front. And then this is one of the locking plates. You can use a block that comes with the device, or I generally just put a locking chimney, which gives me enough support to manipulate the plate, as well as avoid, makes it difficult to drop. I'm passing the sutures to the holes of the plate. Once I've done that, I will start to tie this together and then proceed to standard fixation of the proximal humerus. Generally start with an oval hole, which allows me to adjust the height of the plate. That's the check on the plane radiograph to see what it looks like. And then this is what it looks at the end after the plate goes on and after the plate. And a year down the line, this has been very well indeed. So in summary, it's key to identify the cases preoperatively. Beware of the very simple looking three-part fractures. Look out for the medial hinge and the medial combination. And I certainly have a low threshold to use an allograft. At first, it sounds quite daunting, but as you practice, it becomes easier. Thank you very much for that.
Sir, let me speak the second speaker. Oh. So, gentlemen, this was an awesome presentation by upper limb specialty surgeon and president-elect of British Indian Orthopaedic Society, a prolific upper limb surgeon, Professor Vijendra Singh. Now, I would request the audience if they have any question for Professor Vijay.
Hello, I am Dr. Sankarlingam from Chennai. If allograft is not available, can we use the fibula from the same patient?
Yes, of course. Fibula is a very good option, actually. You may have to split the fibula sometimes because the medullary canal can be narrow. In UK and I guess in Western countries, we try and avoid another morbidity, and the allografts are freely and easily available.
So now, since Arpit Jariwala has joined in and he has to leave this panel after a while, so I would request Dr. Arpit Jariwala talk to be presented. Before that, I want to give a brief interlude, introduction of Dr. Arpit Jariwala. He's in postgraduate from BHU. Thereafter, he took his higher training as specialty training in NHS UK, Scotland. He has worked. Currently, he is associated with the University of Dundee, which run a fabulous MCH course in orthopedics, and he runs in one-stop upper limb clinic, a super specialty clinic. He's a prolific upper limb surgeon, has presented his work all over the world and got many landmark publications in upper limb. And his today's talk is on management of AC joint injuries. So here I tell my team to present recorded video of Dr. Arpit Jariwala. Thereafter, he will take live questions from the audience.
Arun.
Yeah.
Can you hear me?
Yeah, definitely, sir.
Yeah. So can you hear me loud and clear?
Loud and clear.
Okay. Hi, Vijendra. So I'll do a live one. Sorry, I didn't have time to record it. So first of all, good afternoon to everyone, and a big thank you to the organizing committee and the education committee for the IOACON to give me this honor to be invited here. Hello, Professor Meena, and hello, Dr. Das. Hello, everyone. So
thanks very much.
I'm Arpit Jariwala. Thanks for the kind introduction. I'm the head of department and also the MCH Orth course director at the University Department of Orthopedics and Trauma Surgery in Nine Wells in Dundee. This is our major trauma center where I work, and some of you have been here. So the talk today for me is management of AC joint injuries, and my aim here is not to teach my colleagues, my senior colleagues and my mentors in India how to manage AC joint injuries. It is just to share how I treat it and some tips and tricks. We all know the Rockwood classification starts from grade 1 to 6. 6 is very, very rare. So we'll discuss today 1 to 5 injuries. When we look at type 1, 2, and 3, they're normally sort of grouped together, and you have, when I see these patients, they're mostly seen in virtual clinic and discharged to physio for about 6 weeks to 3 months. And majority of type 1, type 2 generally settle down with few weeks of sling and pain relief and physio. Very rarely, about 5% in my experience, they'll come back with pain issues, and a local and steroid injection generally does the trick. Now, grade 3s are tricky, although most of them will settle down by around 3 months period. A percentage of them, in my practice, around 25%, will continue to have problems with the AC joint dislocation. And if you go back and have a look at, these are the people who are involved in heavy work, heavy upper body work, and also are athletes or are working mostly with their upper limb. And these are the people who come back after a good trial of physio of around 6 to 8 weeks. And if they're not improving, I would offer them surgery. Grade 4s and 5s, generally they require surgery. Over the years, I've seen that some of these actually don't need surgery. And hence what we have done is, over the last few years, we've slightly changed the protocols that we send all of our AC joint dislocations for physio for at least 4 to 6 weeks. And most of the grade 4s and 5s will come back for surgery. However, there are a few percentage, I would say around 15 to 20%, that would again settle down without any intervention. And these are the people or patients who are mainly sedentary job holders, mainly desk job people who are not involved in heavy upper body work. So that's my experience of these injuries. Now, I'm hoping we have gone away from putting K-wires and Bosworth screw into the AC joint. And I personally don't do hook plates, because I think for 2 reasons. One, they need a revision surgery. And secondly, I don't like the hook plate irritating my cuff. I've done quite a few, I used to do Weaver Duns and ligament reconstructions. However, I've gone away from them. In the last 7-8 years, I've used this device, which is called Lockdown. It's a double braided polyester weave, which then stabilizes the clavicle to the coracoid. It's a very stable implant, and generally my patients are do away with the sling in about 2 to 3 weeks time. By 12 weeks, they're back to normal functioning, including contact sports and heavy upper limb work. This is not new. This has been more than 11,000 have been implanted in UK, and this was about 9 years old paper from the Inventor series, and they generally do well. So my setup, I usually do them in a log deck chair position. If I don't have a fellow or a trainee, which is very rare, then I'll use an arm positioner to help me reduce the AC joint. I use a brass strap incision, and the skin marking goes from the posterior aspect of the clavicle towards the coracoid, and generally around a centimeter medial to the lateral end of clavicle. Generally, I don't get them acutely, so what I'll do is open the AC joint, and most of these AC joint starts to look unhealthy, and hence I take 0.5 to 0.7 centimeters of the lateral end of clavicle away, so that after fixation, you don't get impingement issues. Then there is a wire passer through which the tape goes through, and you pass it through the medial side of the coracoid onto the lateral side. And this is where you have to be careful, because all the sort of tiger area is around medial to the coracoid. So I carefully dissect out the medial side of coracoid, make sure I put an artery clip, open it up, and pass the suture passer. And thereafter, this is a tape measure which goes through the suture passer, and then it goes under the clavicle, over the clavicle, and then you reduce the AC joint, and then you measure what sides of lockdown you need. This is a small video. I'll not bore you with the whole of it, but I'll take you through the important parts. So this is where your suture passer is going from the medial to lateral under the coracoid. You pass your fiber tape, and then you take the tape suture passer away, and you loop the tape around the coracoid, snugly fit it, and then the tape goes under the clavicle first, then make a small hole in the deltotrapezial fascia, goes over the clavicle, reduce the joint, and this is where your trainee or the your arm positioner helps, and then you measure what size of lockdown you need. Once you've done that, you don't take the tape out completely, because the lockdown device, it acts like a feeder to the lockdown device. And then similarly, you pull the lockdown device from medial end of coracoid to the lateral end, loop it around, get it snugly fit down, and similarly again pass it back under the clavicle, over the clavicle. And then what you do is you reduce the joint back again to as best as you can, and then you fix it with a 3.5 millimeter screw with a washer which holds the device back. So in effect, what you should end up is this. In AP plane, the joint is well reduced, and on the axial plane, the screw is away from the ligament so that it doesn't irritate the ligament. So post-op regime, I normally leave them in a sling for 2 to 3 weeks. My physios follow them up. I don't see them post-op, and they normally start doing their day-to-day procedure, driving and day-to-day activities at around 4 to 6 weeks mark. And I see them back generally between 12 to 14 weeks mark, where at that time they're doing well. I get an X-ray, make sure all is well, and check them over, and after that I just discharge them with an open appointment to come back and see me if there are any issues. And generally I allow them to get on with heavy work, contact sports, and any activity they were doing prior to the accident. So when I started doing them in 2012, we looked at our own results of 2014 to 2017. This is all my results. So 20 patients, out of which three were excluded. Mean age was 40, average operation time was 9 months given the NHS waiting times. Only one had one I operated was an acute injury, rest all were chronic injuries more than 3 months old. So average follow-up was around 7 months, and 15 of these were discharged as they were doing very well at the last follow-up appointment, and they were not seen back. One of my patients had underwent a revision, and one had an infection. So this is one of our cases. This is an investment banker, does weekend cycling. He fell off his cycle. He had a grade 5 injury. He had spoken to his colleagues and also looked at internet. As he was quite internet savvy, he wanted it fixed, so I fixed in around 6 weeks mark, and he did very well after the surgery. He was discharged thereafter. This was a gentleman who is a solicitor. He didn't want surgery initially. This was a grade 5 injury. We managed him conservatively for about 6 to 9 months. 9 months, and in 9 months he came back to me and said his shoulder was not right and he wanted it done. So we did a lockdown for him, and he was pleased thereafter. This is Adam, and this I've taken permission to share his pictures and his videos with you. So he is a heavy construction builder, but also does professional mountain biking in Scotland. So he had a grade 5 injury when he fell off his mountain bike. And this is his week 13 post-op scar, very well healed. He's happy with it. And this was his x-ray on week 13 when I saw him. He was doing very well. His x-ray was fine. And this is his post-op range of motion at 13 weeks after a lockdown on the left. On the right, sorry. And again, this is him telling us about, if you can hear his. So he's generally saying that he's very happy with his operation. His scars have healed well. He's back to doing everything. Before that, he was having pain in day-to-day issues and couldn't do any part of his work, which is heavy construction work. So generally, most of my patients are like these, that around 14, 15 weeks, they're doing very well and they're discharged off. So again, we are surgeons, so we do have our fair share of complications. So this is a gentleman who had a grade 5 AC joint injury. He dislocated his, he had his surgery done around 4 months post injury. He was doing well. He was discharged off, and then I got a phone call from one of my colleagues when he was around 8 months post surgery that he had come in with quite a bit swelling, redness, and he was feeling unwell. And we got an urgent ultrasound scan, which looked at as if he had pus in there. So he was taken same day to theater by my colleague, and they noted pus around the area. They washed it out. They took the lockdown away. They took the metal work away, and he was put on IV antibiotics for 4 weeks and then oral for a total of 12 weeks. I saw him around 4 months after his washout debridement, and he was doing well. Thankfully, his infection had settled down, and although the joint still had come back up again. We discussed whether he wanted to go ahead for the revision surgery. He felt that after the second surgery, his shoulder was not feeling weak to go ahead with further surgery. So we have left him at the moment. I've not heard from him in the last 3 years. This is another gentleman who is 50 years old, had a grade 3, grade 5 injury. He had severe neck issues, chronic pain, smoker. He wasn't the best way person to operate. However, we recommended surgery. He was reluctant for surgery because he had pain issues. So we waited for about 11 months, and he then finally came back and said, I would like to get the surgery done. We did the surgery. He did inform me that his shoulder symptoms had improved. However, his neck pain and his chronic pain were more or less same. He then came back to me around 6 months after this, my surgery, and his joint had again subluxated off. And I was worried that either there was a clavicle fracture or a coracoid fracture. So I got a CT scan, and there was no obvious fracture. So he was in a lot of discomfort. So we went and to revise his lockdown. And what I had found was this surgery was done by my trainee, and I wasn't paying attention where the screw was going. And what had happened was the screw had, instead of going medial to the lockdown device, it had gone through the lockdown device. And over time, because of the movement of the arm, it had completely cut the lockdown device. So we took everything out, washed it out, and then we refixed him with a lockdown, and that is him 2 years, and he's happy with at least his shoulders, although he continues to attend the chronic pain team for his chronic pain. I'm aware that there are newer techniques now, both open and arthroscopic with tightrope. And again, at present, if you look at the evidence, nothing beats lockdown. In my hands, lockdown works very well. I'm happy with that. I've done around probably 50 plus over the last 7 years, and generally they do very well. They're very happy with the results. So I personally don't feel the urge to change. And at present, the evidence doesn't tell us that there is anything stronger than or better than lockdown that is coming out, especially the tight ropes, because they have their own issues of being weak. And they have, then you have to put two tight ropes, and the acromion, the coracoid then fractures off. So at present, my management for symptomatic AC joint dislocations is a lockdown technique. So with that little note, thank you very much from whole of the University of Department of Orthopedics and Trauma Surgery in Dundee, and thanks to the organizing committee and the educational committee of IOACON, and hope you have a brilliant meeting. Thank you all.
Thanks, Dr. Jariwala. It was a wonderful talk. May I ask among the audience if they have question? Just Dr. P. Shankaralingam is there with his question. He's an avid researcher. He has most of the time his questions are very pertinent, and they deliver express what actually audience are thinking about the presentation.
Earlier, there was a report in Rockwood and Green that they used radio opaque material like Dacron mesh wound around like a lockdown, and later they found that it is eroding the total clavicle and causing clavicle fracture. They concluded, the senior author of Rockwood and Green, they concluded that the shoulder dynamics is more any implant which is bound to fail over the time, whether it is metal or mesh or anything. What happens to your lockdown?
So again, that's a good question, and I think there's always a possibility, and that's why you don't want to put it very tight. Also, you need to be very careful with your screw positioning, that you're not taking 2 or 3 trials at the screw to weaken the lateral end of clavicle. There have been some extraction studies done by Professor Angus Wallace, where they went back in some of the cases they had put in where the tissue had been ruptured, but they didn't find much issue with the clavicle. So most of the, and it also with lockdown, we don't get a lot of or any allergic reactions from lockdown coming back. And as I said, that it's not just 5 or 10 that has been implanted. I think more than 15,000 of them have been implanted in the UK. So if there were issues with clavicle fracture, coracoid fracture, reactions to the polyester, then we would be getting more issue would be coming up in the series or in publications. So we don't hear that. In my practice of more than 50, the 2 complications that I've shared with you are the ones that have happened. There are other couple of them that continue to have some pain issues, but I have not seen a failure or reaction or fracture as such from the lockdown up to now.
What is it made up of?
It's a polyester. Polyester. So it's a polyester made up. It's multiple weaves of polyester.
Thank you.
So, any question from the panel?
Dr. Urmit, this is Dr. Kiran from Kolkata.
Hello, Dr. Kiran. How are you?
Fine, sir. Sir, do you use only these flexible fixation for last few years? We still are using the rigid fixation in Kolkata, but I think you are using the flexible fixation for years.
So from 2014, I've not used anything other than lockdown. I've taken quite a number of hook plates, and every time I take a hook plate out, my heart bleeds for my rotator cuff. Because and again, only recently I took a hook plate out 2 months ago, and that gentleman still continues to have shoulder problems. So I, as I said, in my hands, lockdown works very well. I'm sure there are other devices which work very well in other people. Some use tendon grafts, some use Lars ligaments, some use tight ropes, and it's. But I think it's a safe device which on an average orthopedic surgeon like me can work with.
Thank you, sir.
So, thanks, Mr. Jariwala. So
thank you very much, and thank you to. I'm on call, so I need to rush off. But have a brilliant meeting and all the best.
Thank you, Mr. Jariwala. And now we can move to our next talk. That would be delivered by Professor Vijendra Singh. Why to research? Because he also has to leave after a while. So, Professor Vijay, Would you like to deliver it live or shall we present your recorded live video?
Recorded, please.
Recorded live. Professor Vijay, why to research? Last talk of the session. Team Grover and Karthik. Yeah. And I must welcome Mr. Manish Bhatia, Educational Secretary of British Indian Orthopaedic Society and postgraduate from our very SMS hospital, avid researcher and avid foot and ankle surgeon. He has also joined. Thanks, Dr. Bhatia, to join us.
Thank you, Arun.
I'd like to thank the IOA organizing committee for giving me this opportunity to talk on why research. I thought about what aspect to deliver this on, and finally I thought perhaps give it a bit more philosophical look rather than talk a lot of science. Obviously no conflict of interest with this. I want you to have a look at these two pictures and see what you can see. We pause for a moment. What I see is a child with an inquisitive mind. And that's what the basic human mind is, inquisitive. Wants to learn, wants to know. And it starts right at the young age, whether it's chasing those soap bubbles or going and sniffing and looking at the flowers to see why do they look different, why do they feel different. Or indeed, like this young boy who, when hits a key, it makes a different noise. And hits another key, that makes another noise. And that's what the inquisitive mind or curious mind is the basis for any research undertaking. Unfortunately, as we grow older, sometimes we lose the track with normal day-to-day things, or as it's called, normal day-to-day thinking life. Being asked to learn what is 2 + 2 and what comes after the B. And sometimes in that race to get where you want to means that sometimes you stop for that moment to analyze and think why, how, what. And that's what I'm hoping to be able to share with you. Now, we all know that research advances in the medical care and public health has meant that we live at least 10 years more than in the 60s and 20 years more than the 30s. And clearly that wouldn't have been possible without advances in the medical care, which would not have been possible without people doing research. And often I get across and come when I speak to juniors, they often feel, oh, I can't do research, I'm not good at research. But what we often forget is that everything we know now, everything that we can do, everything that medicine has to offer in the way of improved health is based on research. And this is the vital part. Those who can imagine that we can get along without supporting research are deluding themselves. That's one of the basic provisions of undertaking research. And I believe that everybody should be taking part. Now, as with anything in life, there's benefits and downsides, both on a personal as well as on a professional levels. On a professional level, if you're involved in research, it allows you fostering of critical thinking and skills to handle learning. You learn to question why a particular treatment, why a particular modality of management. It may help somebody to find their academic career. A lot of people, certainly when I was training, for instance, the undergraduate days, did medicine because that was asked of them to do. And I personally remember that ever since I was a kid, I was trained not about research, but that I wanted, that I was going to be a doctor. And so I was true with that career. Yes, I'm not saying I regret it, and it's taken me to places where I am now. It certainly helped expand the knowledge and understanding of the chosen field outside of the classroom. And I always believe that if you've got to teach somebody, that's the best opportunity to learn. And I always find if I have to do a lecture, for example, this one, I'll spend more time looking for understanding research, not on a particular topic, but just understanding the basis of research. And that's a lot of information and knowledge that is going to be useful. It certainly helps develop connections with different people across the world, across the society. And now I'm connected through the field of work, research I do, to people in South America, North America, Australia, Europe, and of course India. And again, that carries on with helping build community relationships with peers, both locally as well as internationally. And you can use your research ideologies to help with their academic progress. People who are in government jobs and even NHS can get specialty points, which are worth credit as well as some financial benefit. I was speaking to a friend and says that hobby is certainly a way it can become a time-consuming hobby, especially if it's a difficult hobby. It always certainly provides you with peer recognition, and you know, if I named a few people, then yes, well-known people in India, orthopedic community, they are known worldwide. This I had to put just so that if people are looking into research, then they need to understand the various levels of research that one can do. And again, you don't have to be what's called as the top level, systematic reviews and meta-analysis. I think for a general day-to-day practitioner, and when I say practitioner, it includes all the subspecialties and the super specialists, is to look at your case reports, your cohort studies, case control studies. And I certainly feel that these things are vitally important in progressing medicine. Not everybody needs to do, and not everything is based on randomized controlled trials. Cohort studies and case control studies are vitally important because that tells you as a treating doctor about your own practice, and also provides help to the upcoming and other people. Downsides, I must say, one of those things that you don't really actually regret. If you consider that you have to spend time as a downside, then yes, that is a downside. Quite a lot of time, especially what your spare time you have. But I always believe that you always regret things that you don't do, but never regret things that you've done, and that could be applied to research. Now, when I was trying to gather information about this research business, rather than make it very boring, dry, I came across a few very interesting things. So this was one of the quotes saying that Oprah Winfrey, who's who everybody across the world knows, and this is her confession that she spent a disproportionate amount of time gathering information from communities and outside the court. So Even she is doing research to get to her level of popularity and where people consider it a voice. She has to do that background work. She has to do that research on people who she's going to talk to. I think it's another interesting thing, although not related to medicine, but it can be applied. Says the most successful business people understand their industry, their products, and most importantly, their customers. This can only happen through research. So if the industry people are looking like that, perhaps in medicine as well, to a certain degree, one should look along those lines. I certainly feel that research should form an integral part of all medical training of varying intensity, but always providing opportunity and stability. And that not everybody needs to be in full-time research post undertaking that, but it should be encouraged flexibly so anybody who wants to be involved doesn't feel discouraged. So just to finish off, why should you do research? I think those are the reasons. If you're a good doctor, if you just want to be a good doctor, somebody said that I don't want to do involvement research, just want to be a good doctor. Now, all of us will agree that to be a good doctor, you need to be up to date. And to be up to date, you need to be aware of what's happening and to be able to analyze what is being published. And you need to have some information and some understanding of the research. And that's what you should understand. As I said in the earlier slide, even if you're looking from a business point of view, so if you're running a hospital or a private consortium, to know what your patients want, you need to hear them. You need to know the outcomes, what you're going to offer, and hence again, research. It's vital. Wanting to keep up to date, and again, just reading research like a newspaper is not going to help you. So, and again, to understand what is written in a scientific paper, you need to have some understanding of the methodology, how to interpret it. And of course, widely, some people go on to make a name in the community. And I'm not going to name names, otherwise I offend somebody or things. And you just need to think about a name that comes into your mind, a name that you think, oh, that person has made it by research. So I think all in all, research undertaken without too much constraints or too much pressure is a good thing. It keeps your mind healthy. I would always encourage people, even in small practices, wherever they are, to be involved in this. Thank you. What happens in UK is there is encouragement through these training bodies, the Royal Colleges, the postgraduate deans, and the Medical Education Training Board, along with the agreement with the NHS employers, the universities, as well as the industry will come together, funding research. At the center of all of this is patient care, which is held by young clinical academics, and teaching and research is part and parcel of that. Thank you for listening. Hope I've given something to take home from today. Oh, thank you very much.
So this was a wonderful talk delivered by Professor Vijay Singh. Now I would ask the audience if they have some question around the research, some query whether we should research or we shouldn't research. If surgical scientist, orthopedic researcher is an oxymoron or it is very much an exigency, a need of time. Any question? So I think talk was so elaborate. It explained everything and I enjoyed this talk better on personal level. I enjoyed this better because I don't do upper limb much, but and second thing, it was a master class how to present. I mean, message went loud and clear.
So thanks, Professor Vijay Singh. Dr. R.C. Meena, President of Indian Orthopaedic Society, wanted to thank you for sparing your valuable time, but he has to go for some meeting. So on his behalf, I am thanking you, sir. And I bow down to you that you gave your precious time to us. And one more question I do have. I mean, predatory journal. If you think Indian perspective, our Medical College Council of India has given directives to have 3 papers to become a clinical tutor, assistant professor, then year-wise papers. And they have given wide array of citation index that you can get published. So there is sudden sprouting of so many predatory journals. So could you give your British perspective? How do you deal with these problems?
So that predatory journal issue is there everywhere, and especially with the availability and access of internet and web-based things, it's almost become like a business. So I think we need to be careful how these are being supported. And equally, I mean, I probably get, and I'm sure many on the panel, including Manish, gets a request probably every week to join the editorial board or become a reviewer for journal. But I think it will be upon us to reduce and sort of keep it under control. Otherwise, this is going to go out of hand. But no, it's there here as well. So no difference.
Thanks, Professor Vijay. And for the audience who joined late because the session was just after lunch, so I must repeat his brief introduction. He is FRCS Trauma and Orthopedics, DNB Ortho. He did his MBBS and Masters from Vadodara 92. Then he did his traveling fellowship from Perth, and he is visiting professor and pathway director in the University of Canterbury, Christchurch University. And he is an avid badminton player. He is a avid walker, and he's walked his way to, or rose his way to the president-elect of British Indian Orthopaedic Society, a prolific society associated with research and spreading education. Thank you, sir, for joining us.
Thank you, Arun. Just one correction. I'm actually the current president of the British Indian Orthopaedic Society.
Sorry,
Thank you. No problems at all. Thank you.
Thank you, sir. Now I would request Dr. Manish Bhatia to stay with us because we are gonna play his talk. And before that, I would introduce Dr. Manish Bhatia, although in our part of the country, he doesn't need any introduction because he's an alumni of SMS only. 96 or 97, sir? Dr. Manish?
Yeah, so 93 to 96.
93 to 96, you finished then. Dr. Jayant Sen, Dr. Anu were your contemporaries, sir.
That's right.
And thereafter, he did his higher specialty training at Southeast Thames Hospital, 1-year fellowship at Edinburgh Hospital, Cambridge University, then traveling fellowship of Foot and Ankle Society of Europe, where he visited various hospitals in USA, Carolina, and other places. He is avid researcher, presently Education Secretary of PIOS. Am I correct for this time?
That's right.
Yeah. And he has written a chapter in prestigious Oxford textbook of foot and ankle trauma, chapter number 4 foot. And he is educational secretary, gives a lot of time and education research and propagating knowledge about foot disorders. I was his fellow in 2019, was with him for 2 weeks. He allowed me to join their annual meeting. I enjoyed company of all the stalwarts of BIOS 2019, and a lot of coffee and tea and discussion in between his surgeries at his hospital, Leicester City, Royal Infirmary Hospital, and the other hospital of NHS. Thank you, sir. So, Team Grover, are we ready with Dr. Manish Bhatia talk?
I'm going to do a live one.
Live?
Better,
sir. Live.
We're trying to jump. We're making him jump.
Okay, jump.
You need to mute.
That's good.
Where'd you
Okay,
jump?
I better go now.
Go.
Thank you, Arun.
I'll move this now.
Yeah, it was nice to see you in Leicester, and I really wanted to come to Jaipur. Thank you for your kind invite. Unfortunately, because of the lockdown restrictions, we are unable to. So I'm missing the Jaipur hospitality and lunch and everything. So I'm going to share my views from here, Lester. So good morning to all of you. Obviously, there's good afternoon tea time there. So Arun has asked me to share my talk on talar osteochondral defects, and I'm going to share my screen now. Hopefully, you'll be able to see. Tell me if you can. Can you see it?
No, sir, your screen is not visible. The cursor is moving, but there is no slide.
Okay, 1 second.
Cursor is moving.
You can hear me though, don't you? Can you? You can hear me, yeah?
Loud and clear.
So please share again.
Please share the screen. Team Grover.
Good.
सर सबसे पहले आप अपना पीपीटी ओपन कीजिए, उसको मिनिमाइज कर दीजिए, तब शेयर कीजिए सर.
सर
ये व्हाइट बोर्ड आ रहा है सर.
मनीष सर पहले पीपीटी खोल लीजिए अपना, फिर फर्स्ट ओपन योर प्रेजेंटेशन, देन शेयर द स्क्रीन. First start your PPT in your lappy, then share the screen, sir.
Okay, sorry, just let me just stop share. Okay, हाँ बोलिए अभी. PowerPoint अपना.
हाँ जी,
मैंने
PowerPoint खोल लीजिए पहले.
हाँ जी, खोला हुआ है.
Start the PowerPoint first.
हाँ जी, खोला हुआ है.
सर उसके बाद नीचे शेयर बटन पे क्लिक कीजिए सर.
Yeah.
कर लिया सर
आपने? अभी तो मैंने एक टॉक दिया, कोई प्रॉब्लम नहीं हुई. आई डोंट
of the surgical technique.
एक मिनट.
उसको पीपीटी सिलेक्ट कर लीजिए सर. पीपीटी सिलेक्ट कीजिए.
एक मिनट. तो टॉक खुला हुआ है और जूम.
पीपीटी को सिलेक्ट करके शेयर कर दीजिए, आ जाएगा.
सो शेयर किया है. हाँ अभी आ जाएगा.
यस, सिलेक्ट करके शेयर कर दीजिए.
आ गया अभी?
यस या फुल स्क्रीन कर लीजिए.
हाँ जी, ठीक है. कैन यू सी?
Absolutely, sir.
Sorry about this IT hiccup. So thank you very much once again. And I am going to give a talk at BOFAS on 11th. I've been asked to speak on the role of repeat arthroscopic bone marrow stimulation technique for talar osteochondral defect. So I'm going to share my evidence, but I've just modified it to suit it to IOACON. So first thing, so why consider microfracture for osteochondral defects, either in knee or talus? So we know it's a gold standard technique for primary osteochondral defects. And there has been a systematic review by Diamond showing that the success rate of just simple arthroscopic microfracture is 82% as compared to more complex procedure such as OATS, the success rate of OATS being about 77%. And then it's a simple technique. There is no donor side morbidity. There is no need for osteotomy. There is no need for open surgery, and there are very low risks. So that's why we consider microfracture for osteochondral defects. So I'm talking of ankle, so I'm talking about talus. So then the question is that if one has done a microfracture and that's failed, what would you do next? And that's my view, that if the microfracture has failed, then one can try microfracture again. So to answer this question, I performed a search, and I was helped by our senior librarian and a medical student. And we looked through the databases and through using these terms. And we found 500 abstracts, and of those, only 7 were suitable. And now Professor Singh was talking about the research evidence. Unfortunately, the level of evidence for all these studies, so 6 were level 4, they were all case series, and 1 was level 3. Only 1 is a systematic review, which has just been published last week. So let's have a look what the evidence says about repeat microfracture. So I'll just briefly describe the salient points. So this is the first study by Ogilvy Harris, published in 99. It was a retrospective study, 8 patients. So all these 8 patients had an open debridement for talar osteochondral defects. And then about 3 years later, the authors did an arthroscopic debridement, and the success rate was 87%. The second study is from Holland, so Nick van Dijk's group. The second study is from Switzerland. It's a retrospective study. It's a very, very small study, just a cohort of 3 patients, and they tried to do arthroscopic drilling, but unfortunately, in their experience, all the 3 cases failed. But their message was that these were all medial lesions, and medial lesions have poor prognosis, whatever you do. The third study, it's one of the biggest studies by Nick van Dijk's group, Schumann. It's a prospective study, and they had 16 patients which were done elsewhere. So these patients had either arthroscopic curettage or arthroscopic drilling. So what the authors did is, when they did the repeat procedure, they did arthroscopic curettage and drilling, and the success rate following this procedure was 75%. The next study, again, a small study from Bristol, a retrospective study, 8 patients, and they did arthroscopic excision and curettage, and all the patients, out of 8 patients, 4 had poor results and 4 had fair result. So none had a good or excellent result. And again, the same conclusion, that medial lesions and cystic lesions carry poor prognosis. This study, SAVA, is from Saxby in Australia, a retrospective study, 12 patients, and debridement and curettage, and 75% good or excellent results. And again, these guys excluded cystic lesions. Von Bergen, this is a prospective study, and again from Nick van Dijk's group, performed arthroscopic curettage and drilling, and their experience was 60%. And they said that it doesn't matter what size the lesion is, what the location is, it doesn't affect the outcome. And the last study included here is a prospective cohort study comparing OATS versus microfracture for repeat surgery. And in their case, there was the success rate was 32%. But I had a closer look at this study, and there were lots of issues. So they had included very large defects, and majority of the defects were uncontained and cystic. So no wonder their results following repeat microfracture were poor. So just talking about the lesion size here, there has been a classical paper in the past which says that for lesions for talar osteochondral defect, the maximum size should be 150 millimeters square. But this study has said that it should be even less. It should be 107 millimeters square in area. Otherwise, microfracture will not work. And this is the last paper. So this is the systematic review. So top of our treatment ladder. So they looked at they included 5 studies with 70 patients, and the pooled clinical success rate for revision surgery for talar osteochondral defect using microfracture was 61%. And decent results really. Most of the patients could return to work and go back to sports, and low complication rate. All the 10%, they were all very minor complications. The issues from this systematic review was that not all the 70 patients had microfracture. 21 had an arthroscopic debridement or removal of the fragment. And they included one study, which was effect of pulse electromagnetic field. So whether that could have influenced the outcome, I'm not too sure about that. So as you have seen, I've shared the literature search for repeat osteochondral microfracture. That overall evidence is not of very high quality, and the results are mixed. Some people say it works, some people say it doesn't work. However, personally, I feel that if you have a case of talar osteochondral defect and there are no poor prognostic features, such as the size is less than 100 millimeters square, there is no cystic lesion, there is no subchondral bone marrow edema on MRI scan, if it is not an uncontained lesion, and if it is a lateral lesion, then in this case, I would perform a repeat arthroscopic debridement and microfracture, as the morbidity is very low. And you have got nothing much to lose. At the most, it might not work. If it doesn't work, then you can do more complicated surgery. So what I'm going to do to end the talk, I'm going to share my technique, how I perform arthroscopic microfracture. Hopefully it will work. Let's see. This is the video of the surgical technique of anterior ankle arthroscopy and microfracture. Can you hear it, Arun?
Yeah, yes, sir.
That is standard using Gull's distractor, anteromedial and anterolateral portals, injection of about 20 cc of normal saline in the anteromedial portal, which is just medial to the tibialis anterior tendon as shown here by the mark, blunt dissection, and then the trocurrent cannula is passed in the anteromedial portal. Ankle joint being shown, synovitis in the anterolateral aspect, and osteochondral defect on the lateral talar dome. Now, anterolateral portal is being made, so needle is being passed, protecting the superficial peroneal nerve, and then skin cut, followed by blunt dissection again. And then this is the shaver full radius resector, which is resecting the impingement lesion or synovial fold in the anterolateral gutter. Now attention is being focused at the osteochondral defect, and this is the microfracture kit. So looking at the suitable place for making the microfractures, usually 2 or 3. So that's microfracture. The first microfracture has been done, followed by again cleanup of the area with a soft tissue resector to make sure that this is all debrided and all loose cartilage has been removed. Now that's the second microfracture, looking at again the suitable area. That's the microfracture done. So this is all done until the subchondral bone is reached, so that bleeding can happen and the fibrocartilage is formed on the surface. So again, debridement being done following the microfractures. And then finally, the length of the lesion is being measured because it's important after debridement. What's the size of the osteochondral defect? And in this case, it's just over a centimeter or 1.5 centimeter at the most. So that's the view following the debridement and microfractures. Thank you. This is the video. So that was the technique of arthroscopic microfracture. And to finish the talk, I would like to acknowledge our librarian Pip and a medical student from Cambridge, Zaki, who were very helpful for helping me to search the evidence for repeat microfractures following for talar osteochondral defect. And thank you all once again for inviting me. And that's it. Thank you.
Thanks, Dr. Bhatia, for giving us your valuable and precious time. And this is a wonderful talk. And the second talk in for technical session was also well appreciated by the audience. And I hope to see you soon in Jaipur, Rajasthan, whenever you come to India. Lockdown sabotage a lot of plan. And I also look forward to meet you in UK very soon. So I would ask my team, is Dr. Anand Mohapatra online? Team Grover? Karthik? Dr. Anand? Dr. Anand Mohapatra? Online? Recorded talk. But he's trying to enter in the Zoom meeting. If you could give him access. Dr. Anand
Good
Mohapatra.
morning. Good morning. It's actually, hi, can you hear me? Can you hear me? From all over the world, I'm sure people are locked in.
Morning, Anand.
Good morning, Manish. How are you? Oh, we're on the same side, on the western side. Yeah, can you hear me in Jaipur?
Yeah.
That's very good. Thank you. And I think if there's any introduction that needs to be, and then you can go ahead and play the recording, and I'm more than happy to be part of this, and and I can take any questions or anything else. That'd be so nice.
Right,
It's
sir.
so nice to see you all there. I'm missing your hospitality big time. And Jaipur, I have such great two brilliant conferences that I attended, and it's so lovely. What they say about Rajasthan, Padharu Mare Desh. So fantastic. I really am. I'm so sorry to miss it.
Yeah, Dr.
Mm.
Mohapatra, and we have met you everywhere. I mean, you were an esteemed faculty in Agra,
Yeah.
Indore. Your participation in every meeting of Indian Orthopaedic Association, I mean annual scientific meeting, you have been more
Thank
or less a feature. We shared a pan in Agra.
Oh, I know. Yeah, yeah. I think you got the shop opened or something like that. I remember it was late in the night, and anyway, it's excellent. I know I can understand. The mutual love for, and I feel bad that last year I could not host the Indian Orthopedics. The fellows from Indian Arthroplasty and Indian Orthopedics. But I think we look forward to it. We look forward to it this year. So sure, and you want to go ahead and maybe play the video or something.
A minute, but I will just introduce him. He's
Sure.
Dr. Anand Mohapatra. He's settled in Dublin, Ireland. He's an postgraduate of, did his training from India only, an alumni of AIMS. And then he's a big name of arthroplasty in UK, NHS, and Ireland. And he keep coming to India to deliver his various oration and talk in various specialty arthroplasty meeting, as well as meeting of Indian Orthopaedic Association. So please start his video.
Good morning, good afternoon, and good evening, India, Jaipur. From all over the world, I'm sure people are locked in to watch this beautiful IOACON, mini IOACON being held there. I'm really privileged to be invited to this great show by Professor Meena and his team, the scientific committee, and I am very thankful, but unfortunately could not make it in person because of travel restrictions. I'm very much in my spirits in with you all in Jaipur. Thank you very much for the talk today. I'm talking on slightly abstract, which is called unconscious bias, examiner's view. I work as a senior consultant and I'm recently a lecturer at College of Surgeons in Dublin Northeast. And I think as a senior examiner for MRCS, undergraduate MRCS, FRCS, CCOT, ECOT, MCH examinations, I have been involved with the process of examinations for long. As I look at it, when you look at any of examiners in this painting, the face of the examiners was priceless. In the last 200 years, a lot has changed in the last decade, especially because the use of psychometric for examinations and looking at the candidates. There has been a lot of training, there's a lot of human factors that is involved, and that has given rise to a very different exam system now in most of the colleges. When we look at unconscious bias, we are stuck with two groups. One is an in group, one is an out group. And when you look at this, you would always, human beings have their biases. Everybody sitting in that hall will have their biases, and you cannot get rid of all your biases. It's interesting that you should at least try to know what your biases are and at least be aware of it. The talk will take you through some of it. I'm sure there's a lot of work needs to be done. And in everybody wants to be part of an in group. As being part of an out group, you don't feel the best. In Europe, we are a big number of countries and we tend to stereotype each other all the time. If you look at the Irish business sense, you look at the Dutch tolerance, or you look at the Italian vivacity, the Danish creativity, and of course the British fortitude, even if after Brexit, Britain has left us, it's a geographically very important part of Europe. When I talk about you're aware, that remember there is a huge amount of unconscious unaware that is there. When you look at a candidate in front of you, he or she like the person because maybe it looks familiar, maybe it's a school tie that you could recognize, maybe some phrases of speech, somebody talks as if he's from Mumbai or from Chennai, and suddenly you want to know more about this candidate, a familiar mannerism, and you want to interact with this candidate slightly out of the exam content just to know more. But this is something that you need to always suppress as a good examiner. So know your unconscious biases because they keep working in your brain all the time. We talk about Dr. Octopus. It has all the limbs, and it is only because of the limbic system that deals with the unconscious bias and which deals with our emotions. It is something in between the cerebrum and the brainstem, and it's a very important part of the brain. How do we express our thoughts? You know, somebody might say unconscious feelings are expressed by facial expressions, by voice, gestures, word choice, and eye contact. To be very frank, you use all of them to show your feelings or your gestures to tell everything about you. The body language and what you talk about, how you talk about, the tone will tell everything to the other person. We all have our micro iniquities. That is, we would have behaviors that we transmit, which devalues, slights, discourages, excludes the other person. And then there are ways of looking at micro affirmations, which is of course smiling, nodding, good eye contact, positive, encouraging tone of voice. I hope everybody sitting in the hall is not having micro iniquities about the lecture. Hopefully they're looking and listening. Affinity bias, we ignore negative traits of people we like and focus on the faults of we don't. So it just works in your mind that if something you don't like about a person, as an examiner, would you go after that candidate? Which is, of course, we don't do it like that because we've been very well trained to curb all these things and nip these things in at blood level. There's an interesting concept which is nearly more than 100 years old. It's called the halo effect by, I think, Edward Thorndike, who first explained this. And it is actually the picture that tells you everything. You look at the picture, you look at James Bond, and you find that he is not only attractive, he's smart, witty, physically fit, he gets you out of any difficult situation so easily, and he is a winner in all aspects. So halo effect works interestingly that it tells an examiner to look at something in a examining, and he or she might like something, and then it tends to then cover some other issues that the examining is creating, and you tend to then overlook those problems. There is a lot of work done on this, and there is an on effect. where you have a devil's effect. Basically, you do not like something and you go for the person because you do not like something about him or her. And again, over the years, the psychologists have looked at it and they have looked and they find that an attractive opposite gender sitting in front of you would tend to give you maybe a different result. But then they have matched these and they've looked at it. Maybe a lady examiner looks at an attractive lady candidate and doesn't get too much affected by this. So there's a lot of research of psychometric work that's been done on this. There's the other thing is behavioral confirmation. What is behavioral confirmation? It is a self-fulfilling prophecy. When you think about a candidate, and even if the candidate looks like a winner, something about the candidate just you don't like about. It could be, maybe here we have an example, I beat anorexia, would be a winner. But something about this candidate you just don't like, and it affects your final outcome in exams. Unconscious bias affects exclusion, and creates factions. It impacts all areas of work, whether it is exams I'm talking about, but it affects the recruitment, performance management, staff development. It affects your rewards and promotion. This is an interesting slide. I borrowed from Cara Featherstone. She is amazing in the amount of psychometric work she's done in Edinburgh, JCIE. And when we train as a orth examiners, one of these slides gives you a very good in-depth idea about how all this works. It's very simple to look at this basket on the left side, and if somebody as an examiner asks you pick the red ones, you just pick them up. Somebody says pick the green ones, you pick them up. But on the right side, when you see in the basket there are apples, and somebody says pick the more redder ones or pick the more green ones, the biases starts working, because you might pick for yourself a slightly more redder one or a green one, but then if you have, let's say, it has some issues which looks maybe not as the right size, then you might try to exclude it from your picking. What are your aggravating factors? The halt is a good mnemonic to remember. So if, as an examiner, you're hungry, you're angry, you're late or tired, you must work on this, because anxious, frustrated, stressed, and threatened and tired examiners are not good. These aggravating factors have been very well shown by the US Parole Board work, where they looked at judges and they saw that hungry judges, before going on their lunch break, negated most of the parole application, while when they returned back from their lunch break, they cleared most of the parole applications. How do we tackle our unconscious bias? Ladies and gentlemen, the whole Buddhist way of mindfulness really helps you. You should challenge your conclusions. Learn to question your beliefs. It is always true. Do I have any evidence of what I am being presented or what I am listening to? Where did it come from? Is this logical? You need to question these things, and then you become a good examiner. I think be positive is a very important part, and last year has been a very negative year, but out of everything bad comes something good. And I think the most important thing is everybody every morning sends you all these positive messages to keep you going. I think it is most important to have micro affirmations and consciously try to contract the micro iniquities. There's a huge amount of environmental factors which allow plenty of time, encourage your peer review. There is no harm in having a checklist of how you managing this. The JCI has a very interesting way of looking at it, and they would tend to then hair exam, and they put a hawk and a dove together so that the balance in the exam is nicely created. The take-home message here is to be aware and recognize your biases. We all have it, and everybody sitting in that hall has it. We all have to live with our biases, and we all have to make this life go with the biases and work together. So a balance has to be struck. Challenge your thinking, use intentionally positive behavior. No harm in smiling to a candidate, as it creates a very positive atmosphere around the exam time. So the important thing is, of course, make contact with diverse colleagues. The more you make contact with diverse colleagues, you tend to understand their viewpoint very well. I'd like to thank you very much, ladies and gentlemen, for giving this opportunity again. I'd like to redirect you to Project Implicit for those who are interested to learn their own biases in life. It's an excellent system where you could go, look at a few slides, look at a few pictures, look at a few questions, and it brings so many nice things and bad things out of you that you can work on to make it better. Thank you again.
It was a brilliant presentation by Dr. Anand Mohapatra. Now we are having with us President of Indian Orthopaedic Association 2020, Professor R. Simina. His friendship with Dr. Mohapatra goes long back.
Anand, good morning. Sir, we were waiting for you to be here, but it was the unforeseen and dark period and difficult time. So many friends, after doing a promise, could not be available here physically. But thanks God that still we are on the screen and in front to each other.
Dr. Mohapatra, are you there? Dr. Anand? Sir, you have the voice?
Yeah, I have. Professor Meena, good afternoon, and your hospitality is known all over the world, I'm sure.
All over the
Everybody.
Thank you, sir. Thank you very much for your kind word and love and affection towards me as an elder brother. I still have a hope that we will meet soon at the Bombay.
Very soon, very soon. You know, I would, you know, I know as past president, it is always a presidential, you know, honor and privilege to host them in Ireland, and many of the presidents have visited me, and it is the invite is still open to you, and I'm sure you will be able to make it to Ireland in summers. It's a beautiful country. You'll enjoy it, sir.
Definitely.
Absolutely, sir.
And if you remember, sir, one thing is my one thing is do with you.
Yeah, that Iris Paddy whiskey you brought last time, we finish it off. Now
we are online. We have to be careful.
Now you want more? You can bring it to Mumbai, because I am teetotaler, but he keep telling me that was the whiskey I enjoyed. So that you have to do.
Done. Don't forget the memento from this conference for me.
Yes, we will make sure that it reaches to you, sir.
Yeah, fantastic.
So, this was a wonderful presentation and some lovely interaction. With a wonderful interaction, lovely presentation, and some of the subject talks with Dr. Mohapatra, an avid researcher and prolific surgeon. And now we will have to move to our next presentation. That is Dr. Avinav Agrawal. He's a foot and ankle surgeon in USA, has done his specialty training and 3 fellowships he has done. He's doing very well in foot and ankle specialty in USA. So We will play his recorded video. If he is able to join us online, we can interact with him. There are always technical issues. This is how Corona have changed the situation. Dr. Anand could not agree more, because he was planning, he was telling, I'll come and come. Don't worry, I'll come. But he couldn't make it. That is how fortune have changed its course in this very year. So, Team Grover, shall we? Yeah, get set, go.
Good afternoon, everybody. This is Dr. I'm the instructor in Surgeries at the University of Alabama. I would like to say a huge thanks to the organizing committee of IOACON for inviting me for this lecture. Presenting on Jones fracture, which is a personal topic regarding its management. This also described way back in 20 years back, but management and treatment techniques are very controversial, and so I will be discussing a little bit about them in my talk. The financial disclosures or conflict of interest, the objectives of fracture, we'll be discussing it, and it's very confusing. Picture will be surgery, but it turns out it. What should be the ideal toys, screws, blades, tension and plating, a little bit about the surgical technique I've done. Let's start with the anatomy of the fifth metatarsal. The fifth metatarsal has been classically divided into the tuberosity, the base, the shaft, the base of the metatarsal area, which is the area of interest here. The attachments of tuberosity, the lateral part of the plantar aponeurosis, very important because this is the one which has been shown to cause the zone 1 fracture, the Jones fracture. The base, peroneus brevis attaches to the dorsolateral aspect. Earlier it was thought that peroneus brevis causes the zone 1 fractures, but now it has been shown the lateral part of plantar aponeurosis is the main culprit in causing the zone 1 fracture. Zone 2, this is the metatarsal area, it's a watershed area. As you can see, the nutrient artery from the shaft goes retrograde to supply out of the metatarsal area. With the fracture, the supply is cut off, and so there's high risk of non-anemia in this area. Peroneus tertius, it has a dorsal aspect. Most of the zone 2 fractures are between the peroneus brevis and the peroneus tertius attachments, and the zone 3 fractures are slightly distal to the peroneus tertius attachment. A lot of sagittal motion in the fifth metatarsal. Sorry, a lot of sagittal motion in the fifth TMT, which helps to the foot to adapt to the uneven ground. It gives the lateral column its mobility. Classification, multiple classification systems. 1902, Jones first described a fracture, X-ray techniques were bad. Small case series, multiple types of fractures are included. Stewart came with this binary classification dividing the fifth metatarsal into the tuberosity and the base. 1978, Kavanaugh, large series, followed the Stewart classification, first described the Jones groove. 1984, Todd classification, mainly used as stress fracture and zone 3 fractures. 1993, Lawrence and Todd classification, the most commonly used classification, divides metatarsal into 3 zones: the tuberosity, the metatarsal area, and the proximal epiphysis, zone 1, zone 2, and zone 3. This is the Stewart classification, binary classification, tuberosity, and the metatarsal area and the proximal epiphysis. Lawrence and Todd classification is the classification which is most commonly used and most commonly grown in the literature I present. Zone 1, the tuberosity area with fractures caused by lateral neurosis. Zone 2, classical Jones fracture extending to the 4th, 5th intermetatarsal articulation. Important thing about the zone 1 fracture, the zone 1 fracture can have comminution, can be involved with cubometatarsal joint. Zone 2, again, can have some comminution along the middle area, involves the 4th, 5th intermetatarsal joint. Zone 3, proximal epiphysis, mainly stress fractures. This is the Todd classification of the stress fracture, meaning the zone 3 and the chronic zone 2 fractures. Todd 1, you can see this is considered to be the acute fracture. People can have prolonged stress symptoms. Fracture lines are pretty sharp. There's less of intermittent sclerosis, particle hypertrophy, minimal periostal reaction. Zone 2, fracture lines are resolved, more intermittent sclerosis, particle hypertrophy, no periostal reaction. Zone 3, the zone 2 changes are exaggerated. So Todd 3, the Todd 2 changes are exaggerated in Todd 3. little bit of the epidemiology, the annual incidence of Jones fractures is 1 in 2,500 adults. It shows that it's a pretty common fracture. 75% of the zone 1 fractures, and 70% in females. Younger patients, elite athletes, males have been shown to have a high incidence for presentation and diagnosis. Zone 1, as I said, more acute presentation, more acute injuries. Zone 1 mainly acute, less commonly chronic. Zone 3, almost always chronic presentation. They can also have acute chronic presentation. X-ray views, AP and oblique. Oblique is the most important view, shows movement is pretty good. You can also have a little bit of supination, the lateral view, which has been shown because overlap in the tarsal, show good view of the tarsal. Role of CT scan in the MRI is limited. CT scan mainly for diagnosing non-unions, fracture cases. MRI to diagnose prodromal stress response. Clinical assessment is very important when you see patients with fractures. What are the things that you should be looking for? Active delivery of the patient management is very different in the athlete and the non-athlete. The mechanism of injury, whether it's an acute event, whether it's a high-level trauma. Prodromal symptoms, again, very important. People who have stress reaction are supposed to be managed differently from people who do not have a stress reactions. Patients prone to fractures, most of the fractures are acute, but they can have prodromal symptoms to show that there is a chronic presentation. Predisposing anatomy, I'll talk a little bit about that next slide. I mean, some of the factors that can influence the management of Jones fractures, smoking, neuropathy, high BMI. Predisposing anatomy, what I meant was people who have long, straight, and long, narrow, and straight metatarsals, the metatarsal has been shown to be predisposed to metatarsal Jones fracture. There have no non-unions, fractures, and delayed healing. So the fourth IM angle decreases, and this angle right here that decreases shows that the metatarsal, the fifth metatarsal is a little bit of adductus. Hindfoot varus alignment, which can come from the calcaneus. Now the hindfoot can be varus because the plant reflex first ray also. Some studies have shown higher calcaneal pitch, showing a more varus alignment in patients with bone fractures, speaking elite that leads to the non-unions and refractures. This is important in the management because if we're dealing with a patient with a non-union refracture, then we might consider realignment. Management of zonal fracture is pretty easy. A non-operative management is strongly recommended in both athletic and non-athletic population. Degree of displacement, combination of involvement of process because it's consequential, 100% union breaks and patient with raw outcomes have been reported. No treatment is generally required for the case of non-unions. Weight bearing is tolerated 6 to 8 weeks. Once the patient start feeling comfortable, 6 to 8 weeks, it's transition to normal shoe. Initially, it can be placed in boot or a hard sole shoe, depending on the choice. Some studies have shown that boot cause slightly positive recovery, no statistical significance. So symptomatic non-unions can be treated with fragment seizure or fixation. If the fragment is involving more than 30% of the metatarsal joint, some people have fixation. If we have taken out a lot of peroneal spray attachment while excising the fragment, then we can view it as a peroneal spray extent. Zone 2 fractures, acute is the most common, chronic stress is uncommon. Weight bearing is tolerated versus non-weight bearing. No difference in union rates, time to union, off patient reported outcomes. Although people who undergo operative management have been shown to have fast and return to sports. These are some of the studies which show that the results of weight bearing as well as non-weight bearing have been equivalent. People have done weight bearing in the hard sole shoe, in the boot, 100%, almost 100% non-union rate, sorry, 100% union rate with no refracture. These are some of the studies which show the operative treatment of bone fracture. They were done mainly in the elite athletes. These two studies were actually trials between comparing the operative and non-operative management, the ones in bold, and they did not show any difference in the weight bearing, in the union rates or time to move between the non-operative and operative management. The high refracture rate here, this is the elite athlete group, so the different zone 3 fractures, mainly stress fractures, non-operative treatment, high rate of delayed union, non-union, classically 45 to 67% has been described, refracture rates up to 50%. Operative fixation has been shown that elite athletes who undergo operative fixation very fast return to sport, 15 weeks as compared to 26 weeks. Operative treatment, 76 to 100% rate of union, multiple techniques have been used, multiple adjuncts have been used. These operative management papers are mainly prescribed in the athletic population, but this holds true for the non-athletic population also. The refracture rate, 3 to 11%. Again, as I said, multiple techniques have been described. Intermittent screw fixation, this is the example of tension band fixation, this is the example of contact plating. Union rate 76 to 100%, union rate 60 to 100% contact plating, 60% of contact plating is more biomechanical superior. If you try the tension side, you have the potential, you have the opportunity to put some bone graft in there, then the opening effect side, the effect side, also the bone graft is on 100% necessary when you open the fracture up. Also, there is a risk of hyperprominence and cellular entrapment when you're opening the fracture. Intermittent screw fixation, most common technique of fixation. The most important thing to recognize is that the equipment tarsal has a lateral plantar curve. So there's a small straight segment that the screw can engage. If you use a longer screw, it will cause immediate fracture from lateral plantar graft. It's very important to see oblique X-ray or the foreign film with CTA because the narrowest time limit is there. If you use a longer or bigger screw than that, there's a risk of fracture. Length of the screw should be approximately 68% of the total length of the metatarsal. Average length of the straight segment has been described to be about 40 to 50 millimeters. Longest screw dedicated straight segment that's to use, longer screws. If you use screws longer than that, they have the potential to cause active fracture and cause contact gap. Diameter of the screw, most commonly used in the reference is 4.5. Again, none of the screws have been shown to have any statistically significant benefit in terms of heating capacity if you use the largest screw, but largest screw biomechanically speaking has greater bending strength and decrease the rate of refractures. Literature is inconclusive what diameter should be used, but again, they all say that longest and the largest screw, which is the straight segment, should be used. Cannula versus solid versus headless cannula, the technical ease is there, the cost benefit might be there. Solid screws, initially when you're starting to practice, might be a little bit technically challenging as compared to cannula screws because it's inconclusive whether the solid screws provide any benefit, but they have to show biomechanically have high pull-out and bending strength. Stainless steel, titanium, again, it is inconclusive nowadays. The titanium screws are used that are provided by the companies are titanium alloy, and so they are stronger than regular titanium. So I feel that they can be comfortably used. Indication specific screws. So some of the companies have described. Some of the companies have come out with specific indication specific screws. The advantage of these indication specific screws are they will probably decrease the risk of impingement, they have better instrumentation, they have decreased size of the cannulation, which improves the bending strength, and you can still use a cannulated screw. Again, it is inclusive whether they have causing statistically significant benefit. Entry point classical teaching high inside, as I said, for the lateral curve should be medial, should be dorsal, otherwise there is risk of combination or lateral contact gap. Plating should be reserved, in my opinion, for fractures, terminal fractures. Revision cases, risk of cellular entrapment is always there. Hyperprominence is always there. Indication of bone grafting, I would say talk 2 and talk 3 stress fractures. We should have a lower threshold athletes, refracture cases, non-union cases, and if we have a gap at the fracture side, fixing the fracture exists. We can get bone graft from calcaneus, celiac crest, proximal tibia. We can pick that bone matrix, bone marrow aspirate. Refractures, strongly into the bone grafting. Use a longer screw, use a wider screw. The screw has been used late. Vitamin supplementation has been shown to be beneficial. Despite all that, it's not improving in the hindfoot varus, consider hindfoot alignment. Some of the cases, classical zone 3 fracture, talk to type, chronic patient contacted a smoker, drop photo, 1 year follow, completely fracture. Case 2, particular nail, acute injury, common fracture of the base. One in zone 2, zone 3, the fourth metatarsal fracture, fourth injury. Because of the nature of the injury, had a plantar lateral plate. For the KY in the fourth metatarsal 6 months later. Complete healing. Case 3, zone 1 fracture. I would have treated non-operatively, but the fracture was in shock, so I open it up and stabilize the fracture. The zone 1 fracture after a foot plate. Complete healing. This time also for complete healing, but the patient was having hardware prominence and also having some of the pseudo neuritis. So I had to take the plate out to the pseudo transfer in this case. Case 4, classical zone 2 fracture, acute fracture. The patient was high BMI, seen neuropathy, had patient with surgery or patient non-operatively, she underwent surgery, intermittent screw fixation completed in 6 months. Summary and taking points, one for whose classification should be used. Dog classification be used only for stress fractures, which are mainly zone 3 fractures, sometimes zone 2 fractures. Zone 1 treatment, weight bearing tolerated, food, sole, hard sole shoe, whatever your choice is. Zone 2, non-athlete, weight bearing tolerated. Non-weight bearing has been shown to have no benefits, surgery has been shown to have no benefit. Zone 2 acute in an athlete. Surgery, the only benefit of surgery is that they can return to sports faster. Zone 3, stress fracture, intermittent screw versus plating. When we're using intermittent screw, use the longest and widest screw, which can engage in a straight segment to get the apex of the bow, with a high and tight straight point. Start point. Thank you so much for the time and attention. Thank you.
That was a wonderful presentation by Dr. Abhinav Agrawal. Now, without delaying the further proceedings, because session is already running late, I would may call upon Dr. Amitabh Narayan Mukherjee. He's in MBBS, MS, super special trained at MCH Ortho course Dundee. He's a replacement and trauma surgeon. He has been received Sushruth Award in 2004 IOACON. He has got DPOXC gold medal and many laurels. He's a renowned trauma and arthroplasty surgeon in West Bengal, eastern part of India, and people know him all over India and many friends abroad. So Dr. A.N. Mukherjee's talk is on shoulder replacement in Indian model. Grover team, shift.
Hello. Am I audible?
Yeah.
Yeah. At the outset, I thank Arun for giving me the opportunity the day they were starting. So we had a talk and we said, Arun, let's do it. And I tried to help Arun as possible. So far, UK and US things are concerned. And it's his endeavor that his team is really very dedicated team for this work. And they really worked very hard for this, even in these days of dark days of Corona. So to start with, this shoulder replacement and Indian model, it's a journey. It's a journey of years. 1998, I started. It started like the introduction wise, just to say that proximal humerus complex fractures, they need replacement many a times because actual reconstruction is not possible many a time. So initially I did a cadaveric study, which was initially my PhD thesis. So it was the basically cadaveric studies of 60 humeral heads, humerus, out of which they had been drawn and geometrical analysis has been done initially. And the parameters found were noted. Thereafter, the radiological evaluation was carried on of those cadaveric bones on radiological plates. Thereafter, the retroversion was being calculated for Indian bones. The reason of doing this of the South Asian and Indian bone was when I initially came back from Dundee after doing my diploma and MSc way back in 1988-99, I started doing some of the replicas of UK and UK-based shoulders, and they didn't work well. So I thought there must be something wrong. So I started to working on this. And these were the parameters which I have found that humeral head size was 33 to 51. Head shaft angle was 115 to 135. Diameter of the proximal humeral head was 8 to 12, and anatomical version of the humeral head was 20 to 25 to 40, which is average 30, which is grossly different from UK people. Bulk of the humeral head is on the medial side of the humeral shaft. So on the basis of this fact, this basic initial drawing or design of the humeral prosthesis was done. Thereafter, this basic component design was made, which gave me Shushrut Award in 2004. So this was the first generation of the prosthesis which I developed. Even my president of this session, Kiran, he has also used this prosthesis, and they are very helping throughout my journey for helping me to bringing this and supporting me on this prosthesis. So after this prosthesis was been designed, then thereafter I put it in the cadaveric model, and that has been worked with the cadaveric replica, and it has been found to be more or less the same. And that was not the word, so I did a biomechanical study, and which gave me the Dr. Bakshi's gold medal award in 2007. So the biomechanical analysis was done regarding the pull of the myosius anchorage, which is a 30-degree, and the weight of 2.7 kgs was put on the mid shaft of the arm. And this shows that joint forces in this design of prosthesis is much less than the conventional one. You can see 67 and 71, and downward force is tremendous. It's nearly 20 Newton less. So chances of dislocation becomes less with this new generation of prosthesis. Thereafter, considering the biomechanical things were taken in consideration and then were been worked out. And the 5 criteria had been set up: that the proper head size of the prosthesis, proper height adjustment, proper version of the prosthesis, and the proper positioning of the myosius anchorage, the proper construct of the osseous integration. And thereafter, I got it patented in 2005, and this is my patented one, the only one shoulder prosthesis patented for Southeast Asia. This is the only one shoulder prosthesis which is patented. So thereafter, I did my surgical technique, which is a very basic technique, as you all know: delivery of the deltopectoral approach, delivery of the head, then tying of the myosius anchorage, putting down the prosthesis in proper retroversion, then fixing up the GT. The fixing up of the GT is the final clue of the success. Then I had my basic first generation surgical technique, which has been given in YouTube in many big ones. So I don't know if they are not moving. I don't want to take much time. Is that? No.
Time is not a problem, Dr. Mukherjee. I mean, if it plays,
I'll leave it. So that was a standard technique which. Oh, I don't know where it is moving. Whatever, maybe. So then this was the further modification, and the further modification, further implementation. Can you put that? I don't know where it is moving. My dear friend, can you put that off? Okay. So no, I cannot see it and where it is playing. Whatever, maybe. So then I.
Tim Grover, what is the second?
Where is can you band kar diya bhaiya? Whatever may be. So then prosthesis in the medullary canal with 30-degree version along with the transcondylar line. I cannot see it. Part of the bone is kept. Reduction of shoulder, tying up of the osseous part and the humeral part with the valve. মনে হচ্ছে ওইখান থেকে চালিয়েছে বাইরে. Is that over? वीडियो इधर तो नहीं चल रहा है भैया. Okay. हाँ ठीक है. Okay, thank you. So I put it off. So I go fast. So thereafter, that was the standard operative technique. So this was the next renovation of the technique, where the modification of the stem was done, and then it came into the sterile plaque of OrthoTech, the 31 to 49 size. Then the surgical instrumentation was developed. So further cement gun and other instrumentation was been developed. So this is the modified technique with the modified instrumentation, you can see. And earlier I used to tie up this meiosis anchorage with wires, and now it has been replaced by ethibonds. In between there was proline also I used. So this is one of the another cases showing how the things goes on. So I'm going to just run through because time is running short. That modified surgical technique again continued. So post-operative regime is rehab, initially fixation, limited rotation, and external rotation. So thereafter, this whole thing I gave a silver jubilee commemoration lecture in WBA in 2000, I think, 2010, I believe, 2010. Then that series has 71 cases. Mainly all are 3-part fracture, 4-part fracture, and 4-part fracture dislocations. These are few cases. I don't want to go much details. You can see and come account. These are the few cases done by the same prosthesis with cemented and uncemented, both types. So you can see this side, the head is totally 180-degree rotated back. So that's one. This is the early movements. So this is another one. So there are all these cases which has been done, and I don't want to show you the videos. And you can even tie the stem like you have a fracture shaft of femur, where you do a total hip or hip prosthesis. You can do the same with the shoulder. And this is another one. And this is one of my friend's failure case, which has been revised with the same prosthesis. And these are the movements, clinical movements you can see. This is one of the case which came from the neighboring country. And this is one of the case which gave me the maximum satisfaction. Maybe beyond the, if I can see, show is this one X-ray will tell you everything. You can see that was the outcome. You just see. So trust me, nothing can be more pleasuring beyond this. The same prosthesis was used for tumor surgeries, GCT, osteosarcoma, and this is how the lady does his movement, her movement, without even meiosis anchorage, with the jerk of the deltoid. So that was another case, tumor surgery. If I say I didn't had complications, I am lying. I had my complications. I have instability. I have stem exclusion. I had, you can see, migration of rotator cuff. I had periprosthetic fracture, and I had infection. These are all there. And these were the radiological evaluation of, the prosthesis, how it look when on thoracoscapular region. And this has been found that 90-degree of movement is there in thoracoscapular glenohumeral, where the average range of motion is 120-degree. But we have an thoracoscapular rest as we have a normal shoulder, but 90-degree as at glenohumeral movement. So that was the thing, as you can see. So rest, I did a CT scan study where advanced CT was done, and it said that it looks absolutely anatomical with the other part. Then these are the results based on the pain, stability, and radiological evaluation of the stem, function of ADLS, then the functional abilities and abilities of day-to-day work. So this was the forward flexion, this is the active abduction, the rotation, and patient satisfaction, on which UCLS shoulder scoring was done, which was 29.69, and constant Morley was 53.86, knees was 81.38, which is quite satisfactory. So anatomical reconstruction of a shoulder was quite encouraging, and patient satisfaction rate was 92.3. So there the journey didn't stop. So the third generation again started. The third generation prosthesis, which is available now, had an offset, had an head, and had an stem. So this all can be assembled together, and they can be used like this. This is one case just showing, just putting the things in, and you can assemble you have different size of stems. You can assemble the stem size accordingly. This becomes the one part, assembling these two, and this becomes the third part, and this is the post-operative X-ray. This was the fracture. This was the surgery. You can see. So this is the post-operative X-rays. This is one of the surgeries just few days back. One of our ortho club has been opened with the same fracture, and this is the pre-op and post-op surgeries. The quest didn't say it doesn't never finishes the quest for the learning. So I thought I must do a stem which is basically fit for all, hemi, total, and reverse. So that's called as platform stem. So I went back, studied again. I designed, this is my initial design for the platform stem. The same stem can be used for shoulder hemi, then total, then reverse. So that was the hemi part, how it looked like. And I'm going fast. That was this. The same thing can be changed to reverse. That's how it looked like. I took the help of the Dandi lab, and there the stimulation study was done. Dr. Jariwala, and this is the stimulation study which showed, and this gave me David Rowley Award in Scotland. You can see that's the stimulation that shows this prosthesis is working as a normal shoulder. So that was the stimulation study, but in UK they don't allow you even your stimulation study is over. So thereafter I have to print it on polyethylene, and then this PLA was inserted in cadaveric. So cadaveric shawbone model was been worked out. Then this has been put on thial cadaver, which is as good as the cadaver of the human body. So that was the basic stem for shoulder hemi. Then the same stem has been changed to keeping the same stem. It has been changed to total, then to reverse. So I'm going fast. So this was the thing. So results was calculated, and this has been found absolutely encouraging for use of future generation, this platform stem. Thank you for giving me this valuable time.
Wonderful presentation, Dr. Mukherjee, as usual. So may I ask the audience if they have some question? Any question from the panel? Kiranda has worked and joined hand and worked with Dr. Mukherjee and
You are a
developing
great help in my early days. Without them, I could not excel.
Exactly. This has been the quintessential Dr. Kiranda, supporting, helping each other, backbone of every scientific program of West Bengal and East India, and is still pushing youngsters to excel. This is such a selfless man. This is Dr. K.K. Mukherjee sitting next to me, and likewise Dr. Ian Mukherjee helped us a lot to assemble this galaxies of speaker from all over the world in these scary times when technical glitches, online virtual presentation, everything. So thank you, sir.
Thank you.
And now I would request yourself to introduce the last speaker of the session, Dr. Lewis Jerkel. Thereafter, we can play his video.
This gives me immense pleasure to introduce Dr. Lewis Jerkel Jr., who is the founder and who is the president of Sign Fracture Care Society. Sign is a voluntary society. Dr. Jerkel is an orthopedic surgeon who was posted in Vietnam War. That was a war which has seen nearly like Second World War type of casualties on war field in fracture of long bones. And that was not possible to treat them by referring them. So Dr. Jerkel, he invented the sign nail to treat them on Vietnam war field. This is a nail. Single universal nail can be used in femur, tibia, and one of our fellow, Nicholas Antao from Bombay, he started doing it in humerus, and now we're doing well also. The same nail can be used retrograde, antegrade, both way. Coincidentally, there was 4 centers. I am a project manager of East India still now. Rest 2 project has been stopped. One more project is running. So we have an database, and these all nails are voluntary for poor people. They come voluntary, and he is a wonderful whole of the Africa. 80% of the Africa, poor Africa, is treated by this sign nail. This is a wonderful database. My database is nearly 1,000 of this nail. I have doing this from 2002. So I have given my database entry to show. Can we see just first? No, pehla se. This is a database. Every one of the sign surgeon of the world, they have a database. And every database has been scrutinized by the sign director, board of director, how the surgery is done. So every surgery is been scrutinized, and an opinion comes to you at the end of the week that you did this right, you did this wrong. So these are the sign database. Every of us has a database, and this is mandatory that we put the database, any one of us. After putting only the database, we get a replacement nail. If I don't get then I don't get a nail. So that is the thing. So with this, Jerkel is a wonderful man. I have been to US with him and stayed with him years together. I have worked with him in some casualties and earthquakes everywhere, even in Pakistan when it was there, Ahmedabad when it was there, he came with his team. We all were there. So thank you. Now I think this is the time Jerkel's recorded video will be played. Is that?
Yes. Yeah.
Thank you.
Team Grover. Lewis G. Jerkel.
Louis Jerkel.
Lewis Jerkel.
Yeah.
Volume goes up.
By the way, he's nearly 85.
And donation of appropriate implants to treat the poor. The sign nail was designed 21 years ago. It has not changed since we first designed it. The shaft is straight. There's a 9-degree proximal bend, which makes it a trochanteric nail, and there's a 1.5-degree distal bend for easier placement down the canal. So we can pass it by rotation and tapping. The canals of the femur are different around the world. These are different sizes, but the basic arc of radius is about the same, with about a 10-degree difference. So we had to design a nail which could be used in all these canals and fit them very well to provide excellent stability. We were lucky because the nail follows the helix in the proximal femur, and we can, through our technique, very rarely have problems inserting the sign nail. This was the first operation done with sign nail. This was done in Vietnam. The surgeons there did it closed, and I was very pleased with their reduction. I actually was there. And then this young girl came in. She had a floating knee, which means a fractured tibia and femur. So we did the tibia first, and we had thought about how we would treat the femur. Back then, we didn't know about retrograde approach to the femur. And there was one paper about retrograde approach. This is a retrograde approach. The bend of the nail is posteriorly, and now we make the bend of the nail anteriorly. And this is the picture of the girl sent to me standing on her broken leg at 6 weeks. And this really pushed us forward, knowing that we could treat tibia and femur. Nicholas Santao from Mumbai did the first humerus nail using sign. This man had had multiple operations. They had failed, And Nicholas did this excellent surgery. If you look critically at the depth of the nail and the amount of flexion he has, it shows that we have a lot to learn. The sign journey has been an agony and an ecstasy. We went from Vietnam to Bangladesh. We had hand drills with us, and the bone in the Bangladesh was very hard. These kept skiving off the bone, and then we caught the reamer in the canal and had a very difficult time removing it. It was the last case. We were trying to get one more case in, and I had a plane to catch. We removed it, and I went home very concerned. This was the agony, and thought later, how can we make this a good thing? So we'll put the flutes of the reamer at the end of the nail, and this will provide quicker surgery. No distal interlock is necessary. And we have found through studies on the database that this is very stable. We have also designed reamers. Our current reamer gets a lot of bone graft when it's passed. You can see the current one and the original one. We have an advantage because we have to do open reduction a lot of the time, and therefore we can take the bone created by the reamer and put it in the canal, and our fractures heal very quickly. We wanted to treat fractured hips because this was a big problem and still is. We wanted to treat all different kinds of fractured hips, stable, unstable, and therefore we made a modular system, and the anatomy of the fracture dictates which implants are used. And this is an example of one. We have plates where we've currently changed our plate anatomy, and we have compression screws, which are the long screws, and the interlocking screw, which articulates with the plate. And these provide us excellent results, and they actually show the excellent surgical ability of the sign surgeons throughout the world. Everything hinges with sign on the database. All sign surgeries are reported to the database, including follow-up. And therefore, we can learn how our present implants work, and we can also think about new implants and better ways to immobilize. So sign is continually improvising, making new implants and new instruments to improve our results. We value the skill of our sign surgeons throughout the world who get excellent results, and these are demonstrated on our surgical database. We ask for pre-op, post-op, and follow-up x-rays, and you can see the squat and smile picture, which we'll talk about. We must remember that orthopedic truth is like a big pile of sand, and you can see all the orthopedic surgeons around shoveling sand, and we all know a little bit. We don't all know how to put it all together, and therefore it makes us very humble. Our database has 340,000 surgeries reported and many more individual x-rays. Thank you. I'd like to introduce Adu Subramanian. He's worked with us. He's one of the smartest people I know because he can put together all of these entries from the database and get conclusions which are very important for us. And so I introduce Adu to you, and he'll just tell you about two of his many projects. Adu?
Sure. Thanks, Dr. Zirkle. Let me share my screen here. And I will be talking about two different projects, both of which are unique to sign. One of which is evaluating healing, and the other which is a new way or novel way to treat patients. So the two topics are going to be what's a squat and smile, which is a useful test. Sign is developed to evaluate clinical healing in patients as an adjunct to X-ray healing. And we'll also take a look at intramedullary nailing in pediatric patients and see if the retrograde approach is viable for IM nailing. So first off, Dr. Zirkle alluded to this slightly in his presentation. What is a squat and smile? It is a functional test of healing developed as a way to assess healing outside of the X-ray. You can see here, you get two views, front view and the side view. You can see on the front view how even the patient is. And on the side view, you can see knee and hip flexion. See how far they are squatting, see how much weight they are bearing on their injured legs. Now, I attempted to look at the database to answer some questions about the squat and smile test that's been implemented for the last 20 years. How useful is it in predicting healing? How can we use it to increase follow-up in low-income settings? And what's the best position for a squat and smile? So this is the data that we collected based on the following criteria. Patients have to have a 720-day follow-up to ensure no intervening, no occluding factors from lack of follow-up, and they have to have a squat and smile image taken. A near or below parallel squat was considered a positive squat and smile because sometimes the smile is a little bit hard to judge, and depending on cultural differences, some patients may not want to smile. So the depth of the squat and evenness of the squat was taken as the most indicative factor of a positive squat and smile. Some of the results are as following. All of the patients who could squat and smile along their patient journey didn't lose that ability. Though some did not unite on the X-ray, even at 2 years, they still could squat and smile, and they still were functionally healed. But that being said, 90% of those who could squat and smile went on to unite on the X-ray within the 2-year healing, within the specified 2-year healing period. This is an extremely high percentage for a test that is not radiographically correlated at all. It's completely functional. But the other thing you can see is that the average days to getting a squat and smile is much lower than the average time to X-ray healing. And this shows a clear difference between functional and radiographical healing. It suggests that functional healing precedes X-ray healing. Now, one question that might naturally arise is this: what happened to those patients who could squat and smile and didn't eventually heal? And you can see from some of these results is that they had varying outcomes. Some of them were reoperated on, some of them had a nail breakage, some of them had a secondary accident, some of them got infection. There were a lot of outcomes, but no clear trend across ages, across approach types, across nail types. There was no clear trend, but we did notice one surgical trend among patients that didn't go on to heal. And it was this: you had to have an adequate amount of fracture fixation at the fracture site, an adequate amount of compression. And this is especially noted in mid-shaft femur fractures, transverse mid-shaft femur fractures to be specific. Oftentimes transverse femur fractures and tibia fractures, in that case, without enough compression, the patients could squat and smile, but they achieved this sort of dynamic union with the nail in a way that they had functionally healed and could squat and smile, but the healing on the X-ray, there was no cortical touching. This is one thing that we noticed across, like I said, both tibia and femur fractures, and the result is pretty different. There is a 20% different rate in healing based on whether or not there was enough compression at the fracture site. So here I'll go through a couple of case studies of patients that took a long time to heal, one of which that were reoperated on. So you can see on the left here, 5 months post-op, the patient could squat and smile. You can squat pretty accurately. It's an even squat, pretty positive squat, and he had not healed on the X-ray yet. For this patient, dynamization was done 8 months post-op. And in fact, 3 years later, the patient is fully healed and is living a great life. This is an interesting result because you can see that this reoperation was done at an early stage. As we noted earlier, As noted earlier, X-ray healing can take up to 2 years. So sometimes it took 720 days without operation to heal, but this diamondization was done earlier and it still got a positive result. So you can see even here, it did take 2 years post-diamondization, and this can be due to many number of factors. Another case study where a patient could squat and smile, but there was no healing, was this one. It's a 12-year-old male who was treated with a spica cast before coming to a Sion hospital. It was a mid-shaft fracture. And you can see here on the 8-month follow-up, a perfect squat and smile, but no complete X-ray healing. Then bone graft and a plate was added 2 years post-op because the patient still had not healed, just for some extra stabilization and to stimulate bone healing at the fracture site. Go here, 3 years after the original fracture and 1 year post-reoperation, the patient doesn't look like he's on track to heal. But the interesting thing to note is throughout this entire process, he didn't lose the ability to painless weight bear, and he didn't lose the ability to squat and smile. This is an interesting result because even through reoperation and maybe a lack of X-ray healing, he still had functional healing, which I think demonstrates the need to segregate the two. Healing isn't a singular thing that you can say yes or no to. Oftentimes, it's a scale. And the squat and smile is part of that scale that we're trying to develop more and see how far a patient is on that healing scale. Are they functionally healed? Are they X-ray healed? In fact, this patient did eventually go on to heal about 2 months prior. So these are some of the conclusions just to summarize. 90% of those who were squat and smile did go on to heal. And we're trying to use this result to develop an app for patients to send in squat and smiles to surgeons to assess healing remotely, which is especially important in low-income settings where follow-up is low and patients may not have the resources nor the time, nor just adequate access to a surgeon who could be 200 miles away. So for further work, one thing is what position is acceptable for the squat and smile. We couldn't really find that out completely from the database because there are a heterogeneous amount of pictures. There are different positions squatting patients are sent in with. The other thing is how can we factor in cultural differences? For example, some countries and some cultures may squat more often, and that may factor into the fact that those patients are more flexible and those patients can squat and smile more effectively. So now moving on, I'll talk briefly about pediatric fractures. So rigid intramedullary nailing in pediatric patients less than 10 years old is not something that is common. Oftentimes it's thought to cause avascular necrosis, but one of our surgeons, Hassi Shahab, did a review of 13 patients and found no cases of avascular necrosis, and in fact did IM nailing in pediatric patients as young as 6 years old in the antegrade approach. The pediatric fin nail developed by Sion is specially designed for pediatric femurs, and the fact that it has a space to bypass the growth plate so that it doesn't interfere with growth in younger patients. It achieves stabilization with 3-point fixation and the fin at the top of the nail. Using the retrograde femur approach, which is specifically what I'll be looking at, has shown promising results in younger patients, which is really interesting. And this is without any limb length deformity, but I'll get into that. So just as a brief overview, one thing that we've noticed is just looking at the overall number of cases for overall number of pediatric cases. 2 things that were interesting results is that 1, pediatric nails are phased out in Sion surgeries around the age of 15, which we would use as a criteria to judge which patients to use in the study for the retrograde femur approach. In addition, Dr. Zirkle mentioned differences in nail size across countries, and this may lead to different nails being used. And in fact, you can see this. Kenya and Mongolia have significantly different nail sizes used across all their fractures, and you can use this as a proxy for the canal size of the patients. This is another interesting result because it shows that maybe not pediatric nails may not be appropriate for everybody, and the use may vary across the age groups over the years because of a larger canal size in places such as Mongolia and Kenya. So the origins of the retrograde femur approach is actually done in sheep studies. And there were a couple of them, and they both came out with similar results, was that it was a viable approach as long as the growth plate violation was kept to a minimum. 8% was the number established, but keeping in mind these are sheep, that's probably not a hard and fast number. And in real patients, the results may differ. If you also look at a nail migration study, for a retrograde femur approach in younger sheep, there was a growth discrepancy observed, but this only suggests that maybe we should remove the nail in a timely fashion and not let it stay in the femur. Now, can we look at the database and see some insights to the outcomes in human patients? And this is what we did. We wanted a follow-up greater than 180 days, less than 15 years old. Healing radiologically was 3 out of 4 connected cortices, and clinical healing was judged by the squat smile. So these are the results. And you can see here that the results are extremely comparable between the retrograde approach and the antegrade approach. Both have a healing rate, a 2-year healing rate of near 90%. In addition, there were no cases of limb length deformity, and there was no significant difference in the time to healing. You can also see on the right graph, the right side graph, that there is no difference between nail types, whether it's the pediatric nail, the thin nail, or the standard nail, on the number of patients that were healed. So some of the conclusions that we have for this is that the retrograde femur approach is viable in pediatric patients and humans. And it had an overall healing rate of greater than 85%, which was comparable to other approaches in pediatric patients. One key note is that you have to pass the growth plate, the epiphyseal growth plate at the end of the femur. And you can see on this case on the right, when a screw was placed through the growth plate, almost immediately post-surgery, the screw was then removed so it didn't hinder the growth, and this patient had a positive healing outcome. As more cases are done, more robust studies can be done, we can get more data, and we can truly work out the intricacies of the retrograde femur approach in pediatric patients. All right, thank you. This is just some contact info, and this is the bibliography. Thank you so much, and have a great day.
So Team Grover, you might focus on the stage, and this was wonderful history and functioning of sign nail. Now, if any learned audience or delegate want to have some questions in his mind, Dr. Ian Mukherjee would be more than happy to take it, as they have gotten a strong surgical audit. They do a sign nail, and then it is discussed all over the world with the audit team. I think message is loud and clear, crystal clear. So probably nobody has got any other question. So Dr. Ian Mukherjee can give a summary statement the way he wanted.
This was a wonderful session. Thank you, both of you, my both chairmen. To conclude, the whole session was very informative. And at the end of the day, I don't want to say about my prosthesis because I'll be biased, but sign is a wonderful nail in proper hand, proper things. And this is in Bangladesh, Nepal, Bhutan, Africa, where people cannot purchase nail. The snail is giving a wonderful humanity, and whole trust runs on charity. Whole trust runs on charity. So that's all. Thank you. Thank you for giving me this opportunity. Thank you very much.
Thank you, Dr. Mukherjee, for assembling this ensemble cast of speakers, which can beat, in Hollywood analogy, can beat cast of Godfather, hands down. I keep getting these analogies from cricket, and which probably everybody love. And then, since so much good work is being done in West Bengal and so many eminent orthopedic surgeons, so I might ask Dr. Ian Mukherjee and the long-time office bearer of West Bengal Orthopedic Association, Dr. K.K. Kiranda, to take some of our fellows from SMS and to send us your fellow. We are doing a lot, estabulum and arthroplasty, scopy, everything that we can discuss and plan. Dr. Kiran might give his take and his overall take about the conference.
That's well taken, and we'll work in future.
We can work it out. We can work it out. So thank you, gentlemen.
Thank you. It was a long journey. I came here long back when Dr. Sethi was there and Dr. Kardzu was there. He was the pioneer in orthopedic in he was from JNK. I came to Dr. Kardzu in 96. He was a wonderful soft tissue surgeon. I'll never forget his surgery. So I have seen him doing surgery here. Then he was transferred to Bikaner. I believe
Yes,
he
sir,
was Bikaner. So it is a long association with SMS. Thank you.
Thank you, sir. So this is the story from the center. We conclude this evening session, but we got to have an Pune operative trauma course 6 to 8, which you can watch live. We have given link to all the delegates, and we will all meet tonight in gala dinner. Thank you. Thank you very much. Team Grover, समेट लो भैया, मतलब समेट अभी के लिए समेट लो, सब एक ही दुकान अभी.